Once again, I, Dr. Ranam Siddiqui,
and I, Dr. Riddhi Intwala,
your master of ceremony for the conference, are here in front of you all on behalf of our team, Cynodent International and Indian Society of Dentistry, to welcome you all to our 3rd World Dental and Facial Aesthetics Conference from 3rd to 5th November, organized by Cynodent International and Indian Society of Dentistry in collaboration with Himachal Dental College, situated in the heart of Himachal Pradesh, Sundarnagar. Before moving forward, students have prepared a welcome dance, and I would request the participants to please come forward and the IT team to coordinate with them.
Before starting with anything else and following our very authentic Indian culture, no event and hence our conference cannot be inaugurated without Ma Saraswati's blessing and Saraswati Vandana.
And for that, I kindly request all the respective dignitaries, that is our Honorable Chief Guest Professor Dr. Surendra Kashyap Sir, our Honorable Guest of Honor Shri Sohan Lal Thakur Sir, Dr. Vikas Jindal Sir, Dr. Anmol Bagaria Ma'am, Dr. Anil Singla Sir, Dr. Baljeet Singh Sir, Dr. Ashish Chandra Sir, Dr. Devendra Sharma Sir, to come forward for the lighting of the lamp and the Saraswati Vandana. I would request our team to please
Vishesha
guest of honor, Shri Sohan Lal Thakur sir, to kindly grace the dais. We also request all our respected dignitaries to grace the dais. Dr. Baljeet Singh sir, Principal, Himachal Dental College, Sundarnagar and Convener-in-Chief. Dr. Anmol Bagaria ma'am, Founder and CEO of Cynodent International and President of Indian Society of Dentistry. Dr. Ashish Chandra sir, Co-Director of Cynodent International and Vice President of Indian Society of Dentistry. And Dr. Divendra Sharma sir, Vice Principal of Himachal Dental College, Sundarnagar. Please give a round of applause.
And are immensely graced by your presence amongst us today for inauguration of our conference by Cynodent International and Indian Society of Dentistry in collaboration with Himachal Dental College, Sundarnagar. Theme of conference is International Advances in Dentofacial Aesthetics.
After this introduction, let me brief you all with Cynodent International and Indian Society of Dentistry. Cynodent International and Indian Society of Dentistry was founded by Dr. Anmol Bagaria ma'am and is headquartered in Mumbai, Maharashtra. Our national, state, college teams are spanned all across the country and are led by a very diligent board of directors. We also have a team of eminent international and national speakers. Our patrons and advisors include the very renowned Dr. Cohen, legendary endodontist from USA. Dr. James Gutmann, legendary endodontist USA, Dr. Pavitra Rastogi sir, President UP Dental Council, and Dr. D.N. Kapoor sir, legendary orthodontist. Cynodent soon expanded to 20 countries across the globe. And today, with the blessings of Almighty, ladies and gentlemen, Cynodent International stands rock solid with members from 70 leading countries of the world. Our purpose here to address global health, increase awareness about patient safety, create opportunities for dental and medical professionals, and very importantly, to reduce the gap between research and clinics. We share this with immense pride that we at Cynodent are a global organization serving medical and healthcare professionals around the world. We believe in putting our best foot forward for the welfare of humanity by sharing knowledge and granting assistance in the finest way possible. We publish high-impact journals, newsletters, magazines and papers every year. Our very committed team of scientists, medical professionals and clinicians across all specialties work day in and day out to transform bold ideas into sustainable realities which most definitely will make this world a better place to live in. Cynodent has also launched a unique digital healthcare platform which is the first of its type in India. We are also working for social welfare and humanity to enhance the quality of life by providing healthcare services, raising awareness and providing free treatment to many. We have done 100 plus camps with completely free of cost treatment. We have trained 500 ASHA workers and have also organized blood donation camps. Also, we have launched Oral Health Program 2022 with a vision to spread awareness. Also collaborated internationally with WHO, UNICEF and UNDP. We have done 150 plus free webinars for young doctors to update their knowledge and skills. We have launched the textbooks of Grossman and periodontology on our platform. We have patents, copyrights, books and scientific papers and whatnot to our credit. We have organized 13 plus international conferences at eminent universities and 3 conferences on facial aesthetics to share knowledge regarding the recent advancements and state-of-the-art technology, so that the lag between the research and clinical application reduces and better care can be provided to our patients and also to enhance research in the field of dentistry by scientific presentations. Indian Society of Dentistry is recognized, well-known society that believes in providing the best dental education which is at par with international students. Maintaining high standards of teaching and promoting research activities with a strong foothold in the Indian dental industry.
But ladies and gentlemen, अभी तो असली मंजिल पानी बाकी है, अभी तो हौसलों का इंतहा बाकी है, अभी तो तोली है मुट्ठी भर जमीन हमने, अभी तो तोली है हमने मुट्ठी भर जमीन, तोलना अभी सारा जहां बाकी है.
In other words, we promise to serve you with the best of our abilities for the times to come. It's an internal bond that we share, a bond so beautifully nurtured that there shall be no stronger bond than this. And now, I would like to call upon Vediki for the introduction of Himachal Dental College, Sundarnagar. Please give a round of applause for her.
A very warm good evening to one and all present here, respected members of the dais, eminent and renowned owners, speakers, teachers and my fellow budding dentists. I, Dr. Vediki Seni, welcome you all to today's evening. I feel honored to be able to stand and speak a few lines about my alma mater, the place that made me, or better to say, transformed me. Himachal Dental College, being the first dental college in the state of Himachal Pradesh, started in 1994. Affiliated to HP University and Atal Medical and Research University, HDC is proud to be a premier institute offering both BDS and MDS programs in dental sciences. Situated in the foothills of Himalayas in Sundarnagar, away from the distractions of city life, offering an excellent environment for academic deliberation. In 1994, a dream was kindled in Himachal Pradesh by philanthropist Dr. V.K. Gupta sir, the founder of Himachal Dental College. This dream, now carried on by Dr. Vikas Jindal sir and Dr. Anil Singla sir, the very able directors of our college, has paved the way for aspiring dental professionals. Along with this, Principal Dr. Baljeet Singh sir and Vice Principal Dr. Devendra Sharma sir, along with dedicated staff and students, continue the legacy, providing that education is a beacon for future generations. Now this is just the basis that I just said. And from this all, I am recalled by Iqbal, a very famous poet, जो कह गए हैं, नहीं तेरे नशे मन कसरे सुल्तानी के गुंबद पर, नहीं तेरे नशे मन कसरे सुल्तानी के गुंबद पर, तू शाहीन है बसेरा कर पहाड़ों की चट्टानों पर, तू शाहीन है परवाज है काम तेरा, तेरे सामने इम्तिहान और भी है, तेरे सामने आसमान और भी है. This is just the beginning for a very glorious future of HDC, and I wish everybody here a very prosperous future and a very great evening. Thank you very much.
Thank you so much, Dr. Vediki. It's a pleasure and a matter of great pride for Cynodent International and Indian Society of Dentistry to have 30 plus eminent speakers associated with us nationally and internationally. We welcome all our international and national speakers and delegates to Himachal Pradesh with a touch of heritage, spirituality and a modern panorama. This conference is providing a great opportunity to students, clinicians and academicians to learn and to explore Himachal Pradesh as well.
Summing up the introduction, without further ado, let's move forward and continue with our inauguration ceremony. It's time to welcome our respected dignitaries to the podium for welcoming and addressing our dear delegates present here with us today.
And invite Dr. Ashish Chandra sir on the podium to address this gathering.
A very good evening to one and all present with us today. I, Dr. Ashish Chandra, extend my warm welcome to you at 3rd World Dental and Facial Aesthetic Conference organized by Cynodent International and Indian Society of Dentistry in collaboration with Himachal Dental College, Sundarnagar, which is located in the heart of Himachal Pradesh. I heartily welcome the dignitaries on the dais, respected chief guest, Professor Dr. Surendra Kashyap sir, Vice Chancellor, Atal Medical and Research University. We welcome you, sir. Guest of honor, Shri Shohan Lal Thakur, former member of Legislative Assembly, Sundarnagar. Our founder and CEO of Cynodent International and President, Indian Society of Dentistry, Dr. Anmol Bagaria, ma'am. The organizing chairperson of the conference, welcome, ma'am. I also like to welcome our respected principal, sir, and vice principal, sir, and of the dais, the chairman, sir, and director, ma'am. I also welcome the respected dignitaries of the dais and all the delegates. Cynodent has served you selflessly for 7 glorious years now, and today we are again at your service as we embark upon the beautiful 3 days of learning and sharing. We started with a day of extensive pre-conference courses which included the course on facial aesthetics, lasers and dental implants. And today we officially inaugurate our conference where we had from morning the scientific sessions and lectures by eminent speakers from all across the country. And not just that, to acknowledge and honor the stalwarts of dentistry, we have dentist awards recognizing and dentists across the globe. So buckle up yourself because there's a lot we have to teach and a lot you have to learn and upgrade your skills and knowledge. And I again, on behalf of Team Cynodent International, I commit to continue to serve you in the coming years as well. I wish you all a good time with us. Thank you. Thanks a lot.
Thank you so much, sir, for your kind words and your constant support. Now I would request Dr. Vikas Jindal, sir, Patron and Director, Himachal Dental College, Sundarnagar, to address the audience.
Respected Chief Guest, Professor Dr. Surendra Kashyap, Vice Chancellor of the University, Shri Shohan Thakur, former Chief Parliamentary Secretary, Government of Himachal Pradesh, dignitaries on the dais, Principal Sir, Vice Principal Sir from Cynodent, dignitaries of the dais, faculty members, speakers, and my dear students. At the outset, I would like to welcome our chief guest and our guest of honor for this conference. And I am grateful to the Cynodent for organizing this conference in this college. Conferences and continuing dental education programs do matter a lot in disseminating knowledge and education to the students at large. Himachal Dental College has never shied away from its responsibilities to teach the students and increase their knowledge and imparting knowledge to students at large. Once again, I thank you all for organizing this conference. Welcome all the delegates, the chief guest, guest of honor, and my dear students. Thank you very much.
Now it's time to call our Honorable Chief Guest, Professor Dr. Surendra Kashyap sir, Vice Chancellor, Atal Medical and Research University, Himachal Pradesh, on the podium to address the gathering and inspire all of us with his words of wisdom. Please welcome sir with a huge round of applause.
Good evening, everybody. Thank you, Dr. Singha, for very warm and kind introduction. I place on cards my regards to Mrs. Santosh Gupta, Chief Patron and Chairperson of HDC, who will make it to this conference. Shri Shohan Lal Thakur, guest of honor for the day, and former member of Legislative Assembly from Sundarnagar, a very humble and cheerful personality. Dr. Anil Singla, Patron and Director of HDC, Dr. Vikas Jindal, Patron and Director of Cynodent College, my friend Dr. Baljeet Singh, Convener and Convener-in-Chief and Principal of the Institute, Dr. Devendra Sharma, Convener, Organizing Committee and Vice Principal of the Institute, Mrs. Anmol Bagaria, Trustee and Patron of the Institute, Dr. Anmol, Madam, Founder and COE of Cynodent and President of Indian Society of Dentistry, Dr. Ashish Chandra, Co-Director, Cynodent and Vice President, Indian Society of Dentistry, members of the faculty from this institute, and the invited speakers, dear students, undergraduates, postgraduates, participating delegates, both present here, and I was told it's a conference in hybrid mode, so those who have joined through wire, members of the electronic and print media, ladies and gentlemen. My greetings from Adult Medical and Research University, Madhya Pradesh, which we have nicknamed as AMRU. Several of you may not be knowing, but let me tell you, AMRU is a newly established university in the state of Madhya Pradesh, exclusively for the area of health sciences. Though the university was established and the act was enacted in 2018, but due to some delays it could not be initiated, but somehow it has started working since 2019, and I am happy to share with you today that as of now, all the government, private medical colleges, nursing, dental, paramedical, homeopathic and Ayurvedic colleges of the state are affiliated with this university. And I'm happy to tell you that this prestigious college where we have gathered today, Himachal Dental College, is also affiliated with us. Thank you, Dr. Singla, for appreciating our effort as far as our counseling and admission process is concerned. I must share with the members of the faculty and students here that it is our endeavor and effort to the best of our ability to make this university as one of the least paper-using universities. So we want to make it as paperless as possible. And for that, we need the cooperation and support from all the affiliating institutions, which we are getting. And I assure you from my own side that in time to come, this is going to make a place not only in the country but also at the international level. Now, before I start or deliver my very short address, Dr. Baljeet, I take this opportunity to thank you for inviting me here, and also the members of the organizing committee for this conference, particularly the executive members of the Cynodent, to come over here and inaugurate this national level conference. I am indeed honored to be here today amongst you all, and I can just feel the energy, which is not only palpable but infectious. It gives me great hope and satisfaction to see the shining faces and the immense potential of participants who have gathered here today. Friends, I understand that this is the third World Dental Facial Aesthetics Conference being held in this beautiful town of Cynodent, Madhya Pradesh. I am deeply honored to stand before you today at this prestigious national conference wherein the dental surgeons from across the country have gathered to exchange knowledge and expertise. Allow me to say that this event will serve as a platform for collaboration and growth in the field of dentistry, and I applaud the commitment of all attendees to work for advancing the health and well-being of our fellow citizens. Himachal Dental College, as we call it HDC, and Cynodent have shown tremendous dedication in organizing this event and their commitment for the advancement of dental education and practice, which is commendable. They deserve our gratitude for their tireless efforts in making this conference a reality. I must tell you here, organizing conference, particularly in a smaller place like Cynodent, is a very Herculean task, and I must appreciate the team, Dr. Baljit and Dr. Singla, and of course all of you who are involved in making this a success. They deserve a great thought. Ladies and gentlemen, we will appreciate that this conference is an opportunity to engage in meaningful dialogue, share groundbreaking research, and foster connections between the talented faculty, participating delegates, and students to drive their vision forward, helping ultimately in improving the knowledge and skills. This conference will also provide a great opportunity to students, clinicians, and academicians to learn the latest advancements and developments in the field of dental and facial aesthetics. Although I am not an expert in the subject, but I like to add that dental facial aesthetics is a holistic approach involving the art and science and rejuvenation of cosmetic and aesthetic dentistry. It does not just involve dental treatment, it is a collection of treatments and procedures undertaken to enhance the appearance and functional aspects of face, creating a harmonious, balanced look. You will agree with me that in this era of specialization, I feel that the basic degree in dentistry may not be sufficient to care for the care and the needs of the society. Therefore, specialization in dentistry is more or less a mandatory requirement, and it's in this vision, with this vision, that such conferences are very, very important to improve the skill and knowledge of the participating delegates. I understand that during this 3 days long conference, which has started yesterday, will provide research, scientific and educational programs for dental surgeons to enhance their knowledge, skill, and keep them updated regarding their recent advancements and latest treatment developments. This conference will also provide a great opportunity to students, clinicians, and academicians to learn and explore the lectures and workshops covering multiple approaches of dentistry, particularly dental-facial aesthetics, by renowned speakers from India and abroad. I am sure that at the end of the conference, the participants will be charged with new ideas, skills, and thoughts. Besides, I am of the firm view that such conferences also serve as an excellent opportunity to interact with the experts in the field in one-to-one basis, and also to enhance the social and cultural fellowships. May I congratulate and compliment the organizing committee once again for organizing this conference. here in this place on such a scale. Thank you for your kind attention. Jai Hind, Jai Bharat. Thank you.
For your inspirational words. Now it's time to call our honorable guest of honor, sir, Shri Sohan Lal Thakur, sir, former member of Legislative Assembly, Sundarnagar, for addressing the audience. I would request you, sir, to please at least say 2 lines to address the audience. Please welcome, sir, with a huge round of applause.
Respected Professor Dr. Ashokji, Vice Chancellor, Medical University, Principal of College, Dr. Baljeet Singh Ji, Director Anil Singla Ji, Vikas Jindal Ji, और organizing secretaries for this conference, and all faculty member of Medical College, Sundarnagar, or upcoming doctors studying in this college. I think in presence of doctors and becoming doctors, I'm the odd man, but I'm very happy, and I must congratulate Dr. Singla for having this conference here. It has not only given a good name for Dental College, Sundarnagar, but also opportunity for the students of this college by deliberations हुई होंगी about the advancement in dental studies as well as अभी तक if I share my this thing, एक common आदमी dental उसमें पहले tooth extraction, फिर उसके बाद feeling, उसके बाद जो RCT, but I can see that facial aesthetic जो आपका subject रहा है इस conference का, definitely this field is now expanding and more research is being done in this field. और एक इस तरह की कॉन्फ्रेंस आपने यहाँ सुंदरनगर में कराई, मैं इसके लिए आपको बहुत बहुत बधाई देता हूँ। और सुंदरनगर का मुझे खुशी है इस बात की कि हमारे यहाँ आपका कॉलेज एक प्रीमियर कॉलेज, फर्स्ट कॉलेज ऑफ डेंटल कॉलेज हिमाचल में, इससे पहले सुंदरनगर में एक और अच्छा रहा कि फर्स्ट और टेक्निकल कॉलेज भी सुंदरनगर में था। एंड आई थैंक माय लीडर्स राजा वीरभद्र सिंह जी, जिनकी ब्लेसिंग से फर्स्ट इंजीनियरिंग कॉलेज ऑफ द स्टेट वाज opened in Sundarnagar, and I feel very happy and proud that this college, after NIT Jaipur, it has got accreditation हुआ है इस कॉलेज का। तो Sundarnagar is known for educational hub in Sundarnagar in Himachal, and हमारे efforts हैं। और डॉक्टर सिंगला ने यहाँ लिखा है कि गेस्ट ऑफ ऑनर, आई फील कि अगर आपने होस्ट बोला होता तो ज़्यादा अच्छा लगता। तो मैं सभी और जो यहाँ बहुत अच्छा आपका ये कॉन्फ्रेंस रही, इसके लिए आपको बधाई देता हूँ और सभी स्टूडेंट्स को मैं अपनी तरफ से बहुत बहुत गुड विशेष देता हूँ। धन्यवाद।
For that, firstly we would like to call upon Dr. Anmol Bagaria ma'am, Dr. Baljeet Singh sir, Dr. Ashish Chandra sir, Dr. Devendra Sharma sir to please present a memento, to please come forward and present a memento to our honorable chief guest, Dr. Surendra Kashyap sir. Please give a round of applause for sir. I'd like to invite Dr. Anil Singla sir on stage. Thank you sir for being a part of our conference. We are extremely obliged.
Yes, please. Thank you.
Next, we will
Wait. File होने का नहीं ले. Okay. Sir, please. Excuse me.
Dr. Anil Singla sir, Director, HDC Sundarnagar, to please join the dignitaries on the stage. In the presence of all the respected dignitaries, we are going to present a memento to Himachal Dental College Sundarnagar. A memento of appreciation to Himachal Dental College. We would like to present a memento to Dr. Anmol Bagaria ma'am, found a person of Cynodent International and Indian Society of Dentistry, in the presence of all the respected dignitaries. And for all your blessings throughout. Then we would like to present a memento to Dr. Ashish Chandra sir, Co-Director of Cynodent International, Vice President of Indian Society of Dentistry, and the Organizing Secretary of the conference. Thank you, sir, for all your motivation and support throughout. Thanks to all the respected dignitaries, and I would request everyone to kindly take their respective seats. Before moving forward, for all the respected dignitaries and assembly present here with us today, and to keep this audience to please give a round of applause for all the respected dignitaries present here with us today. Please give a round of applause to keep the spirits high of our audience. I would also specially like to welcome Dr. Vikas Jindal sir, who is the director, Himachal Dental College, Sundarnagar. We are really obliged that you are present with us. Thank you so much. Before starting with our next keynote lecture, we are going to do the felicitations of the speakers. I would request Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir, Dr. Baljeet sir, and Dr. Vikas Jindal sir to kindly present a memento and felicitate the speakers.
गिनी भाई पीछे आगे पीछे 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 का वेट ओके ठीक है थैंक यू सर थैंक यू हाजी प्लीज या जी सर प्लीज
Thank you, sir and ma'am. Thank you, sir and ma'am. Of Himachal Dental College, Sundarnagar, we have Dr. Anmol Bagaria ma'am, founder and CEO of Cynodent International, president of Indian Society of Dentistry, and she is the organizing chairperson of this conference. I would request the audience to please give a round of applause for ma'am, because of whom this conference is possible. Thank you, ma'am. Also, we would like to introduce Dr. Ashish Chandra sir. He is the co-director of Cynodent International, vice president of Indian Society of Dentistry, and the organizing secretary of this conference. Please give a round of applause for sir. We would also like to share that we have Dr. Anmol Bagaria ma'am's mother, Mrs. Usha Bagaria auntie with us. Thank you, auntie, for always being with us and supporting us in our endeavors. Please give a round of applause. So now, without further ado, we start with the next keynote lecture. And for that, I am going to introduce our next keynote lecture. We are eminent oral and maxillofacial surgeon and internationally renowned facial cosmetic surgeon specialized in facial aesthetics and psychology. I would request the IT team to kindly switch on.
Today I'll be talking about facial aesthetics and cosmetology, and my apologies for not being present in person. I was fortunate enough to be there yesterday in a workshop, and I was good and enthusiastic audience with us. At the onset, I would like to thank Cynodent, Dr. Ashish, Dr. Anmol for having me here. I have a practice in Delhi NCR. I'm myself a surgeon. I work with a few hospitals and I have my practice by the name of One Aesthetics in Gutmann and I practice time in Delhi NCR. So, without wasting much time, I will just try to come up with the topic of these facial aesthetics. Just a reality check, which doesn't really stand a chance at this time. There's a lot of studies for limiting fasting, and it's true in some way that people undergo a lot of hormonal influences, and the body framework is much smaller. So the effect of aging is even faster, but I do believe that they have a very good skincare regime as compared to the it's been very hooked on to what its integrity is in its face much longer than it does in its. Everything that happens on the face is primarily because of the signs of aging, which is because of the loss of fat pads and volume from both sides of the face. As we age, we lose volume from the temple to the face, and the tissue accumulation starts happening more in the lower third of the face. All these tissues are kept in its place because of the aging ligaments. These ligaments primarily hold the soft tissue to the bone down below. We can't deny that there are many things happening as well. So the ligaments itself lose its integrity, and the soft tissue also droops down. The aging triangles basically represent the same aging pattern in which the usual face will have a base. Will have a base of the triangle pointing towards the mentron, while the base of the triangle is towards the temple, and the apex towards the mentron. And in an aging face, the triangles reverse completely because there is more tissue accumulation in the lower third of the face. You need to know about all these techniques to actually do justice and know the best about aesthetics, which include the use of toxins, fillers, peels, lasers, threads, blood derivatives, and microneedling. And there's a lot more of surgical options as well which you can use and combine. Toxins, as we know, are multiple types. They come as 50 units and 100 units, and to be diluted with normal saline. 2.5 ml of normal saline to be diluted with 100 in mobile, and use your insulin syringes to inject. The acetylcholine is what the toxin stops from being released from the neuromuscular receptors, so the muscle contraction stops, and the dynamic reduces the discipline. Learn when to say no is the biggest thing when you're starting your aesthetic practice, and make sure that you can understand the patient's expectations and deal with it and give the best to the patients. These are simple cases, straightforward cases of forehead toxins. If you can see the fine lines and the wrinkles tend to disappear. These are dynamic wrinkles. Dynamic means at function, and if you can see there's a glow that comes to the face, which is a very natural thing that happens because the toxin stops the release of the sebum, which is the sweat glands, from the sweat glands, and there's a glow that comes wherever you get the toxin, apart from just the hyperactivity, stopping the hyperactivity in the muscles. In this case, there's a slight difference. I've used fillers to let go of the static wrinkles here. Otherwise, the technique of injecting toxin into the procedures, corrugators, and frontalis remains the same. This is a case of hyperactive mentalis where the toxin has been used in 3 different spots here and 3 units each to actually relax the hyperactive mentalis. Dummy smiles are something that we see every day, and the point that we inject the toxin into is known as the Johnson smile. 1 centimeter lateral to the allowed nose, 3 centimeter above the normal ground. You inject 5 units of the toxin, and you will see results like these, which are very natural and the posterior muscles can stay in this position. These are the markings which verify the Johnson's point, and the 3 muscles which need to be reduced. In this case, I ended up over toxin, and you can see I injected in 2 sessions, totaling in the span of 28 days. I injected 9 units of the toxin, and you can see the muscle tonicity in this case is a little less, and the patient was comfortable and happy with the smile, but the muscle tonicity was definitely a little less. So this was a sign of using excess dosage of Botox or Gutmann. This is a PubMed study. If you want, you can relate to it, and there's a lot of information there in the study. It's one of the longest case studies for the use of Botox in Gutmann. You can also do lethal direction, like in this case. We have done excision of the lethal junction, brought it down, and re-established the system in the future. And these results stay. Toxins can also be used by hyperhidrosis for palms, for soles, for axillars. They tend to be very effective in reducing even hypersalination. These can use toxin. In neuralgia, we have primarily used a lot of toxin in the extra-orbital points or the trigger points. Again, very effective. PMDs make a big domain of the use of toxin. We primarily inject the toxin into the masseter and the temporalis to reduce the muscle load with the bite forces, and really help these patients out. We've used a lot of toxin in facial pain and migraine, reduces the frequency and the intensity of the migraines, and most of the migraine patients actually suffer quite a bit. And it's a tough phase when the migraine actually happens. So frequent use of the toxin actually reduces the pain frequency and intensity. Moving on to double fillers and threads. Fillers are primarily made up of hyaluronic acid, and it's completely compatible with the body itself as polysaccharides, and it's very naturally component. The main role of the fillers are to primarily volumize and address stagnant nerves. Multiple brands available. Please go ahead and use whatever you feel might be right for the patients. And they should be sure the product has a CE and a certificate and a FDA approved. Filler techniques primarily that we are using are retrograde therapy, boluses, aliquots, fanning. The use of cannulas have made filler injections very, very easy. So what most important is that the filler placement is primarily in the subfield plane or in the reticular dermis, and make sure that the filler is not deposited to superficial, because that will be one of those reasons which the filler will be visible under natural light. Facial artery is a very important artery of the face, and be sure you actually read your anatomy well, and you know that where on you be careful with the vessels on the face. In this case, we've done a simple correction of the lower third of the face. We've primarily injected toxin to the EAO, which is the precursor anti-iodis, the muscle putting the muscle down. We injected fillers right where the corners are, the marionettes, the chin, the mental and some amount of the fold. The corners of the mouth are now parallel to the marionette plane. While achieving this, what I encountered was a vascular occlusion. The filler entered the blood vessel and it clogged the blood vessel. Do a capillary refill test and check for branching in the occlusion, and you go ahead and inject the antidote, which is hydrolase, and the result which you see, the final result is after overcoming the complication. Simple mid-face filler. You can see the pre and post of this. This is an immediate pre and post, 1.5 to 2 mm each side, which is done for a flattened mid-face. Same patient also wanted correction of the chin. If you can see the nose to the angle of the chin has come forward. The surgical correction for this would be a genioplasty if the patient is interested. This is a temple volumization. This is done to actually have symmetry with the temples and the midface so that the jawline can actually be narrow. These are temple threads. We go ahead and use multiple different vectors from one point or multiple points. And these are long bob threads which are addressed right to the temples, and even use fillers after the use of threads. Turns out to be a good way to actually tighten those temples and volume loss. You can even use mono threads. Mono threads are small threads which actually tighten below, and the effects of these start coming in by about 2 to 3 months' time. They last for about 8 to 10 months. And these are normal mono threads. Again, with the use of blood derivatives. The pull that comes here in this picture is because of the use of cork thread. Cork threads are long, aggressive threads. I will play the video for multiple such videos and show you this at the end of the presentation. Same patient, before and after immediate, she also got lip filler done, and you see the nasolabial fold is looking much better than baseline. This is a triple vector lips, one vector above the zygoma, one below the zygoma large, and one at the jawline. Main monothreads for the submental area will be oxyfolic acid, and that's how the all threads actually tend to enter the tissue, and I'm just trying to pass a little faster if possible. Bypassing the musculature, the facial artery will reach up to the video. These are aggressive long threads, so they engage the tissue and you can pull it and tuck it in laterally. Lateralization of the face is very important when you want to tighten the face. After it engages the tissue, you can see that you can actually pull the tissue laterally. The entire tissue how confident you work, and you can see it before and after. Narrows down the face, tightens it. Hereditary pigmentation, there are a lot of solutions. You can use lasers, you can use field. You primarily want to do a little bit of volume here, but there is a volume loss. And you use threads and run the lipids also. Before and after for it. This is the use of cannula with fillers for under eyes, and we use fanning technique here and address the entire hollow area in the suborbit, in the periorbital region, primarily for the under eyes. Very predictable way of correcting those hollow areas and static lines or volume loss. Another same case, you can see the before and after, immediate pre and post, and under eyes imaging results. This one was done with the needles, so you can see the before and after. This is again immediate pre and post. Lip fillers are very important and you need to replicate the lip anatomy to give the best results. This case before and after is you should know how to replicate the lip anatomy and how much the patient actually wants. It's better to do less than to do more with lips. In this case, lip micropigmentation was done with lip fillers. Bring the shape down. This was a cleft lip in which we had done the correction for the lip to make it look like a round lip, and a surgical scar revision for star and post surgery, which was done with that. This was some filler lumps which were left in the patient's lip by another practitioner, and it was a long time back, so I did not work with the lump surgery. A lot of patients undergo lip reduction surgery, and we are careful not to remove too much of the lip tissue, so you got the minus cavity plans and this is being post-op. Buccal fat removals are very, very predictable and a good procedure to narrow down the face inside zygomatic below the arch. Pretty narrow complication there. The aim is not to remove the entire back, the aim is to remove half or slightly more than half the back, front of the back. All incision to the rest say cutting the entire back, very important. Here before and after the face was narrow, contour. Nose we can use rhinoplasty threads, they are very practical option for bridge and even getting some clear projection. You can combine it with some fillers and consider before and after, and 4 months time it really does look good. Even though surgical rhinoplasties are the mainstay in rhinoplasties. In this case, apart from using threads, we also combine it with some fat on the patient's body, and we can some fat off into the face as well. This was the same patient that I showed before, and if you can see, we have actually done a surgical revision for we've done a surgical rhinoplasty, mid-face lift, so done some fat down, and if you can see the face looks very, very nice. When you're doing the facelift, which are surgical, you need to be careful about the planes that you're dissecting. These are examples of male and female pattern facelifts. These are all surgical. You can see the before and after. It gives some brilliant results, and these are cases which cannot be solved on surgery. This is another surgical case. You can see it's important to know your patient pains well, dissect properly, and remove the excess tissue. Get some good results for you. Fat is something that we use regularly as a filler, and isolating the fat and filtering it. And the easiest part is actually utilizing it as a filler. Just like we use fillers, we use fat once in and for all the areas that we actually deal with. In this case, the temples, the face, jawline. And if you can see the patient turns out to be very, very happy because there's a glow that comes, the patient face looks healthier, another fat dropping case. You can see this to ease out the autoimmune condition on one side of the face. In blood, platelets are the answer. Most of us use the platelet-rich concentrates. It results in the face and the hair and neck and all the procedures that we use it for. We use a lot of low certification rate concepts. We use a a lot of PRF because fibrin stays in the tissue much longer, say approximately 6 to 7 times longer, and gives better results. Acne scars, acne pigmentation, you've combined PRF with lasers, substitution, microneedling, a lot of techniques that you would want to mix and match and combine to get the best results. The hair starts volumizing with the use of fibrin, and the results are much faster. You can also go ahead and, apart from knowing the hair cycles, you also need to know what type of alopecia you're treating. Areata and androgenic alopecia is what we commonly treat. And you should classify them, you should know the use of punches by using hair transplants, by you're doing hair transplants. They can be manual or motorized punches. We use a lot of motorized punches. This is a grade for baldness, and you can see we harvested from the donor area and transplanted into this area. These are how the results come out in about 7 to 8 months' time. Best results come in about 8 to 12 months' time. This is another case where we harvested and grafted about 3,500 grafts. If you can see in 10 months' time, patient's own hair. Young male, 30-year-old, and good amount of thick hair which it has now, but the patient needs to maintain their hair. This is like giving a female pattern hairline to this patient. This is a beard transplant, and all these are transplanted which been harvested from the oxygen. A good technique to actually tighten the tissue is what we use. Lemon is what I use commonly in trust. I use it for a lot of reasons. Not just for skin, not just for tightening of the tissues, not just for collagen production, but all those tension areas like the upper lip. You can actually tighten all those areas. You can use it for stretch marks, weight reduction marks. I've even used it in multiple occasions for intraoral uses, second stage procedures, something like a peptide. All those uses I use this device very commonly. So if someone wants to find out more, please get in touch with me and let me know. So these are mismatch combinations. You see the use of toxins and fillers and all these things that get used in combination. And these are before and after. We should have mismatch the combination to get the best results for the patients. We have reduced the acne scars, we have contour the face, we use fillers, threads, and fractional lasers in combination to produce results. We use fillers primarily in this case to give high cheekbones and some botox to massacre with the photo. We've used multiple components in this case, mid-face, forward-face, jawline. We've used deoxycholic acid in the submental area. We've used monothreads for 100 of them, or 4 to 5 ml of fillers in the face, and 100 ml of toxins to get such results. Autoimmune conditions, so the first thing was to use lasers to reduce the pigmentation, then use fields to get the resurface the skin. Then we went ahead with the fillers. About 7 to 8 ml of fillers done from this lady, with the use of toxins and repeated follow-ups and all that. We use threads also in combination to tighten the tissue. And simply the right since that's the thing that the patient actually has good compliance towards the treatment. Again, multiple treatments done, inwards to smooth the skin. A lot of peel sections, a lot of fillers, face, under eyes, jawline tightening, use of threads, and use of fractional laser with a lot of peels, about 6-7 different sessions of peels as well. When the end part is actually we need to plan to get good results and correctly plan good patient selection. Use of good products. The 3 important ingredients that are required to actually give the best results. Make sure that you actually give the results according to patients. We do a lot of fellowship programs to train our students very well. No more, we'll be more than happy to answer your questions. We're one of the pioneers in the fellowship programs with calibers also for our students, and make sure that they train so well that they can deliver results to patients. You can follow me on Instagram if required, and you can get in touch with me as my contact information. That's my clinic name and the company name. That's for patiently listening and to answer your questions once again. Thank you again. Have a great day.
Thank you, sir, and thank you, delegates, for listening very patiently. Our next keynote lecture will be an offline session by Dr. Cynodent sir. He is Professor and Head Department of Periodontology from Himachal Dental College, Sundarnagar. Please give a big round of applause for sir.
How many of you are postgraduates? Postgraduates? Undergraduates? क्योंकि आज आप पहचान में नहीं आ रहे, इतने खूबसूरत बन के आए हो कि पहचान में नहीं आए। रोहन, can we start? But a camera is side में कर सकते। Mathematics. Anybody? Okay. See, I am in the habit of distributing chocolates during the presentation. So I will be asking a few questions, and anybody is invited to answer those questions. And if the answer is correct, you will receive a chocolate. Perfect? So with the grace of God, let us start with the presentation today. And I want you to be a little bit of, interactive, so that you learn what we talk about. To my mind, nature is the gift of God to all of us. If we want to take a bath in the morning, what do we do? It's a chocolate question. What do we do? We open the tap, fill up the bucket and take our bath. But from where do we get the water? From where do we get the water? We get the water from the tank. From where does the water reach the tank? Sorry? Pipeline. Okay. And how does the water reach the tank? By motor. By motor. Huh? But now you have to raise the hand and give the answer, only then you will get the chocolates. Rohan has got a full bunch of chocolates. So you will get the chocolates if you raise your hand. Am I audible? Yes. Okay. So the water has to reach the tank by a motor. Right? But how does the water reaches the top of a coconut tree? Is there a motor? Yes.
Vascular system in plants.
Vascular system in plants. Chocolate plants. Vascular system in the plants, and that vascular system is given by nature. By nature, So there are wonderful things in the nature which we must utilize to our benefit. As we are utilizing nature, the water, natural water, to get electricity in the dams. Now this scientist, Murdoch, he saw the birds of his clinic entangled with the fur of his dog, and he invented Velcro. Next please. And the applications are in front of us today. Similarly, the bionic car of Mercedes got its invention from the anatomy of box fish. Next, the jet planes got its anatomy from the octopus. And the straws, they got its anatomy from the mouthpiece of the butterfly. So this is how we use the natural things to our benefits. Now my next chocolate question is, what is mimetics? Anybody who knows what? Yes. No, not you. Yes. Mimicking something is mimetics. Chocolate, please. And a big round of applause for the girl. Mimicking something is mimetics. So what is biomimetics? Biomimetics is a scientific endeavor where you synthesize materials, create scientific things, and you mimic something biologically. That is biomimetics. Understood? Okay. Now what is biomimetics in periodontal regeneration? Biomimetics in periodontal regeneration is where you mimic biologically what might have happened during development of the periodontal ligament. That is biomimetics in periodontal regeneration. Understood? Now, what do we want to attain in biomimetic periodontal regeneration? We want to regenerate the periodontal ligament. We want to regenerate the cementum. We want to regenerate the alveolar bone. यानी कि हम पूरे के पूरे पेरिडोंटल लिगामेंट को रीजनरेट करना चाहते हैं, नॉट ओनली द alveolar bone. Am I clear? Okay. So what are the two major goals of periodontal therapy? Number one is to arrest the infection, and number two is regeneration of periodontal ligament. Agreed? But what are the problems which we face if we want to get the periodontal ligament regeneration? First problem is that cementum is not vascular. Second major problem is that there is repopulation of bacteria. Because it is an oral cavity, you keep on eating something, but the treatment is not proper because the bacteria get repopulated. And the third most important point is that these three tissues, the periodontal ligament, the alveolar bone, and the cementum, they arise from actomesenchyme and mesoderm. So what we need is 3 cells, 3 matrices, and 3 signaling molecules to get the periodontal ligament regenerated. So it is very difficult to get these 3 molecules to work in proper harmony with the matrices and the signaling molecules. Right? So my next chocolate question is, what are the conventional ways to regenerate the periodontal ligament? What are the conventional ways? Somebody at the backstage, please take care of the volume. What are the conventional ways to regenerate the periodontal ligament? How do we regenerate the periodontal ligament conventionally? What we follow these days? Yes? Flat, 1 chocolate for this girl. By placing the graft, very good. 1 chocolate for your name, please. Ishita. And 1 chocolate for the boy who is transferred for the graft. Yes, very good. What else? What else? अगर हमने पेरिडोंटल लिगामेंट को रीजनरेट करना है, there is a periodontal pocket, तो हम क्या कर सकते हैं? One answer was we do flaps. It is okay, good. हमने flap किया, we have removed the granulation tissue और वहाँ पे regeneration possible है. Yes. Second is grafts. Yes. We place the bone grafts and bone grafts helps us to get the periodontal ligament regenerated. What else? Membrane. He will not get the chocolate because he is a periodontist. Yes, you place the membrane and you guide the tissues to regenerate, and that's how you get the regeneration. But although the traditional treatment therapies, they allow the tissue to remain, next please, to remain, Rohan, can I have you there? Thank you. Please come there. Next slide, please. Next, please. Although the traditional therapies, they allow the tooth to remain in the oral cavity for a longer period of time, but the protectability and efficacy of these treatments have probably reached its limit of potential. So there are new treatment modalities which are coming up, and these treatment modalities are biological treatment modalities. They give the clinician with more tools so that he can apply those tools and they can get the periodontal ligament regenerated. And it is possible when we start thinking at the molecular level. It is when we start thinking at the molecular level that we think about the biological ways to get the periodontal ligament regenerated. So it all started, if we recapitulate the events which happened during embryogenesis. What happens during embryogenesis? You get the development of the body in the womb of the mother. Only if you recapitulate the events which happened during embryogenesis, you will get a biological way to regenerate the periodontal ligament. So, the periodontal ligament regeneration, conventional therapy and the biological therapy, they go hand in hand, and this is where the advent of tissue engineering comes in. It will be a little difficult for the undergraduates to understand tissue engineering, but the sooner you understand it, the better it is, because it will give you a better horizon to understand the subjects during your journey of all these 4 years in undergraduate program. So when we talk of tissue engineering, we have to know, we have to understand there are 3 things which are necessary. One is the cells which should be present there for regeneration. Second is the matrix where these cells are present. And third is the signaling molecules which are important for the crosstalk between the cells. So cells are one of the most important requisite for the tissue engineering. And my next chocolate question to all of you is, what are the cells which are present in the periodontal ligament or the periodontal space which helps in regeneration of the tissues? Chocolate man, please. Fibroblasts, very good. A big round of applause for her. No, galat chocolate mat de dena. Any other cell other than fibroblasts? Undifferentiated mesenchymal cells. Very good. Anybody else? We have cementoblasts, जिससे cementum बनता है. We have odontoblasts, जिससे dentin बनती है. We have fibroblasts, जिससे periodontal ligament बन सकता है. We have undifferentiated cells which differentiate into these cells and make new tissues. So cells are the most important part for any regeneration, right? Secondly, the scaffolds. Scaffolds, they form the right matrix for chemotaxis, for differentiation, and for the fibroblast to make new cells. If we don't have the proper matrix, we could end up something like this. We can't make a proper finger if the cell is not proper. So, scaffolds are analogous to the extracellular matrix which is present in the periodontal ligament space, and they allow the cells to grow and regenerate. right? Next is the right signaling. Signaling is the crosstalk between the cells. Somebody has to go and tell the cell what to do. That is signaling. So the right signaling is important, but if the signaling is not important, we can end up something like this. So when we talk of signaling molecules, it is either the self-surface receptors, or it is the growth factors, or it is the cytokines which help in the signaling of the molecules. So if we round up everything, we say we have to have these cells. These cells ought to be present in the proper scaffolds, and they need to get the proper signaling so that everything falls in place and we get a new regenerative tissue. Now, biologically based approaches to periodontal regeneration are either the growth factors, or the recombinant plasma proteins, or the extracellular enamel magnetic proteins, and so on and so forth, which we'll be talking in the later slides. Now, which is the richest source of growth factors in human body? Anybody? Sorry? कुछ कोई बोला था जैसे प्लेटलेट्स 2 चॉकलेट्स हैं इसमें. Very good. The richest source of growth factors in the human bodies are the platelets, because platelets are not only the first line responders to tissue injury, but they are the natural richest source of growth factors in human body. We must understand that the platelets are very important for the regeneration of the tissues, because they contain 6 native basic growth factors in them, which allow them to go to the various tissue components and regenerate the tissues. Now next, we can use the platelets in the medical and the dental field. We can use the platelets for hair loss, and from the platelets we can make platelet-rich plasma or platelet-rich fibrin. We can use it for facial upliftment. We can use it for meniscus tear, and the most important, next please, we can use it to smoothen out the wrinkles. Next please. But lately, since the last 10-15 years, this platelet-rich plasma is being used in dental field also, in prosthetics also, in implantology also, in periodontal conditions also. Next please. So platelet-rich plasma in periodontal defects gives the growth factors increased in the amount so that it can cause the regeneration of the tissues in the periodontal enamel. And this is how we make the platelet-rich plasma. You extract the blood from the patient, and you centrifuge it, and then you get a plasma which you can easily place in the defect. How does it work? The alpha granules of the platelets, they release those particular factors which are then carried on to the various other positions, like the angiograms, like the osteoid, like the cementum, and they tell them to make new tissues for themselves. Next please. These platelets are actually dimers which attach to the extracellular, the surface receptors which are present outside the cells. Once they attach themselves with them, they activate the phosphate bonds within the cell. Next please. Once the phosphate bonds are activated, they activate the gene in the cell and they tell it to go to the nucleus, and the nucleus then tells to the other cells to regenerate into either the cementum or the alveolar bone or the periodontal ligament cells. This is how the growth factors, they work within the cells. Let me show you a few cases. Now, as you see on the left side, this is a clinical view of the infrabony defect and the bony depth. Here you can see the initial radiographic view which shows the loss of bone. This is after the tissue was opened. This is the intrasurgical measurement of the intrabony bone. Again, the application of PRP on the defect. 12 months clinical view of the intrabony defect. You can see or appreciate that the pocket depth has reduced. And this is the radiographic comparison of both the preoperative and the postoperative view, which shows that the bone formation is there after the application of platelet-rich plasma. Another case, upper molar, a big defect in the bone up there on the left side, application of the PRP. Re-entry after 12 months shows the comparison between the both. Next chocolate question is, who is the PM of our country? Samir, I don't have so many chocolates. Thank you. So yes, the PM of our nation is Narendra Modi, and a very good Prime Minister who has taken our country to greater heights. Now next is recombinant protein therapeutics. Now what is this? This is another protein which is available in the market, which contains platelet-derived growth factor 1000 times more what is present in the platelets. That is available off the shelf, and you can apply it in the defects. When the material is packed in the defect. Next please. This growth factor is directly released over the defect. It stimulates the periodontal ligament cells, and the bone and periodontal ligament regenerate after the maturation of the tissues, effectively restoring the normal bone structure and the tooth function. Just to give you a little view about how it works. This is a preoperative radiograph of the patient and shows the defect on the right side. Next please. Can we have the previous slide? This is the defect. Next please. And this is the defect still after the recombinant protein derivative has been placed. Next. Another defect, a large defect in the anterior tooth, the anterior canine. The defect has been covered by recombinant protein derivative. Next please. And this is the result after 6 months of the placement of the protein derivative. The defect is completely filled, and this is the radiographic picture which shows the preoperative and the postoperative result after the protein derivative has been placed. Now next is enamel matrix proteins. For the first year and second year students who are sitting here, you must have read about the bell stage and the cap stage when the formation of tooth takes place. After the tooth formation the enamel formation is completed, we have Hartwig's epithelial root sheath. The Hartwig epithelial root sheath has an enamel layer inside which disintegrates and which stimulates the dental follicle to make cementum and alveolar bone. Now this is exactly what we have in enamel matrix protein, which is known as amdogain. And after it has been potent the defect. It mimics the work which is being done during embryogenesis. It mimics that. Next please. When we place the embryogen in the defect, it stimulates, next please, stimulates the periodontal ligament cells and the alveolar bone cells, helps them to regenerate, and a mature tissue is recast in the tissues which have been lost because of the periodontal disease. Now, where are these EMPs derived? From where are these EMPs? From where do they derive? Anybody? Anybody who can tell me from where do we derive the EMPs? Okay, these EMPs or the enamel matrix proteins, they are made from the fetuses of the rabbits in Scotland. 6 months fetus of the rabbit in the Scotland, their tooth bud is extracted and they derive the enamel matrix proteins from them. So far, 3 million patients have been treated with the enamel matrix proteins. Can we have the case reports? Now here you can see loss of bone on the mesial side of the upper central incision. This is the clinical picture. And after it has been placed, the bone gain and the radiographic picture which shows a lot of bone gain after the abdomen has been placed. And next case report, lot of bone loss in the premolar area, both on the mesial and the distal side. Radiograph shows the increase in the bone height after the abdomen has been placed. Again, the bone loss before and after. Right side shows the loss of bone and the left side shows a lot of bone gain after the abdomen has been placed. Another case, loss of bone has been appreciated in the radiograph after the abdomen has been placed, 2 months after the abdomen has been placed. And here you can see there is a bone loss and also there is a periodontal infection at the base apex of the tooth. Root canal was done, abdomen was placed, and on the right lower side you can appreciate the bone gain after the abdomen has been placed. So this is the beauty of the growth factors, the protein derivatives, the abdomen enamel matrix. It's a lot of scope that we have to learn, because you are the budding dentists sitting here, both the undergraduate and the postgraduate students. So a lot of scope. We have to learn the new principles. We have to copy those principles and synthesize certain materials which help us regenerate the materials. So if I have to conclude, I would conclude that we should think beyond the conventional ways of dentistry. We should think the biological way to regenerate the periodontal tissues, regenerate the tissues which we have lost in the oral cavity. And we have to have that comfort zone, between the materials and our way of working. When I talk of, the comfort zone, I have this beautiful slide with me. This is the, next please, this is the American president. He visited China and he kissed the Chinese premium's wife and he was in China. So he invited the Chinese premium to his, USA, and when he kept him at a comfort zone so that he would not kiss her again. So we need to have that comfort zone to create, winsome smiles, and we should thank God that we are sitting here in this premier institute. Thank you, Cynodent, for organizing this conference and giving our students an opportunity to learn, an opportunity to interact with the speakers. Thank you very much. God bless you all. And if you have any questions, society.
Thank you so much, sir. It was a pleasure hosting you here as a keynote speaker as well. Thank you once again, sir.
Can I have 2 chocolates for the beautiful ladies standing there?
Thank you, sir.
Thank you very much.
Further ado, I would like to continue with our keynote lectures. It's time for our next keynote lecture, and it is the speaker of the keynote lecture is Dr. Sameer Kaura sir. A brief introduction of Dr. Sameer Kaura sir is he is ex-professor and head of department of oral and maxillofacial surgery, Himachal Dental College, Sundarnagar. It's a pleasure to host sir today, and we are looking forward for your informative lecture. Please give a round of applause for sir once again.
And HBC for inviting me here. It's like coming back home. Many of you know that after finishing my graduation, I started my career here in HBC. And probably whatever I am because of this place and because of these 3 gentlemen. One of these 3 who are here with us, one is always with us, blessing us from top. So I owe a lot to these 3 gentlemen and to this institution, HBC. Thank you very much again. It's like family here. Now, you have heard beautiful lectures since morning, and they were all brilliant because they were not artificial, they were actually natural intelligence. But what I'm going to talk today would be artificial intelligence in healthcare. And that's the reason my slide will not show Dr. Sameer Kaura, it is Sameer, artificial intelligence, right? So, let's see what we have there. How many of you are hungry? That's why you're having chocolates. I don't have chocolate questions for you, so please do not expect any chocolates from me. But I assure you that after my presentation, for which I'm going to take like 30-35 minutes, I will feed you with good lunch. Would that be okay? So from few chocolates to wholesome lunch for everyone. Thank you. Right. So how many of you change phones, or how many of you flip each other's phone and sniff into others' phone? Very difficult, right? We can forget our books, we can forget our money bags, but we don't tend to forget phones. But कभी किसी ने चोरी एक दूसरे के फोन में झांकने की कोशिश की? Majority of that. How many of you have actually done that? Nice. Thank you. So, what did you sniff in your colleague's phone? Dr. Kanika actually sniffs on the Google searches and YouTube videos which Dr. Jindal sees. So what do you sniff in each other's phone? The WhatsApp chat? Right, so if all of you open YouTube on your phone, I'm sure everybody will have a different set of content. So if I open a YouTube content, I would have the kind of songs which I listen, the kind of videos which I listen. My son opens it and he sees Ed Sheeran there and the young people who sing. My wife sees a lot of laparoscopic surgeries. So we all 3 log in at the same time in the YouTube without even pressing a punch. We see different content. How is it possible? It is one company sending all the data, staying at the home page, yet we see different content. And that's because this internet or this server, it learns what you are seeing. So depending upon your visual patterns, depending upon your searches, it tends to open the kind of content which you like to see more. And that is all because of this AI. We are all dealing with artificial intelligence in a little bit or in a major way, but definitely for sure, the future is going to be artificial intelligence. except for the people who are sitting from this side on the front row, we know era of 1990s where we never had a mobile phone or a cordless phone. Our phones were clipped onto the wire, and we used to if a phone call used to ring, we used to run from one room to another room to answer the call. And that was an era where it was wired technology or unplugged era. I believe most of you were born in 2000s. We had an era of 1995 where internet was born. The only thing which we used to do with internet era was to check our emails. There were no flashy sites, nothing, no information around. The kind of articles which you look for your journal clubs or for your seminars, they were really very hard to find. When I did my post-graduation, we used to travel to Delhi National Library or travel to Manipal, where the library was huge, flip through the pages of journals and then get the articles which we wanted to. However, now all you need to have is a subscription, surf all the articles, whether it is published in US or Canada or Australia, on your computer. And then came an era of mobile era, which is called as mobile era in 2005, where everything was mobile. I mean, we had mobile phones, and it was a kind of royalty if somebody used to possess one mobile with him, though the incoming calls were like 16 rupees per minute, which I'm sure that you wouldn't have dreamt. And all I remember in that era was first 5 seconds of the call was free. And I remember me and my friend used to call within 5 seconds. Hi, how are you? And the phone used to be kept down because we didn't want to be charged for our incoming as well as outgoing. And then in 2015, that's an era which you guys are actually enjoying or relishing, where each device is interconnected with each other. Your mobile phone is connected with your iPad. If you are an Apple user, your iPad is connected with your Apple MacBook. So all your devices are interconnected with each other. So you are basically living in the cloud. So if you upload any stuff on your iCloud or any cloud, you can access that in any part of the world, and that era is the one which we are living in. You must have seen Terminator movie. Well, we have seen. This movie was actually released in 1984. How many of you were born in 1984? 1990s? 2000? 2001, 2, 3, 4, yeah, many. So this movie was released in 1984, and I was in 4th. I passed my 4th exam when this movie came. It was a big-time sci-fi movie where a robot is trying to kill a gentleman, a small kid, and whatnot. It was very hard to dream about such things in 1984, but all these things are turning out to be reality in today's world. So we have all thinking computers now. You think about it, and probably another computer somewhere in the world is also thinking about it. Because we are making our computers such advanced that we don't have to think much about it. We have smart devices. We are about to enter an era where our devices will read our memories, read our reminders, read our schedules. So if you are scheduled to enter a hall like this, where you want to listen to one of the lectures, so automatically your phone will go on silent because you don't have to press the button silent. So that's the kind of technology we are looking forward to. A lot of transistors were used in a microchip to develop all these gadgets. Now, number of transistors, depending on the transistor which is present in a microchip, depicts or shows how advanced your technology is. And these transistors keep getting doubled every 2 years. So every 2 years, the number of transistors in a microchip gets doubled, and that's how your advances are seen every 2 years. You might see a good Apple product every year, but if you really want to see an advanced Apple product, it comes every 2 years, which because the chip is getting upgraded every 2 years. So we have computers now which are actually making computers. If you go, happen to run into a computer factory, you might find a robot who's actually manufacturing a robot. If you see a video how a car is getting manufactured, 70% of your car is also getting manufactured by automated units. So people are running, doing different kind of jobs rather than fixing nuts and bolts in a car. And because of that, advancement in the technology, because now we have computers, we have softwares which are upgrading by themselves. Sometimes if you have to log into a very high secure site like banking transactions, we need to justify ourselves by clicking on these boxes that I'm not a robot, or you might have to answer a few pictures. Click on the pictures where you see traffic lights, click on a picture where you see some kind of gadget. So that is just to create a human error so that computer doesn't realize what patterns you are following. When you see 20 years of growth in terms of GDP or technology-wise, we are advancing at a very, very higher rate. 20 years of growth was seen when you see the data between 1900 and 2000. So in 100 years, we only grew by 20 years. When we see the growth of 20 years between 2000 to 2014, it took only 14 years. And it took only 7 years for to see a growth of 20 years from 2014 to 2021. Who knows, for the next 20 years, growth is only seen in 4 or 5 years. So we are moving actually at a very, very faster pace. And thanks to our artificial intelligence. We have stores now in India as well. The first store of Amazon Go was opened in Washington, and that was in 2016. All you need to do there is show your QR code of your Prime app, Amazon app at the entrance, enter inside, pick whatever you want, and then just walk away. Automatically, the products or the bill would get debited from your account. And we have a store which is opened in Kochi last year in India as well. So life is getting simpler day by day, and that's all because of our technology. AI is not only into our professional lives, but it is also in sports. There are computers which are beating the world's best players. We have a game called Go, but that's also been beaten by a computer. It's a 2,000-year-old game which was beaten by a computer. You have softwares from IBM Watson. They were the first guys to integrate artificial intelligence into banking system, and then which is slowly getting integrated to every day-to-day life. China is far ahead than most of the countries in terms of artificial intelligence. We know that there are brilliant software engineers in India, in US, in Europe, but they have equally number of good engineers there as well. The only added advantage which China has over the rest of the world is the kind of data which they have. They have the highest number of face recognition data compared to anywhere in the world. China, there are places, you enter a restaurant, he's going to give you an option. Sorry, we cannot serve you a dessert because you are diabetic, because your face is recognized by their software. There are places, there are many apps which use your face recognition and tell you what to see, what not to see in China. So China is getting way further ahead than any other country than us. How this AI works? How this AI works? If I'm a human, I would identify this as a husky, Siberian husky. But if a computer has to identify this, how will he identify that? He doesn't know a picture, right? So what he does, he maps an outline. He sees what is present behind the picture. It's woods. What is present around the picture? It's snow. So what animal is present in that? It's either the Siberian husky or a wolf. So he identifies this as a wolf or a Siberian husky. But as you train this software, as you train this, ultimately he's going to give you an answer that this is a Siberian husky. What we are using is our intelligence to learn that this is a Siberian husky. How a computer learns? He checks the surroundings of the picture and says it's a Siberian husky or a wolf. In India, we are getting started. There are face recognition systems at entrance of many of the airports. So we are getting there. So if you want to develop a software for artificial intelligence, all you need to learn are three things. You should be good in maths, which doctors are mostly not. You need to learn Python language and a Java language. But if you can learn all these three things, you can develop a software on artificial intelligence as well. Because there is a software called TensorFlow, it is free of cost. All you need to do is learn how to map your things and then identify them, and you can create your artificial intelligence software. So what is artificial intelligence? It's nothing but simulation of your human intelligence. Now it has three learning focuses. It learns, it reasons, and it self-corrects. So as I told you, there is a picture of this wolf or a Siberian husky. It learns the points around. Now, he has to make a choice between two, either a wolf or a Siberian husky. He learns that this structure or this appearance has to be Siberian husky over data after data. And that is how it self-corrects it. And finally, now, if you show that picture, he's going to come out and say, this is a Siberian husky. Instead of giving you two options, he's going to tell you it's a Siberian husky. So how in medicine, there are two branches of AI which works. One is machine learning. What is machine learning? It's something like if I give a picture of cat to a child. If he sees a picture of cat, if you show multiple pictures of a cat to a child, he will recognize how a cat will look like. But what is deep learning? If I just show eyes, like if I show you just a picture of eyes of Aishwarya Rai, I'm sure without looking at the face, you will certainly say, okay, she's Aishwarya. And that is your deep learning, because you have seen that picture so many times that looking at the eyes only, you would say it's Ash, not somebody else. So that is deep learning. So there are two branches. That is how AI works. It is machine learning, that's initial phase, and deep learning, that is your advanced phase. Now we have a lot of uses of this artificial intelligence in healthcare as well. Though it is the beginning, but it's definitely not the end. Sorry, I don't know why it is jumping. That's artificial intelligence. So there's a software by Google called Lyna, L-Y-N-A. Now what this software does is, you put the slide, subject that slide to a software, it's going to give you a diagnosis. And for breast cancer, it is 99.9% accurate. It's more accurate than a pathologist. So probably in future, we will see many more developments that doesn't mean that your oral pathologist or a general pathology is going to go without a job. We need them to validate these things. So we have a software, by looking at the slide, that's going to give you a diagnosis. There are softwares and machines to identify if a patient has a diabetic retinopathy. It's one of the major causes for blindness, and if you identify these things early, you can save a person from going blind. These machines are approved by FDA and they've been installed in many parts of the United States, in Walmarts or Costco's everywhere, and all they need to do is sit in front of a machine and they're going to give you a definitive diagnosis whether this patient is vulnerable for diabetic retinopathy or not. If he's vulnerable for diabetic retinopathy, a slip comes out and he takes that slip and goes to his optometrist or endocrinologist to get his condition treated. So AI is getting very helpful by day. The first presidential lecture in any scientific congress happened in 2018, where in a urology conference, the topic was artificial intelligence. So artificial intelligence, I'm only talking after 5 years. There have been lectures, there have been keynotes, 5 years before me. That's a robot, Da Vinci robot. People try to. There was one surgeon who was just sitting and he made a sandwich, and when you had to check the kind of sandwich which was made by this robot, it was as good as a sandwich made by a Michelin star chef, though it took 8 hours to complete one sandwich, right? But what we get from this is that the finesse, the precision which we can get with these machines, it's far ahead than humans. Let's come to AI in dentistry. So are robots the future of dentistry? Well, let's see. We have dental simulators. Many dental colleges have these dental simulators where you do cut cavities, where you learn crown preparations and do other stuff on these kind of simulators. They are not just phantom hacks, they are pretty advanced simulators. Few of the models which are used in Japan and many European countries as well as North America are these Showa Hanko, which not only doesn't behave like a phantom hack, but also responds with the eyes, like she's got some pain while you are cutting a cavity in that. You have a bit more advanced Geminoid F, which can smile, which can give a frown if you're not doing a cavity preparation right. But you have the most advanced, which was released in 2019, Simroid, 2019 or 2018. If you are not cutting the cavity properly, if you are harming that patient, she's going to come and complain. Look, mister, you're not doing the cavity right. So we have simulators so advanced that they're going to be like patients, live patients, and you learn the things in the right way. So, and this is only possible with all the advancements with artificial intelligence. There was one article written by Dr. McGill Stanley, which was published in one of the dental magazines in Dental Tribune. He says artificial intelligence is going to be part of your diagnosis and treatment planning. It's going to be part of your execution of your treatment and also day-to-day management of your clinic stocks. How? Diagnosis and treatment planning, it's already a part of it. It's going to be the future when we start deciding about the kind of treatment which you should be doing and how you should be doing. Because we are already having few robots in our dental management practices where a robot can place a dental implant as well. For managing your dental practices on day-to-day basis, we are still getting into it. But the day is not very far off where we see artificial intelligence playing a major role into our practices. There is a software called IOSmile by Ivoclar. All you need to do is you get yourself clicked in that software. He's going to see your smile from different angles and tell you what best you can do for your smile. So it's a very good software for smile designing. You can go to YouTube and check all these videos. There's an article published by Hung which shows the role of artificial intelligence in dental and maxillofacial radiology. Now what it does is, it says that you can identify caries by 96 to 99%, and that's very, very close to your human examination, which is around 99%. But when you take perioperative radiographs of posterior teeth, the accuracy is around 75 to 93% with artificial intelligence software. Whereas the range of accuracy with clinical experts is from 19 to 94%. So what you need to see is these two values, the 75 and 19. There were people who could only appreciate posterior caries or the proximal caries by 19% only, whereas a computer minimal accuracy is 76%. So the more accurate diagnosis can be made by use of these artificial intelligence softwares. There are softwares available in the market, they are still in beta stage, where all you need to do is get a panoramic view, subject that panoramic view in that software. It's going to give you what all is present, what has to happen in your oral cavity. There are 1 or 2 companies which are working on it, and the day is not far behind when we will have that software in our clinics as well. It's going to show on your radiograph if there are implants present or not, how many cavities are present there, how many restorations are there, what kind of bridge you require. All that information which our oral medicine and diagnosis department does would be done by this. But again, we are not taking away humans from a day-to-day practice. We still need doctors who will train these softwares. Coming on to orthodontic field, again, we are not omitting or we are not saying that orthodontists are going to go off work, but it only says that there is a study published which says there is an 80 to 93% of accuracy whether to go for extraction in this case or not. Sorry. So that was deliberately to show it's not artificial intelligence, it's still a human talking. Okay, so there was one article which I was reading, I can't recollect whose article was that, but the greatest confusion between clinicians is whether to extract or not to extract, and that ranged around 50% of the people had different opinion and 50% of the people had different kind of opinion. So if we have softwares which can tell us with an accuracy of 90% that we should be extracting teeth in this case or not, it will make our life a little easy. Perio. How many perio PCs are here? I'm sure in the next 5 slides, you guys are going to face the hell from your bosses. I'm sure because once I leave this, you're going to have a journal club with this because the maximum number of slides which I have with artificial intelligence is from perio. So get ready. Okay, so how accurately can you differentiate between aggressive periodontitis and a chronic periodontitis case? Please. Okay, then buy the software which will give you accuracy of 90 to 98%, right? This will differentiate how from a peripheral blood smear by going through the values of your blood investigation. The accuracy of differentiating between aggressive periodontitis and a chronic periodontitis case is nearly 90 to 98%, and which is a very decent number. And depending upon that, you can decide whether to extract that tooth or not. So how predictable that is? That's again in the tune of 76% to 81%, which is very, very close to our human judgment. Now, the only confusion was with the premolars. Why that confusion? Because it is very difficult for a computer to judge whether this first premolar or this is a second premolar, because both the premolars look very much the same. But with time, that hurdle would also be overcome. Then, by use of this artificial intelligence technology or science or software, just by subjecting your photographs of a patient, you can check whether this patient's got a chronic periodontitis, how aggressive that periodontitis is there or not. And this study was done on 567 pictures, and it showed very high sensitivity and high specificity in diagnosing these periodontal conditions. So imagine if I send you one picture, this is a picture of my gums, you would send me a message, oh, you're going to have chronic generalized periodontitis, please come and see us. So the diagnostic value of these softwares is very, very high. Coming on to endo department, it again plays a very vital role. Most difficult thing is to identify the canals. How many canals are there? Yes, we can take CBCTs and read through those CBCTs and see how many canals are there. But how much time do you take to analyze that data? how many canals are there? One, what is the angulation of that canal? What is the angulation of mesial canal to the distal canal? How many orifices are there? How many minor delta canals are there? We take a lot of time, and the average time which was taken was around 25 minutes to analyze a CBCT to reach these diagnoses. How much time software took? It took less than 20 seconds. So what we are saving? We are saving on our diagnosis, the treatment time, the diagnostic time which we spend on these software. And how accurate that was? It was around 87%. That's another study which showed the accuracy of reading apical foramens. And then using these artificial intelligence technology, we have navigation surgeries in endodontics as well, so that I don't touch the innocent teeth, I just do the surgery wherever it is required and very, very precisely. In oral pathology, again, I showed you a slide of Dr. Lina, where Lina software was diagnosing to the tune of 99% about the breast cancer. But we have softwares for oral pathology as well, which differentiates between meioblastoma and dentogenic keratocyst or dentogenic keratocystic or dentogenic tumors. Now, looking at the radiograph only, it will tell you whether this is a meioblastoma or a OKC. Now, the life becomes easy when I just need to subject a radiograph, not subjecting a patient for a biopsy. Looking at this only, I can differentiate between a dentogenic keratocyst and meioblastoma. And the accuracy of this is again around 80%. Dr. Divya gave a beautiful lecture on dental implants, hi-fi lecture, the lecture which I waited to hear for nearly 5-6 years. I've been requesting him to give me that lecture. He refused.
I wanted you to come to Sweden.
I came 3 times, but he did not share it. But I'm so happy and glad when you see that people who I was not a teacher exactly, I was just a 1-year senior to him. But I'm very happy and very proud when I see people who are progressing, and I'm very proud to see Divya reaching these heights, that there is a time that I want to learn from him. It's good. Time is yet to come where I have to make my teachers proud. I'm still waiting for that time. I have to use some artificial intelligence for that. Okay, so we heard a very beautiful lecture about dental implants. The biggest problem with when we see a lot of cases with consultants is that we are unable to identify the mandibular canal. And that's one of the key structures when we are placing implants in the posterior mandible. Now, if I have a software which can identify a mandibular canal so easily that I do not go wrong, chances of my injuring inferior alveolar is minimized. It's the clinical judgment error which gets reduced by use of this artificial intelligence in identifying inferior alveolar canal, and the accuracy is 96%. So don't go by word only 96%. 96% is a pretty high value. Divya teaches a lot of people, he conducts a lot of courses. I travel a lot to conduct a lot of courses, and I see that there is a lot of difficulty with our participants to identify these normal anatomic structures. So if we have something which can identify these anatomic structures, life becomes very easy, and we can eliminate one component which can give us more complications. Using all these technologies integratedly, either in a scanner or in a CBCT or identifying normal anatomic structures, we can finish one implant case from start to finish, from entry to exit, in at least less than 90 minutes. You walk into my clinic, if I have all the technology in my clinic, I can send the patient out from my clinic in 90 minutes with a temporary prosthesis. That is how technology has to be used. There is a robot which assists in a dental surgery. You can see that video a little later. you need to enter values into this robotic hand, and it's going to place implant the way you have devised. Now the question is, if I move left or right, what will happen? Will this drill drill at the same place, or will this drill enter my teeth or my tongue? No. So if a patient moves left or right, this arm will also move left and right. So there is no chance that the drill is going to enter your tongue or teeth area. I think in 2017 or 18, there was one surgery done in China which was completely robotic. 2017, which was completely robotic. The old surgeon, what the surgeon was doing, he was only changing the drill bits in that handpiece. Rest, every surgery was done by a robot itself. All you need to do was, you have to feed the data into that computer, and rest everything a computer would do. We have intraoral scanners into our practices, and that's the in thing, that's the vogue, everybody wants to have it. It makes life very easy, but doesn't take away the effort of a prosthodontist to take physical impressions. We have these intraoral scanners in our operatory, and trust me, the accuracy is not very good, but it's good. It's less chances of human error, less chances of distortion of your impressions, less chances that your technician is going to break your casts by transporting or in the lab. And in 10 years' time, if you need to redo something, you still have data in your computers, and you can use the same data and fabricate another crown maybe at a later date. In oral surgery, again, AI plays a very important role. One of my friends in Cincinnati, he's developing a software using these OPGs. He's coming out with a software where if there's an impaction, he's going to guide us what cuts to give. If you follow those instructions, extraction of this impacted tooth becomes very easy. There are softwares which are used to check the symmetry of the face, which will help us in doing a good orthodontic surgery with exact precision. A surgeon works with precision. I mean, you're all surgeons, not only the abstract surgeons need precision, but you all need precision. So we are getting there where a robotic arm can have the same tactile sensation like what we surgeons have. When we are reflecting a full thickness mucoperiosteal flap or a partial thickness periosteal flap, or you are elevating a tooth with the help of a periosteal elevator or an elevator, we rely on our tactile sensation. So there is a study going on, there is work going on where a robotic arm can develop these tactile sensations and would have same kind of hermetic feeling as you have with your fingertips. There are smart toothbrushes available in market. I'm not sure if they're available in India or not, but there are available in global market from Oral-B, where you brush your teeth and the data is getting transferred onto your app in your mobile phone, and that will give you an indication how much, what's the duration of your toothbrushing, how many times you are brushing, and how much surface of your teeth is covered with your brushing. So that's going to give you a kind of idea how good you are in maintaining your oral hygiene. So all this artificial intelligence actually works on this concept of data, information, knowledge, and wisdom. What we collect from our articles or from CBCTs or from X-rays is the data. And when you subject this data with questions like when, what, where, how, it becomes information. And when this information is supplemented with your experience, you will come to know whether I should be doing this case or not doing that case. So the difference between you and me is not much. The difference between you and me is that you are probably collecting the data, oh, this is got a periodontitis, this needs probably extraction or maybe not. The difference between your teacher is that he's using his knowledge as well as wisdom, where he's able to decide with his experience whether I should be extracting to get a good result or not. Or I can save with my surgery this or not. So the whole artificial intelligence actually works on this BIKW concept. So AI is becoming more accessible in our day-to-day life. AI is automating routine work, not taking people's job, but the kind of jobs which are happening now are just getting different. Human interference is possible because it is us who are calibrating these data, but definitely healthcare practitioners are unlikely to be displaced by artificial intelligence. For sure, there are some challenges, ethical challenges with artificial intelligence, but I believe with time, with passage of time, these challenges would also go away. You remember when there was no electricity bulb, we used to use oil lamps, and everybody was so scared of using these electricity bulbs, they thought the whole house might get burned by any fire or any short circuit with our electrical fittings. But now, can we survive without any electricity? No, never. So that's just the beginning of what we are seeing in artificial intelligence. So it's just not the end, it is just getting started. Now, all this information was easy to get. I have a ChatGPT on my phone. All I did was need a presentation on artificial intelligence in dentistry. I just screen recorded this whole thing. And you know how much time it took? Milliseconds, and my presentation was ready. It's right there. What should be my first slide? What should be my last slide? Slide 1, 2, 3, 4, 5, 6. I made my presentation like this. That's not all. That's not all. But then, should I really be relying on this ChatGPT? That's a question. Now read the answer what ChatGPT gave me. It is a valuable tool for general information and conversation, but should not be solely relied upon for making important decisions. I showed you a way of making a presentation, but should we really rely on these kind of information? Trust me, answer is still no. Thank you very much. Really appreciate it. Any questions before instead of chocolates, I give you coupons for lunch?
I have one question.
Yes, sir.
See, I will listen to your entire lecture. So I listened this lecture about a year back also on the same topic from you only. And a lot of new things that you have added, I think, in this lecture. What I gathered is, I think it is the diagnosis part which is made easier with AI, or is the treatment aspect also? Let me complete, sir. One more.
Yeah.
So you were talking about different specialities. Let's take my specialty, orthodontics. So you must have heard about aligners these days. What is the role of orthodontists in aligners today, in the backdrop of artificial intelligence?
So two questions. One is the role of this artificial intelligence only limited to diagnosis? Yes, the answer is still yes, because right now most of the data which artificial intelligence uses is from your radiographs or CBCTs. And that's the key where there are a lot of centers in India, especially in Pune, where people are collecting data from CBCTs, they are analyzing it and selling it to different artificial intelligence companies. That is how, if you see the entire lecture, whether you are dealing with orthodontics or you are dealing with periodontitis or MaxFax, everything which gives you a 90% accuracy is with your radiographs. So the diagnosis is becoming little easy. The second line is your treatment part, not the treatment planning. We are getting better with our diagnosis and treatment planning, but not the treatment part, because that would require help of our robots. They need to be trained. So far, we just have one computer, one robot, that too only for implants. Yomi, that too is available only in US. So we are getting there, but we are still very far out. The second question was aligners and artificial intelligence. Yes, I believe that a lot of data is used, a lot of artificial intelligence is used to define aligner, how an aligner would behave. Because I was taught orthodontist by a sir, but I quit doing ortho long back. Orthodontists come. When I speak to sir or many orthodontist friends in India, they all say we are doing Invisalign or whatever aligners just for the sake of it. But when we do tell our patients that you will require braces, maybe you will require, maybe you won't require, but we charge them braces plus aligners. Brace aligners, I am not very expert in that, so pardon my ignorance. Aligners can give you some kind of finesse, maybe some kind of results, but to be good, I think braces still play a very important role in most of our cases. I have no hesitation in telling you, I tried myself Invisalign for correction of deep bite. My bite went off, the deep bite is still present. In the bargain, I started developing TM joint issues. So, maybe in future, we will have some role of artificial intelligence and more accurate kind of aligners than what we see now.
See, one more thing you said that you being a teacher of Divya, you are proud of him. We are all proud of both of you. We have seen your growth also, Sunil. So the day, I still remember those 2001, 2002 days when you used to work with us. And where you have reached today, we are all proud of you.
Thank you.
Oh, thank you very much.
Thank you, sir, for such an informative and interactive lecture. Please give a huge round of applause for sir. Dear delegates, lunch is being served, so you can proceed for lunch. Meanwhile, the lecture will be continued in the auditorium. So, now let's move forward with our next keynote lecture.
The keynote session by Dr. Jasmeet Singh Kalra, sir. Dr. Jasmeet, sir, is an eminent prosthodontist and a pathologist. Yesterday, we took a very interactive and informative lecture and hands-on workshop on dental implants as a pre-conference course. And it's a pleasure for us that sir is present amongst us today as well via digital online mode to deliver his keynote lecture. I would request the team to kindly
Hi, good morning everyone. So my name is Dr. Jasmeet Singh Kalra. I've done my post-graduation from ITS College, Greater Noida in the Department of Prosthetics. So basically I'll be talking about the on 3D implant placement and prosthetic rehabilitation. So if you can see here, the beauty comes with different packages. What are we actually looking for? Package like these, where you see the gingivals and frame where you are not getting the results. Or maybe somewhere where there is a black triangle. And because of this black triangle, your patient will have an anesthetic smile. Or in a case like this, where what you see is the implant shoulder which is exposed. And because of these exposures, you will always find an anesthetic results. Cases like these, when we have to use this pink ceramics and just to hide the dental papilla or to mimic an dental papilla. But if the patient has a low smile line, you can still get away. But if your patient has a high smile line, you ought to give a better results than these. Or in these cases, wherein there is hardly a buccal bone and the entire implant is can be seen through the soft tissue, or the bleached metallic hue can be easily visible. Or in this scenario, after the wrong implant placement, it has been placed more buccally, because of which you can see the entire 3 to 4 threads of implants are exposed. So my name is Jasmeet Singh Kalra. I have done my graduation from Cynodent International College, Lucknow. I'm indebted to ITS College Greater Noida, whatever prosthetics I have. I'm diplomat with World Congress of World Implantology. I'm a fellow of Dentistry Academy Korea, TOP leaders with Dentistry and CSM implant companies. Mentor for foundation course in implantology, which is FCI and LCI, Westcom implant prosthetic module. I've been extensively trained by Guy's Pharma for hard and soft tissue grafting. Consultant for more than 15 clinics in and around NCR, and I'm proud owner of 2 medical offices in Saudi. Always believe something wonderful is about to happen. Sharing my first case, wherein what you see is a routine case when there is one month missing, and patient comes to you in this scenario. What do you do next? Implant is no more a luxurious treatment. It is a mandatory treatment. We hardly do fixed and processes in these cases if the young patient comes. Reasonably, we are looking at least 20 years from now, and we don't want the natural tooth should be hampered or we should be tampering with the natural tooth. So what we did is we have given a pressure incision and opened up a full thickness flap, and this is the kind of bridge which is visible. As soon as I retract more and reflect the flap more, you can see this buccal concavity or buccal diastance. So in this diastance, it is not easy to place implant. Or maybe a case like this, wherein after extraction, if you plan any kind of immediate extraction and implant placement, you can always have no introductory mode, and you cannot even plan to place your implants. So first, before starting to place implant, we always go with this SSC classification, that is, what are the simple cases, what are the advanced cases, and what are severely advanced cases or the complex cases, I would say. So accordingly, we plan our case as per this classification, and then we proceed ahead for the implant placement. So what is most important even after these classifications are the placement of implant in the correct 3D position. It's a key to an aesthetic treatment regardless of the implant system use. So your implant should be in a correct prosthetically correct 3D implant position, wherein you should have in case of any anterior aesthetic cases, in case of maxillary, the implant should be placed slightly correct to have a palatal access hole. Whereas in case of mandible anteriors, it should be placed slightly lingual to have a lingual side access hole so that you can still get away with screw-related processes. The basic golden rule placing an implant, most important one is you need to have 1.5 to of bone into the buccal and lingual aspect, so that even if there is bone turnover of 0.3 mm every year, even then at least my implant survival will be not less than 7 to 10 years, depending upon patient systemic condition and oral hygiene. Otherwise, between implant and tooth, the minimum distance has to be 1.5, and between two implants, it has to be 3 mm. Taking these things into consideration, one of the most important law given was basically to avoid the black triangles. So in this, what does it say is if you are placing your implant coronoapically, so in that scenario, from the contact point or cervical region, it has to be between 3 to 5 mm. Only then you can avoid black triangles and you can have a better diagnosis profile. The orofacial lamination implant shoulder is positioned at least 1 mm parallel to the emergence of adjacent bone. So if you see this green zone, the implant has to be placed in this green zone. It should not be placed in this red zone, because that red zone is the danger zone. So what are the 10 keys to implant aesthetics? So I would always stress on these keys. The first one is the aesthetic risk assessment. So when we talk about EI, we have to talk about first thing, as soon as the patient comes into our clinic, what is the first thing we have to focus on? We have to focus on the patient's smile line. Whether the patient has a low smile line, a medium smile line, or a high smile line. A medium and low smile line patient can even be taken care of. But if the patient has a high smile line, the gingival show is so much that you have to be very careful while planning your prosthetic face. You have to go with either simplicity or OPG depending upon if it's a single unit, 2 unit case. I always prefer getting a CBCD extra done. But if it's a full mouth case, we always prefer getting an OPG done. The minimally traumatic tooth extraction is very, very important. We no more use the elevators or forceps with buccal and lingual movements. Rather, we use periodont's nullators to place our implant. If 3D implant placement, correct 3D implant placement is very, very narrower versus wider implant. Wherever possible, in case of NTS for a better images profile, we should be placing a narrower implant. Bone gap, bone graft, whenever there is jumping distance. So what is this jumping distance? The jumping distance is the space which is left after the placement of implant to the adjoining wall. So if it is less than 2 mm or 2 mm, we need not to graft that area. But if that jumping distance is more than 2 mm, it is always better to graft that area. Facial level grafting, if you feel the soft tissue, the patient has a thin soft tissue biotype, it is always better to plan for an FGC or a CT grafting to give bulk to a soft tissue, which in the longer run, and if you talk about the future perspective, you will have a better prognosis. Immediate control management, very, very, very important, especially in cases of aesthetics. Whenever you are planning to remove a tooth or extract a tooth, you can either go with the soft tissue technique where we preserve the bone, or we place our immediate implant and we take care of this control management, and then advanced prosthetics where we customize the impression coping, and the final restoration has to be a screw retail processes. So meet my first patient again. If you see, it's a low smile line case, and secondly, the zenith can be taken care of very easily. This is what CBCT shows. 1 month growth, and after endodontic treatment, you will see a career type pathology. We went ahead, opened up a flap, extracted the tooth. I would prefer placing my implant immediately, but we can see that the buccal diastance is so much that at least 3 to 4 threads of my implant would be exposed. We went ahead with the osteotomy side and osteodensification. This is the X-ray which shows my denser burrs and the side of my implant. I've connected a healing screw or general former onto the top of my implant. And then I started with my guided bone regeneration or GBR technique. This is the diet which I really use, or a collagen blade, which is by gastric bioguide. So first we stabilize the guide. We know at least 4 to 5 threads are exposed. Then first is always a layer of autograft, followed by a layer of xenograft, and then we cover up the side with the help of collagen, and then the final closure. Post that, we waited for at least 16 to 20 weeks of healing. This is after 16 to 20 weeks of healing. Then what you can see is the general format has been already placed in stage 1. So we need not to do any kind of stage 2 surgery, just to open up our implant. What we did was something like this. I started giving a temporary crown to my patient, wherein this first I removed the molar format with the help of scalpel and open up the crown, raise my buccal tissue, and with the help of my shed Next, opportunity taken to meet my patient at place, so he came to me with alien 2-1. Again, everything was advantage treated, motion code done, failed. So what we did was split the root, we split into the buccal palatal aspect, we removed the palatal part of the root, split the pulpus, she was repeat, we started the structural side, also densifying the side, placement of an implant is placed in the right feeding position and buckling. This is the gingiva after the clearing machine. So in socket sheet, we have to have a sheet which is around 1.5 mm. The gap has to be between 1 to 2 mm. So if the jumping distance is less than 4 mm, we not that is the final position of the implant. And the final result with the screw between two different points. This is the soft tissue architecture which we got after the crown. This is the kind of aesthetic what we are looking for. A factor which includes in plant placement, PET or a partial section, little amount of bone beyond the socket. The socket should be such that you should always have a palatal bone. Keeping distance will be more than 2 mm on the back side. Otherwise, you need not to drag the area. Facial bone thickness, it is generally 0.3 to 0.5 mm. So we need to preserve that. Next case, again we have done one more socket sheet. If you see the collapse by documentation, this is how the X-ray looks like. In CBCT, I still made a palatal approach and I can easily. So what we started splitting the root from into the buccal and palatal aspect. Remove the palatal part, buccal shield is there. We have prepared my shield. This is how the palatal root comes out to be. Towards that started placement. This is with my Gutmann and Dr. And then one. Goes at implant placement and final abutment, and then with the help of composite plug we are just plugging. So basically this is what the contour management can be. So it is not always important to give a temporary ground. Sometimes you can even give a composite iron so that you can easily manage the immediate contour for your final processes. Multi-unit abutment, which is our screw channel, which is a paradigm shift of implant processes. Mechanization area with aggregating grounds into anterior region, which came to me for anesthetic smile. We have removed the entire crown. This was the scenario. This is a CBCT and a panoramic view. Post that, we started with implant placement. I started with anterior placement, posterior placement, 5 implants, and this was after the placement. Here I lost one of the implants just because of periapical region. You can easily see from the examiner comparison. This is how the implant came off, and we removed this implant. We went ahead with 4 implants and for the processes. This is multi-unit abutment onto the top. These are the compression caps, or you can call these polishing caps, or these are the formulas. These are the multi-unit abutment which I have used. In the anterior region, it was 0.5 to 1 mm subgingival, whereas in the posterior region, it was equigingival or 0.5 mm supragingival. Started making impressions by splitting all my impression copings, my final impression with analogs, and this is for the lower ones, and this is the jig trial which we got from the lab. We did the jig trial in patient's mouth, post that processes. This is how it goes like. So these are the kind of processes we are looking from our lab, and the patient is completely happy and satisfied after getting these processes. This is how my final OPG looks like, everything in place, and bone is completely stable in all of my implants. All on and failing medication, sometimes we have a patient like these. The age of my patient was 24, juvenile aggressive periodontitis. So most of the doctors they even ask the patient to get a basal implants done on their few of them want to do a complete in a 23 years old patient. We went ahead and got the CBCT X-ray done. You can see his hardly moved the posterior region. There was no problem in the region. Went ahead, extraction. This is how we exposed the entire bone. Started with our implant placement. This is the Marlowe guide which we have placed. Post that implant place and PR implant at the closure. This was, we have placed 5 implants, 2 were taken from the mental foramen and a mandibular nerve, and the rest 3 were laser implants. This was after placement of multi-unit abutments and titanium cylinders. This is how it looks like, and temporary processes so that it was hygiene. It was given with the hygiene control, patient can easily clean these areas. Now still the patient has to come back for maxillary rehabilitation. This was just the mandibular rehabilitation now. And in this dual zone grafting control management, meet my patient Tanya. Now she had this particular tooth missing. And this contour management we started the patient has 1/4 missing and it comes in the smile line. This is how the C-shaped concavity looks like. And this is the CBCT scan of it. We got a guide for the pilot group. Post that we have started with the pilot group, then I opened up a 4 slab, densified my site with the Delta bursts, implant placements, and you can see this was the amount of concavity or C-shaped concavity which we did in the buccal zone. We started with decortication. There are two major purposes of decortication. We use number 8 numbers to decorticate those areas. Firstly, we want epigenesis. Secondly, mechanical anchorage of bone graft into the site. So decortication is a part of GBR. This is how we do it, and then we have used a membrane. Membrane again has two parts. One is the smooth part, the other one is the rough part. And the smooth part is always towards the soft tissue. The rough part is towards the bone. We started with GBR. We have first stabilized the membrane, place the graft, and I always overgraft my area. Placement of a membrane and stabilize the tissue. And then this is the result after 4 to 6 months. And then in the second stage surgery, you can easily see the emergence profile in this case and the final results. Guided implant placement case, I will show you edentulous maxilla, pre-operative pictures of my patient. We got the planning done from a prosthodontist and radiologist. Post that we went ahead for the stackable guide. It was a stackable bone level guide. This is how we do it, a 3D model. We do a mock surgery first. Started doing the guide surgery, patients open up a flap, full thickness flap. Post that we need a good full thickness flap. Post that we would be stabilizing the head of screws, which we use in bone care and bone management. So we are reflecting and placing the screws. This is what we do in our workshops in Delhi. We train upcoming dental surgeons in dental implants. So there are two phases: a foundation course in implantology, we have a surgical phase and a surgical phase. So I run a lot of workshop and India. We make the candidates, needs and needs stabilize and maintain. Thank you so much, guys. You will connect with me on social media by all these handles. Thank you so much, Cynodent and the organizing committee, for inviting me for this prestigious conference of yours. Thank you so much.
We shall now move forward to our next keynote lecture by Dr. Pinky Mathur. Unfortunately, she was not able to join us here physically, so it will be our online session. She is prosthodontics and implantologist, fellowship in maxillofacial prosthetics, Ajmer. We are delighted to host you, ma'am. Please give a big round of applause for ma'am. I request ITT to play the...
I'm Dr. Pavitra Rastogi. I am a maxillofacial prosthodontist, I'm an implantologist, and when I'm not working, I'm with children doing camps in schools or I'm doing camps in social work. And when I'm not doing all these things, I'm speaking at a lot of places, and I know a lot of those have been part of so many of. So let's start with today's topic, that is maxillofacial prosthetics or maxillofacial prosthodontics. Now all of us know that maxillofacial prosthodontics is something which is a part of dentistry but always untouched. So prosthodontics includes all these things, all of our we make crowns, bridges, we replace everything is missing. Are we really doing that everything? So I'm going to tell you people this, that replacement of these defects is also a part of dentistry which is a tangent to prosthodontics. So whenever you have a patient coming into your dental OPD who comes up with such a problem and has been referred by say a ortho surgeon to you for say whatever reason, the first thing goes into your head is that this patient also deserves to look good. This patient deserves to function normally. This patient deserves to appear human in every way. So here we have to discuss how we can help these people go ahead with their life smoothly even after battling cancer or say any other traumatic effects. So maxillofacial prosthodontics, as by far, that is something that we are going to help anatomic and functional cosmetic reconstruction by giving a lot of prosthetic parts. So you can find a definition in any of the books. So basically what we are going to do is we are going to use maxillofacial prosthesis to replace the missing part of these patients apart from what is also outside the mouth. So when we come about the aim, why am I doing maxillofacial prosthesis? Of course, for preservation of vestibular structure. Imagine your palate being cut off due to say some kind of ortho surgery, or you might have say cleft palate, cleft lip. You can just imagine the trauma and the type of functional shortcomings these patients go through because of all these things. So basically what we do with maxillofacial prosthesis is trying to get the patient back to the function. We're trying to improve the aesthetics of the patient, and we're also trying to preserve what is already being cut, a part of it, what is remaining. We want to keep the patient happy living with it ever after. Because when we come to meet a patient who has just been treated with ortho surgery, what we see is that ortho surgery jitna surgical part ho kar diya, and now what? The patient is not able to swallow, patient is not able to speak. So here is the part where we come to prosthesis in letting the patient get back to a normal life what it has already lost to say whatever pathological defect. So when I talk about maxillofacial prosthesis, we have different causes for oral tissue losses that we are going to replace. So there might be congenital causes like cleft palate, you might have traumatic causes, as I said, gunshot injuries. There might be pathological or which are radical surgeries, any kind of onco case or any kind of oncological pathology, and this results in two type of factors because whatever is missing or whatever is pathological is resected. So the resected part leaves behind defects. So these defects are the intraoral defect or extraoral defect. So now the defects are classified as maxillary, mandibular and tongue. When it comes to discussing of intraoral prosthesis, we are going to talk about a basic introduction of each of these factors. Then we have extraoral defects where we have facial prosthesis, nasal prosthesis, orbital, auricular. We have combination prosthesis. All of this is going to be discussed and you are going to be well versed with what a maxillofacial prosthodontic part of your dentistry can do. So coming down to intraoral prosthesis, when I talk about intraoral prosthesis, I talk about defects which are going to include your maxilla, your mandible and to some extent your tongue also. So when we talk about maxillary defects, we have again what I explained earlier, congenital, and we have acquired defects. Okay, so now we start with acquired defects. So most of the acquired defects, as I mentioned earlier, are due to surgical resection of tumors or due to trauma or whatever reason. Imagine that after the trauma or the tumor, you leave the patient with this kind of a defect, or you can say this kind of a big hole in the mouth, where the nose knows what is going on in the mouth knows what is going on in the nose. By this what I mean, जो मुंह से खाया नाक से निकाला, नाक से खाया मुंह से निकाला. Just imagine this patient living this kind of a life, and the patient not being able to speak, not being able to swallow. So most of the patients who come to me say that डॉक्टर साहब मेरे को कैंसर से बचा लिया, पर इससे भी कैसे बचूं, बिना खाए मैं कैसे जीऊं? Okay, so we as maxillary possibilities are going to come into picture and get these patients back to functioning. Okay, for example, you have a punctured car, you get the tires done, you get everything done, you get it fixed very nicely. But जब तक आप उस गाड़ी को चलाओगे नहीं, it's not going to be of any use to you. So we as a maxillary possibilities are going to help you चलाओ that car. So before I get into maxillary perspectives of the palate in detail first, because this is most of the things which you are going to encounter in your clinic, where the oncosurgeon will directly referral to a dentist for rehabilitation of the lost structure. So before we get into the picture, why is it important to restore? जहाँ काटा वहाँ छोड़ दो, restore क्यों करना है? So try to get into the anatomy part of it. Now here, as you can see, this is your hard palate, this is your soft palate, this is the pharynx, this is the oral cavity, and this is the nasal cavity here. So during function, when you are going to eat food, the food is going to be pushed with the help of the tongue into, say, your entire esophagus. So here what is going to happen, that your soft palate is going to raise due to whatever pressure and activation of the soft palate muscles, and it's going to touch your pharynx behind and block the regurgitation of food into your nose, and it's going to help swallow and push the food into your esophagus. At the same time, the epiglottis over here is going to become active so that it can close your trachea and it can it can avoid the food getting into your windpipe also. So here, as we talk about resection of defects of the hard palate, what we are doing, we are talking about some kind of say carcinoma or pathology here, because of which this part of the palate had to be resected. Okay, so now I hope you can easily visualize what I'm talking about. Imagine this entire part of the palate being rejected, resected. Now whatever you eat is going to go into your nose, whatever you're not going to be able to talk properly, because the resonating chamber, that is your mouth, this is the resonating chamber. When you try the air, the thrust of air which comes out from your larynx is going to resonate in your mouth, into your nose, and that is how we are able to speak. But now there is no seal of the chamber, because the portion where the seal was supposed to be found was resected. So here, by helping this patient rehabilitate to a normal life view, what are we doing? We are going to replace this area of the palate once again with the help of prosthesis. So coming back to my previous slide, so here again we have certain part of this palate area resected. The patient can't speak, the patient can't eat. So by trying to close the defect, what I mean is, by trying to seal back that defect, the patient is going to be able to eat everything properly. We are trying to break the barrier between the oropharynx and the nasopharynx, so the patient can swallow and speak properly during function. So basically, a maxillary defect requires the placement of an obturator for normal speech and swallowing. This is what an obturator is. So this is the basic concept. I basically believe whatever you do, you should know the reason behind it, so that it gives you the zeal and gives you the thrust to do that thing in a more technically correct way. So, obturator is something which is going to restore your oral nasal partition. As I just explained, this partition which has been resected because of the cancer is going to be resected. Because of the cancer, is going to be replaced again, or you can say sealed again with the help of the obturator prosthesis. What is the function of the obturator? As by far and damn sure we are talking about so many things here, very clear that it is used for the very important purpose, that is eating, so that whatever you are eating in the masticatory function does not have a contact with your nasopharynx. It can help to keep your wound area clean, because it is separating your oro and the nasopharynx again. It's going to help recon to the palatal structure, it's going to help recon to your speech, it's going to of course give you a lot of morale boost. Like imagine these patients, if you have met these cancer rehabilitated patients, or these patients who have undergone radical surgery, they are shy of drinking water in public, going out in public, they are so much mucus discharge everywhere. So just imagine these people getting back to normal life normally even in their social lives. So now there are three phases of treatment when we talk about an obturator. You have an immediate obturator, you have a definitive obturator, and you have a temporary obturator. We will see each of these in detail, and I want you all to be so thorough with the concept that you know that what a maxillary prosthodontist does, and to some extent you can apply, you can also do maxillary prosthodontics on your level. So, the first part is the surgical obturator. Now, what a surgical obturator is? Now, when a patient comes to you for say, or to an onco surgeon or to open surgeon for resection of a particular part of the defect, say, defect of the palate, had to be resected. So, now, what we do is, before the surgery is planned, we make impressions for the defect, we mark the area of this defect, and we make a plate for this area, which is again inserted into the patient's mouth during the surgery itself. So what happens is, as soon as the patient is out of his general anesthesia, he can at least get back to his normal swallowing, speaking, drinking of fluids, water, and he is not disappointed at the very first time where Jesse surgery doing his orodasal and his oropharynx and nasopharynx confidence started, and he's already demotivated, he starts using a lot of oral. So placing a surgical obturator just before the surgery plays a great role in getting the patient back to his function. So now we have surgical obturators for hard and soft palate. Let me be very clear, when we talk about surgical obturator, it is just a plate, you do not extend into the defect. So here it's a small preclinical activity picture that I have put here. For example, this is an ideal task. Imagine a area to be resected because of cancer. So what you are going to do is make a plate for this area. What you can see here is the plate, and then you make a putty index for this area. Once you make a putty index, now in this case this was possible because most of the structures were normal, say normal here, or for example you have most of the structures leaving here. Once you make the index, you place this made plate in the index and you cut the resection part planned on the cast. Now, once you remove this resected part, place a cast again into the index, remove whatever area you don't plan to keep after the surgical resection, and build that area again with acrylic. So now what you get, what is in your hand is, you have a plate which is ready, which can be placed in the patient's mouth of the same structure, of the same measurements, which can be placed post-surgery. Now, because this is from a preclinical activity book, teeth have been placed here, but we suggest do not place teeth or do not place any kind of occlusion load on a surgical obturator because this is going to cause friction, this is going to delay healing. So we generally do not suggest going in with teeth for say surgical obturators. We just plan for plain plates. For example, now this is an example of a clinical case where you can see that this entire portion is planned for resection, say for whatever reason, and now after resection of this part and scraping of this part, we make a clear acrylic plate here which is placed in the patient's mouth during surgery so that the patient can come back to function and doesn't have to stay with that hole there. So advantages, as I am explaining, you already getting clear with it. Normal speech, eating habits, they are going to prevent collapse of the tissue, facial symmetry is going to be maintained, and of course mental well-being. The psychological part plays a very role in such patients. So this is one of the cases where we had a patient presented to me by onco surgeon for the resection of this individual mycotic lesion. And I made a plate for this and I sent it back. Not much was done to be done. Another case here which we can see is this patient had a resistive lesion of the palate. Again, this case was sent. We resected this part from here and then we placed a acrylic plate which was sent to the surgeon, which he placed intraorally after the surgery or after the resection. So now the next part coming to me, we spoke about the hard palate. Now we will talk about the soft palate also, because as I explained earlier, soft palate is that barrier which is going to help in deglutition, is going to help in speech by causing the barrier so that the food is not pushed into the nasopharynx, and also at the same time the food can easily enter into your digestive system, to the esophagus, and not run here and there because of this unwanted pathological or you say post-surgical use. So in this, before I get to this, I will explain to you a small concept again because it's easier to go ahead with concepts. So here what we see is, again I am the same palate which I explained about the soft palate and the hard palate. Now imagine this part from the other view. Now over here you can see this is the soft palate structure here. Here you have the hard palate, here you have the soft palate, you have the muscular sphincter here, and over here you have your pharyngeal walls and you have your pharyngeal muscles. So now what is going to happen during speech or there has to be a point. This area is going to be elevated and going to touch your posterior pharynx. At the same time, your lateral pharyngeal walls are going to come closer to this area to form the complete seal. This will be more clear to you from this diagram. Now you can see what is happening in the soft palate during the mastication and during the speech process. Now for example, in the mastication process, your tongue is being thrust upwards, and during the swallowing, the muscles are pushing this and touching the posterior pharyngeal wall. Okay, now what the same thing what we observe, now observe the same scenario that the posterior pharyngeal wall has been touched here, and from the other two sides we are having the lateral pharyngeal muscles which are going to come and attach and going to form the complete seal. So now the problem comes here when we are supposed to replicate the same things on the soft palate before the surgery. So what I mean here is that you have to plan a very good way so that the lateral pharyngeal walls can touch this area, form the seal, and you can easily execute the functions. So what do is we make a basic surgical obturator, and the relining is done with the help of temporary denture reliner in the patient's mouth with the help of functions itself. What you can see here, see how well the relining material has relined with in function, and it is in contact with the lateral pharyngeal walls as well as with the posterior border of the pharynx. So this is what is the surgical obturator for what we call as a soft palate. Now, delayed surgical obturators. These were all the immediate ones which you placed in the surgical room, and now there are some cases where, because of say whatever reason, either your surgeon doesn't want a surgical plate, or the patient is not able to reach you in time, or the surgeon is not able to reach you in time. So over here we have certain defects which are open defects, but they are still in the delayed phase. So what do is, we go and make a surgical plate obturators for this patient again, so the healing also takes place and the obturator can do its role of separating the oral and the nasal part. So over here, what you can see, one of my cases where this patient was referred to me later after the surgery. So even though we got beautiful impressions of the defect, which you can see here, we have got this beautiful extensions and we have got a very good recording of the defect was, but we were just instructed to go in with a surgical plate because this patient's healing had not taken place. So we couldn't give an obturator to the patient. It's very important if we go into the defective obturator, the healing of the entire defect has to take place. So then we made very simple, we blocked this out of wax, and we made very simple medium obturator for this patient. Again, another case of a delayed surgical obturator from an article where a surgical obturator was relined with certain relining material and it was only used as a medium obturator. Now, why a delayed surgical obturator is a little important, and why is it converted into an interim obturator? Now, when the healing of this defect is going to take place, after a certain time there is going to be collapsing of the tissues, because the healing is going to take place and the tissues are going to be collapsing all the time, and sometimes it becomes so narrow that it is practically impossible to restore these defects to function, and it is impossible to restore these defects prosthetically. So what do I mean by using an obturator, interim obturator in these cases? Function, definitely important, but it also prevents collapsing of these tissues a bit too much, and it helps in nice healing and a nice contour so that we can prosthetically give a good functional tissue to the prosthesis. So interim obturator is given 7 to 10 days after, as we have already discussed about this, and the relining of the prosthesis will take about from say 6 to 1 year, because 6 months to 1 year, because they say that the healing keeps on taking place. There are tissue changes for a year in this patient, because say whatever reason, because most of the patients have also undergone a lot of chemotherapies and a lot of radiation therapies. So the healing also has different roles in these patients. So we suggest going for a definitive after a year. So here in this, an interim obturator is molded with the help of Vinci. Now this is another case where we have seen that this patient was again referred to after surgical resection. Now here we can see that the epithelium is not completely, here there was a skin graft lining done, and here we can see that certain epithelial healing is still taking place. So this patient was not very comfortable with this area, because it was constantly being inflamed. Whatever food he was eating and whatever surgical obturator we had given him had to be discarded because it had started moving into the defect. So we gave him a very simple prosthesis. He could eat very well with it. The prosthesis was healed, and as and when the healing took place, and then he was converted to definitive case after a year. But he was quite happy with the function because he could masticate, speak, drink water normally. Now we go to definitive obturators. So definitive obturators is a big challenge. Converting this into a definitive prosthesis, definitively it's going to stay with the patient for a lot of time. It's going to be something on which the patient is going to be relying on. It's going to be like you say the crutches for the patient lifelong to have the functions executed very normally. So here you get a lot of say concepts, a lot of technicalities, and you need a lot of say patience also for the patient, because here a lot of changes have taken place and you have to execute a lot of things and a lot of challenges which you have to do. Now the most important thing is multiple axis of rotation. I am very sure all of you are very well versed with transpartial lectures or have an idea about it for sure. Now when we talk about axis of rotation, say for example this kind of a defect. Now this area is a defect area. So there are going to be like 3 major axes of rotation which a prosthesis has to overcome to be stable in the patient's mouth. Now because the defect area is going to be so big, they are going to have very little parallel coverage for stability. Of course, because pattern structures are not there, but they say that if the pre-maxillary area on the defect side is concerned, it is a better prosthesis, it is a better case for a better prognostic replacement. But unfortunately, for cases like this, where you can see some midline defect, most of the pre-maxillary part has been resected. So, the movement of the prosthesis is going to take place along this axis, where the prosthesis is going to keep moving into the defect. This picture will make it very clear for you. Now, if you can see in this case, there will be significant movement of the prosthesis into the defect on occlusion, because the fulcrum line is somewhat going to be passing through this area over here, and the prosthesis is going to keep moving in the defect, out of the defect, and also there is going to be a role of gravity. But somehow, we are going to discuss how to overcome these things. Okay, so of course there is going to be an axis of rotation passing through both the rest of the apartment. There is going to be an axis of rotation passing through the distal post apartment. Why? Because when the patient will masticate on the posterior teeth, definitely the prosthesis is going to try to move on the behind part, but this area of axis of rotation can definitely be there. Now, talking about the next part, which is very important, is about the compromised stability, retention and support. Of course, on the defect side, you cannot expect any kind of, retention naturally, so you have to go into the defect, which I will be explaining, and get that support for your stability of the prosthesis. Definitely, with the help of guide plates and good retentive undercuts on the remaining teeth side or on the residual palate side, you can get good kind of retention, different retention, say implants or adhesives. So, when I talk about the diagnostic factors, what you have to keep in mind when you see an obturator success. So, the first and the most important thing, you have a patient here and you have the defect here. Just imagine there is a defect, just to visualize this obturator here. Think it is a normal open defect. For example, it looks something like this. So, you have a defect here and you have to replace it for the patient. Now, what you can see here very clearly is a lining of a skin graft. If you have a very well lined skin graft, a very well lined clean skin graft, you will be having super prognosis of this patient, because the lining grafts are very stable than an epithelial graft, because the lining graft is going to be so good on which the prosthesis can very nicely heal and the prosthesis very nicely rest on this one. Plus, you are going to have a small junction between the skin graft, which is going to be lying here in the defect, and the mucosal portion. By this, what I mean is, again, coming to this slide, you can see this part here, you can see the mucosal portion here, you can see the interdefect area, so you are going to have a small undercut here. So, this is also going to be very useful to you for replacing the prosthesis. Apart from this, the lateral wall has to be taken into consideration. You have to extend it as much as you like. The lateral wall is going to help you in retention earlier. Okay, and then you are going to have a small extension of the nasal aperture, not too much extension, because it's going to interfere with the breathing of the patient. Okay, and apart from this, on the other side, as I said, the normal side, you can use the extra you can use good amount of say glass, or you can use very concentrated implants for retention as apartment. So now looking at a good obturator prosthesis, a nice one which is being made, an ideal prosthesis, what you should look for. Now you should see a very well vertically extended prosthesis laterally into the defect, not medially, because it is going to cause interference with the defect. So we have to rely the prosthesis on the lateral lining of the defect. Apart from this, you can see there is a good impression of the base of the skull, that is very well in contact with the base of the skull, the remnant area after surgery, what was left here, it can be very well seen. Apart from this, there are pharyngeal muscles very well so that all the functions can be executed very well. And the soft palate is very important to be very, you can say, very technique sensitive and to be very compatible with your obturator. Of course, you should see a good amount of vertical extension in your lateral border, which can be seen. You should have a good amount of base of the skull contact. Okay, so all these things are very important for a complete obturator outcome. Another important thing, you have to be able to record a nice lateral movement of the radius of the mandible on the lateral part. By this, what I mean is, over here, somewhere on the lateral part of the obturator, a good impression of the movement of the radius of the mandible should be recorded. Plus, a very important concept that everybody talks about the bulge of the obturator. Now, what a bulge, what I mean, if you can see this over here, this is an open part. It's going to go into your defect. This is as it is going to go into your defect. Now, you can see this is open here. It is quite concave and it is open here. This is an open bulb obturator. This area is called as the bulb. The area which goes into defect is your bulb of the obturator. So, you can see this area is an open area. This is an open bulb obturator. If this area was covered with acrylic or with silicone, so for whatever reason, it would have been a closed bulb obturator. Now, why is an open bulb obturator better? Of course, it is going to reduce that weight of the acrylic. And first and foremost, we are also tense fighting with the force of gravity, axis of rotation, and plus you have a heavier obturator, so it's always going to keep falling. So all your other principles are not going to work that well. So what you're going to do in this case is, you're going to give an open bulb obturator if possible. Second advantage, whatever mucosal secretions are going to be collected into this obturator bulb can be easily cleaned by the patient whenever the patient wants it, and it's going to be a very hygiene maintaining kind of process, and weight of the prosthesis is already going to give patient that confidence. So another important part, very small concept, a very small retentive feature which is included the obturator and is going to give you this good support and retention is going to be this little extension in the nasal part of the soft palate. What you can see, this is the obturator prosthesis. This prosthesis is extended a little bit onto your soft palate area. Okay, this area is soft palate is relaxed. But also, little bit part of the obturator is onto your soft palate of the nasal part. This is the nasal part and the soft palate here. So, little bit of extension is onto the soft palate. So, here you are again getting an undercut. Plus, what's happening when the patient is speaking or when the patient is swallowing, this part is going and becoming activated, and the seal is formed here. Now, once the seal is formed here, it is going to again enhance your mastication. There will be no chance of leakage whatsoever from this area also. So, when you experience the diagram, can you appreciate the same thing? This little part is going to go into your nasal portion. This is going to be the obturator, and this little part is going to be extended over the soft palate, and this is going to act in protection. It is going to, be very helpful in trying to block those slight leakage of fluids here and there. So the cleansing procedures of obturator is going to be, you make an impression for a RPD framework, you make impression of alginates or polysiloxane materials. After this, you make a framework first for the cast with all the principles of your cast partial denture. You do bottom molding in that area, you bottom mold that area with the low freezing compound because the flow of this working time is very good and the flow is very good of this low freezing compound. Now, next is you take wash impression with the help of polysulfide materials. Now, just keep in mind that this impression has to be minimally displaceable. Like, try to scrape enough from your initial material which you have made for an impression and make it a very passive impression. If it is an active impression, it is going to really trouble you with a lot of irritation of the tissue, and the patient is not going to be able to wear the prosthesis because healing in the defect is really slow than the other areas of the prosthesis. So, to check whether this is an active or a passive prosthesis, we can use thermoplastic wax, and the areas where the wax is exposed, we know that the area has to be trimmed and recorded again, and it is a passive. Now, when we talk about a complete prosthesis, with all the concepts and with all the basics that I have applied till now, an obturator prosthesis becomes very successful, and using it for the patient becomes much more easier if it is made with some little bit of technical aspects here and there. So again, once the prosthesis is made, identify whether the prosthesis is a passive or an active. We use pressure indicating paste. For example, if the patient has an occluded salivary gland because of the chemotherapy what is gone through, then you can use disclosing bags to determine these areas. So this is how your disclosing bag should look. You have no active areas, no exposures, and you have a uniform thickness, so you know that this is a passive prosthesis. So now obturators of the nasopharynx, why when you have to extend it into the nasopharynx. So again come back to the same thing where a big part of the palate has been dissected. So in these cases, imagine how the patient is going to speak, talk, because so what we are going to do with the nasopharynx defect is we are going to replace this part. We are going to replace this part so that the nasopharynx, the oropharynx is going to be separated. So what do? Is we just make a simple extension onto your impression materials so that you can record this area very well. Now once these extensions are made, as I explained earlier, it is going to be very clear with this what we aim by making obturators in this area or of the soft palate is that during function, this lateral pharyngeal wall is going to contact this area and whereas the posterior pharyngeal wall is going to contact this area. So it's going to be a total seal because of which the patient is going to be able to swallow and the fluid is not going to escape or leak into the nose, or this area is going to be active only during function. Remember, this area should not be in contact all the time. It should be in contact only during function. So we record it in such an area that these muscles give the functional recordings here at these borders. So what will happen with this? Two things. One, the patient can very well eat whatever he wants, swallowing will be a problem. Speech will be effective because certain kind of plosive sounds, certain kind of nasal sounds can easily be done when the patient wants certain gap or certain air flush into the nose for certain sounds like N and G. There the patient will be very easily having this gap where he can easily speak because this is a passive prosthesis. It will be active when only when you swallow or you thrust when these pharyngeal walls or these lateral walls will be active. So here what we do is we bottom hold this area. Now how do you bottom hold this area? You tell the patient to do all the activities, you tell the patient to swallow, you tell the patient to speak certain words, you tell the patient to put the head down, you tell the patient to rotate the head so that this area is recorded. Now for an ideal impression you will see that, and you can make a final impression with any kind of disclosing match. What you can see that over here is that this area height should be at least 10 to 15 mm into the nasopharynx so that the blockage takes place and nicely the patient can execute this function. So here is one of the cases where I have taken this from one of the articles where this has been replaced with the help of the prosthesis. Now you can see very well that during function these pharyngeal muscles are in contact and there is a small area that is the you can call it the passage bridge, which of the pharynx is in contact with the posterior wall and the entire scene is completed and the patient can eat, drink and speak very well. Now also another article says that this defect changes shape and size with time, and here you can see that a patient who had an obturator of this size when remade came with an obturator of this size. So muscles also keep adapting all the time to your patients so that the changes can take place. So secondly, when you make these obturators for the nasopharynx, it should be kept in mind that these obturator surfaces should be concave, not convex. If they are convex, it's going to irritate the dorsum of the tongue and the patient is going to be gagging all the time and swallowing is also going to be a little difficult. So further, as I said that for retentive purposes, if you do not have enough structure or you don't have enough teeth, you can go in and you're lucky enough to have a good pre-maxillary bone left, you can go in with implants once a good time after radiation is completed. So you can go into implants or prosthesis, and as I said that the most difference are defects where the pre-maxilla has been considered during surgeries, so the patient can easily go in with caution with implants for better retentive gains. Now, meatal obturators, these obturators are obturators now where it is a part of the major sinus complex area. Now, when I talk about this part of my obturator, say in an dental restoration, this part is also covering the posterior part of the nose. Say it is between, now see this diagram between the nasal. Now, this is the nasopharynx, cavity. This is your soft palate. Doing functional soft palate as the pharynx. Now, because of the whatever the section was in terms of the dental restoration, the inserted into the prosthetic inserted into the nasal pharynx over here. Okay, this is the distal aspect of the maxillary prosthesis. Now, what you can see here that two important parts is we need two small holes in this prosthesis. Why two small holes? Because concave is something which increases the surface area of your nasal cavity and those concaves. So, by making these concaves, you are going to somewhere, remove this concave, proceed to the concave, you are going to interfere with the airflow and the nasal breathing pattern. So, you need these two holes so that your oropharyngeal breathing is not interfered with these spaces. So the next part is consonantal defect. Consonantal defect is something which is a little bit difficult and different from that what say acquired defect is, because here the prosthodontist has a very bare minimum goal. Mostly it is either for the replacement of the prosthetic part completely once the entire surgical orthodontic part is done. So the cleft palate is seen as a membrane defect, layer on the palate. All of us are very well versed with it. So the treatments of the cleft lip and the cleft palate, you have made a lot of treatment to go over to the entire body. Okay, so treatment can involve the team of professionals, orthodontists, surgeons, pediatricians, oral surgeons, a lot of people who are doing the prosthodontist also. I will just go directly to the video of what a prosthodontist is going to do. So the first thing is something called the nasal-angular molding appliance. So it's going to be a hell of a task making impression for the referee who's already so troubled with what's happening. Everyone's using this coming out of the nose, he's not able to speak, not able to swallow. So somewhat we try to make the impression of the silicone cutting away. We pour a cast out of it. Once the cast is poured, we actively create a cut and which has recently been cured, and it has a small extension over here. Now, what is the use of this prosthesis? What do we do is, we place this in the mouth, we place bands on both the sides, we have bands which are tied to the prosthesis. So now these bands are going to pull the prosthesis from both the sides like this. So this side is going to be attached, banded here, this side is going to be banded here. So now when these muscles and there will be excess pressure from outside like this, the palatal bone is going to grow at a greater speed and it's trying to join or fuse at the palatal. Apart from it, there is also something you can see that because the allogramm in these patients are collapsed a lot of time. So here there is a small part which is going to be a nasal extension, which is going to push that nasal muscle so that the aperture is also made intact. This is what happens as and when the bleeding takes place. This is what happens with this patient. And if, for example, it's a bilateral defect, you can make two apertures and you can make two extensions for the patient so that it can easily be done for both the sides. So the last part of the occlusive is part here is speech aid prosthesis. Now all of you are so well versed with the anatomy and function. I repeated a lot of times during this presentation itself. So we have two problems. One is where the dissection has taken place. What do we do with this problem? Where you can say it's a neuromuscular problem or it is a problem which was say a congenital issue. So here we have two problems. One is the veopharyngeal competence and we have the veopharyngeal insufficiency. So what is an incompetence? Now for example in certain patients the soft palate is paralyzed, say for whatever reason. So this is not going to get elevated during functions. So the patient is going to go through a lot of problems. Similarly, in the insufficiency cases, this had not grown till its entire length what it was supposed to do. So again, the patient has that problem. So in these cases, how we discuss of the meandral obturators, a small extension can go into the nasal pharynx and do whatever help it can. And apart from this, in incontinent patients, we do something called as the palatal lift prosthesis, or we do something that's called as speech aid prosthesis. So what's going to happen in that? A prosthesis which is going to help you elevate this muscle and reach it. So it's going to help in function because it's going to help you elevate this paralyzed muscle. Now you cannot give a speech aid prosthesis in all patients. Now there are certain patients in which this muscle is partially active. In those cases, it's going to be very rigid. It is going to keep cause the patient a little bit of gag because it's going to keep pushing the prosthesis, touching the dorsal part of the tongue, the patient is going to gag. So before doing that, test this muscle with the help of a mouth mirror. If it is completely say lifeless or it is completely mobile, go in for the once the palate is lifted from this area, over here it is lifted to this portion here, and the patient gets again to that barrier between the nose and the mouth, and the nasopharynx, oropharynx, and the patient starts eating again. Come down to the mandibular defects. Now the mandibular defects are going to be, say, for whatever reasons, maybe it is any kind of carcinoma, any of the foot of the mouth or the tongue. So very basic procedures are made for the mandible. We make guiding flanges because once a resection or hemimandiblectomy has taken place, the muscles cause this huge problem. Twistiness is one problem, and your muscles try to pull your entire lower mandible to the side of the defect because of extra contraction or with extra weight. So because of this, we try to get it onto the other side so that the mastication of the patient is possible with the help of parallel extensions of these guiding flanges. You have wide parallel ramps, say the lower cannot come, the mandible cannot come completely to occlusion. So we try to extend the occlusion in which the patient can at least masticate on this ramp. We have mandibular guiding flanges which can help pull the mandible and keep it occlusion towards the non-resected side. Now, one of this case which I have also published in one of the journals, this patient came to me, and this patient was still having a very compromised maxillary area. So this area was resected also for the patient. This is the X-ray of the hemimandiblectomy that had taken place in the patient. You can see here that I cannot use too much of guiding flange here because already this area has so much compromised process that the chemotherapy just over say 7 or 8 months. I cannot afford losing my teeth to avoid osteoarthritis. So what I did is I tried to make an internal prosthesis and I gave a good groove here where the upper teeth could come and rest into the groove, and this itself acted as a guiding prosthesis. Now you can see a very good change here where somewhat the deviation of the mandible could have overcome because of this reason. So this is without the prosthesis, this is just with the prosthesis. You can see how well the patient has corrected on the deviation part, and I have published this article again in International Journal of Case Reports. So this is another case where a hemimandiblectomy had taken place for this patient. Again the same problem, that the defect was going towards the resected side, the mandible was very limited towards the resected side. So what we did is we made a small extension here so that it could be locked here, your mandible could be locked here, and it would the muscles would get accustomed to stay in this position eventually. This acted as physiotherapy also for this patient. Again, we have tongue prosthesis in certain areas where the tongue also has to be resected. Say, for example, the entire tongue. What does this patient do next? He can't eat, he can't swallow, he can't speak. So what we do is try to somewhat make something which can act like a tongue. Because we cannot make a mobile machine, of course, but we can make something which can help with the barrier method. We can make these grooves here so that this can be entered into the mouth. We try to make this area so that this can be pressed against the palate to help in swallowing when the mandible moves. Apart from this, we can also help in patient hearing and speech because of the tongue and the prosthetic part touching the palate. The resolution is better, the patient can speak a lot of words, and then after this, we can see that the patient is highly motivated because the nurse is good. So, the mandibular defects, the maxillary defects, and the tongue prosthesis were very exhausting, and now the part which is more of say cosmetic part comes into it. Now we go to extra-oral defects. So the extra-oral defect, we will directly go to what it exists. The first thing is the ear prosthesis. Yes, ear prosthesis does come in manifestation prosthetics, and this is the place where you can see the cosmetic surgeon, the often says that hey, doctor, I'm not able to get that tissue to keep collapsing, the ear that I consider keep collapsing. They do something with the cosmetic part of it, and here a manifestation prosthetist comes into play. So what do? Is we have cases like this where you have a part of the ear collapsed or resected, you have congenital missing, you have bilateral missing part of the ear. This is somewhat unfavorable defect because on a mobile tissue, the processes can never stay. So what do we actually want when we want to work on a prosthesis where we can replace the ear? We generally look for cases as a manifestly prosthodontist when we see that the tragus is staying there, or we have the tragus there in that area after the surgical resection. Why simple? Because the margin of the prosthesis is going to hide behind and apart from that, the trace is going to help you hide the anterior margin of the prosthesis and going to make it look more natural. We generally want that this defect area is lined with a skin graft if the ear was surgically removed for say any kind of reasons. So this is the reason why we want a skin graft, because if it is a nice skin graft, you know that infection will be easily maintained and we can use good amount of adhesives in this area. So this is one of my cases where we had a contact with a oral surgeon or an orthosurgeon and a cosmetic surgeon who were in the team, and the cosmetic surgeon tried to build some skull genetically missing here. So I just followed the picture. Now this patient had already done 7 types of surgeries. I was not very happy with the aesthetic part because this kind of ear was lower than this ear, but I advised the patient to get rid of this part so that it become a more symmetrical prosthesis. But she was already so bored with so many incisions and so many surgeries that she didn't want to go, and she said, go ahead, yes, I see the benefit. So we went ahead with this case. We made impressions for this case. After making impressions, we made molds, a 3-piece mold, and we tried to carve the ear onto this. Once the ear was carved, we did a drying. As I said, I was not very happy with the margins because this was at a lower level, but we couldn't help it. We tried not to cover this area, but it didn't look that good, and the prosthesis kept bumping on this issue. So we tried to get an undercut from this area for this patient. Now, after this was done, we manipulated the silicone material and we fabricated the silicone material. Now, there are a lot of methods how we do it. You can either do an injection molding technique into it, and then you can polymerize it so that it gives you excellent details. A lot of coloring methods are there. Some are extrinsic, some are intrinsic colors. Extrinsic colors are better because you can duplicate them very well. And then you have coloration of different types, like the help of shade lights. You can try to get them beautiful and artistic, and then you can do a little bit of deglossing so that it gives you a more natural look. So this is how we retrieved the prosthesis. We did a bit of trial on her, and this is how it looked for the patient. And I tried to put that little earring there that I can somewhat overcome the level, and the patient was very happy because she was happy to see that she has ear, and on the other side also she can wear a earring nicely on the other side also, and she can tie her hair behind also because she's kept opening it on one side to hide the hair. This is how the patient looked, and I tried to hide this margin because whenever I tried to extend my prosthesis to this area, it kept bumping up from the patient, so I tried to hide it at this margin. So with the help of the earring part, I tried to hide the margin of the prosthesis and do adhesive prosthesis. Nowadays, CAD/CAM prosthesis are coming in a lot for this because you have 3D prototyping and you have CAD/CAMs where because of 3D prototyping, your prosthesis is almost ready. You don't have to do so much technical aspect of it. And if it comes to you for sculpting, it is very easy. Divide it into different square areas and try to replicate that in your wax pattern. You will be easily able to do that. For example, see this small area. It's so easy to replicate this area exactly in this area. Rather than see it as a whole, it will be difficult to replicate this area. So divide it into equal compartments so that you can replicate that particular compartment in that particular area. So now coming to margin placement, very important. If you have a tragus below, it's very good. You can hide it behind the tragus and you will be so happy aesthetically that you will identify whether it is a prosthesis or a natural. If you don't have a tragus, simple thin the borders so that you can blend into the skin very easily. The skin does not bounce out like it was happening in my case. Blend it very thin on the skin so that it again doesn't look like mediate the adhesives. So these are some partial ear defects, small ear defects which are again engaged. Again, as I said that if you have partial defects, it is not at all favorable. But I have this of an article where we have been very successfully able to replace it with the help of aesthetic, with the help of adhesives. So also if retention is an issue and the ear prosthesis keeps falling off, you have the adhesive. There is something called as cochlear implants which are coming into being a lot, and you can put it into the mastoid processor. The only thing is that try to keep that area clean, expand the patient area should be clean. Otherwise, periimplantitis develops here in this area which can cause problem, and then you can have all the other problems. The patient will keep complaining of irritation and not hair prosthesis. Coming down to the Now we have two kind of prosthesis for your eye. Now till you can replace an eye, you replace an eye, but it's no more the time where people roam like those pirates and wear that one eye covered. So it's the time where a prosthodontist comes and gives you those eye part over there. You don't have to hide, you don't have to hide, you at least look cosmetically good. So coming to the orbital defect, again we want all the defects to be lined with good skin grafts. We don't want you to retain the eyelids without any use of the eyelids and just want to convert the because any mobilization is not going to let the prosthesis sit on there. We talk about dentures, always cause problem when movement in the prosthesis. So when you talk about orbital prosthesis, what we want is a nicely lined defect. We want eyelids, if possible, the eyebrows should be retained to some extent, but it's okay. This kind of defect is kind of accidental defects like this, where the eyelids have been preserved. It is not possible because you can see here it's not possible to replace the defect at all because inside the socket there is no place on the orbital area. I cannot replace because the eyelid is going to be removed and pushing the defects out. Further, you can see in this case also we don't have enough area for the orbital prosthesis to rest on. So we need a perfectly lined defect and we need a perfectly lined made defect. If possible, ask your surgeon to do those corrections in the patient back if the patient agrees to it. So coming down to impressions, so nice orbital defect, place your impression material, place walls on it, place some adhesive, put plaster on it, so you will be having a whole mold over here. It's going to look somewhat like this. Now in this area, what you're going to do is just place your this is about 3D printing. Yeah, what you're going to do is just place an eyelid with ready-made eyeballs. You get those prosthetic eyeballs at a lot of places. Take those eyeballs, place it in your socket, do some wax off and do some nice wax off which is going to give and look similar to the skin around it. Once you do the wax off, see the wax off from different areas. Try to center the eyeball with the help of the other prostheses. Do your nice glasses if you want to hide the margin of the prosthesis. Try how it looks with the glasses also. Now after this, try to see from different angles. If you are very artistic, if you can set up a good lab, you have to do these very nice lines and very nice effects. After this, you can go and look at the orbital folds, show it to your patient, go ahead with the flasking part, add your silicone material to the part around it. Once you deflast you add the silicone material around it. Once you add the silicone material and your eye prosthesis is ready, you place your eyelids in those areas and your patient is ready to go. There is amazing prosthesis. Now what I skipped now on the slide behind. Yeah, here. Nowadays you have again maxillopatient prosthodontics coming up with CAD/CAM a lot, where you just scan your optical impression and you directly get your prosthesis out, or you can get your cars with the help of these CAD/CAM models. So 3D printing developing in India. If it develops, maxillopatient prosthesis is going to have a boom for these patients because it's going to be really easy and it will be less technical sensitive. Okay, so for further say retention, you can even go for orbital implants. It is mostly placed in the supraorbital bones because they say that it has good periostal blood supply. So here is the case. The only thing is that maintaining the thing is very important. You don't have to end up getting those peri-implantitis in those areas. Cleanliness is maintained is very important. There is another kind of implant which are placed in the socket. Everything is enucleated. It is placed at the time of surgery behind the ocular content. Okay, and this area is sealed. It's just a little bit of extra knowledge. Something just come up very well. And you have a porous polyethylene orbital implant which is placed into that socket. Once that placed in the socket, you have this small nail kind of magnetic attachment on which your orbital prosthesis is going to attach. This is done very rarely, but something which has come up and is going on since a lot of time. Coming to ocular prosthesis now, in orbital prosthesis, the entire content was gone. In ocular prosthesis, you have the eyelids and you have just the enucleation of the socket that was done. So now this was a patient who was referred to us and he had severe inflammation with the old prosthesis. So in this patient, with talking to the ophthalmologist and talking to surgeons, they said you can go ahead and control the inflammation medicines, and he already had the patient when he was ready for the eye procedure. So he had been very little cut a lot of time. We made impressions with a very, very simple technique with the help of, say, the syringe cover, and we placed the made the impressions with the help of nice alginate, and after that we made trays and we molded this area very well. We got the cast done. After getting the cast done and after doing the centering and everything, we got a very nice eye prosthesis which is readily available with the borders with the help of the cast. With the help of the cast with the borders and we did the placement, and then this is how the patient looked when we gave the patient the prosthesis. Okay, so the nasal prosthesis, of course, we have nasal defects also. Nose prosthesis is also part of manipulation prosthodontics. You replace the nose, you have to just keep in mind that keep in mind these areas, you have to keep in mind the area of the, say, above the filtrum, the column of the nose should be very well, the alar of the nose should be designed very well, and a person should hide behind this area. Some basic principles, and you can go very well with manipulation prosthesis. You have staining, which is very important because you want to catch the eye of the person who will look at you. We also have integrated implants for good retention, like you have this area, you can place it either in the nose or the retina, and you can retain your prosthesis. So again, we have the combined nasal prosthesis and cheek prosthesis, where you have the obturator with the nose, or you have the obturator with, say, the entire communication prosthesis. These are all different types of manipulation prosthodontics. We even have areas where you also replace fingers, which is to some extent done, because I remember doing a finger case in my college, but after that in my practice not preferred. So custom fitted silicone prosthetic devices are nowadays made by a lot of people, and manipulation prosthodontists do it to some extent. You have mid-facial defects, maybe it's a gunshot injury to this patient, again from an article, a big kind of a defect, and this entire defect was replaced. A lot of work was done to this patient, which I referred to the article. The work was done with the help of on the nose part, it was done on the obturator front, the teeth were replaced for the patient, and it was given the patient in. In short, materials that we use for doing all these things, we use acrylics, polyurethanes, and silicone elastomers. We have materials. Everybody is coming up with the research on materials, but just keep it simple. What you should do is, if I am getting a prosthesis, it is acrylics, polyurethane, silicone, or elastomers. You have retention aids. We have discussed all of them with wires, glass, with buttons, adhesive, magnetics, with implants. We have different kind of attachments which can be used for retention, because retention is a challenge. Now also in cases we can even go for retention with glasses. Imagine how well a nose prosthesis is going to sit there with the help of glasses, and eye prosthesis on an unfavorable defect with the glasses. Adhesive, as I said, plays a very big role in this. You have magnetic attachments where if you have a facial defect and you have an obturator, so what you can do is a magnetic attachment with the defect and the obturator, so it's going to help move the entire prosthesis together. Coloration, you're going to have colors which you're going to do it, your lab is going to do it in different times, so it's not going to be very difficult for you to think about the colors. So basically, summarizing my entire session, by talking about manipulation prosthetics, I want that all of us should try and bring into this part of dentistry, which is quite untouched when it comes to practicing dentistry in our country. Because losing your body parts to these defects is not end of life, but the beginning of a new journey, which is not going to be possible till and when you're going to tell these patients function back to their life and be there and stand neck to neck with the on-day surgeons, because it is very well said in the book by the man himself, Dr. Gutmann says that an on-day surgeon should always consult a prosthodontist before he cuts that partial, and he knows that the replacement is possible. So try getting the manifestation. We love your interest. I hope the entire basic course you know what manipulation prosthodontics is. You know that what part of prosthodontics it covers.
Hi everyone, warm greetings to all the ones present here. I, Dr. Riddhi Intwala and Dr. Anam Siddiqui, your Master of Ceremony for the conference, on behalf of Team Cynodent International and Indian Society of Dentistry, welcome all our respected dignitaries, all our eminent speakers, and our geophysical and digital delegates to the Third World Dental and Facial Aesthetics from 3rd to 5th to November 2023 at Himachal Dental College, situated in the heart of Himachal Pradesh, Sundarnagar. Today marks the last day of our conference, and we shall now proceed to our first lecture of the day by Dr. Lakshmi Pandey ma'am. She is Assistant Professor at School of Dental Science, Sharda University. Please give a big round of applause for Dr. Lakshmi Pandey ma'am.
Good morning, everyone. I hope all of you are awake. Okay. So, I am Dr. Lakshmi. I am Assistant Professor in Sharda University. I have done my BDS from KLE Belgaum and my MDS is from KVCDC, Surya. Okay, so I'm some product. So, I just want to ask you, what do you people mean by aesthetics? Okay, first I need to know, how many of you are undergraduates here? Okay. Postgraduates? Endo postgraduates? Endo PGs, come in front. Come. Yeah. Interns? How many of you are interns here? Okay. See, my lecture will be very basic. It's very useful for all of you. See, I'm not going to give you any theoretical much knowledge. I'm going to show you my cases and how I've done. Okay? So through the process, you people will come to know how to actually achieve aesthetics. Okay? So, the recent era nowadays, we are more focused towards aesthetics. You know, everybody is talking about aesthetics, pink aesthetics, white aesthetics. Okay? So, these days, it's pink and white aesthetics. So, your pink aesthetics is related to your gums. Okay? How beautifully you're going to manage your gums and how beautifully you're going to give the patient what the patient requires and what is functionally good for the patient. Okay? So, the same thing goes with your white aesthetics. The white aesthetics is your tooth related. I think I'm understanding, I'm going pretty slow. So I think all of you can understand me? Okay, then I'll start. So my topic today is white aesthetics. So before I start my lecture, I would like to acknowledge my guide, okay, Professor Dr. Moksha Naik, my head of the department, because both of them, because of them, I'm standing here. Okay, and then my Sharda team. Okay, here. Can anyone tell me in all the 4 pictures where all I have given the treatment to the patient? Anything. It can be composite, veneers, crown. Can anyone tell me? First picture. Let's just go with the first picture. One, 2, 2, 1. That's it. What else? Okay, I had this habit when I was a postgraduate. I used to do a composite and I used to ask my batchmates, "Acha bata kaun sa kiya maine?" You know, it actually makes you feel very good if your batchmate is not able to recognize. Second picture. Can anyone tell me what I have done? At least tell me which all tooth is treated, which all teeth are treated. Kuch bhi? Composite, veneer, crown.
1, 1, 2, 1.
1, 1? 2, 1. That's it. What about the third? I have done 2, 3. Okay. Third one. Okay, these are my, I have another. Okay, in this 3 pictures. I think the second picture is a little evident, but still I do. Because this is not the follow-up picture, this is the picture which I took immediately. So I think people can see the bleeding gums. Right? And in this, you just guess. It's not a viva is going on. Just guess. 2-6, right? Okay, so I'll show you all my cases and I'll show you what exactly I've done. So we'll start with the first. This was the patient came to me. Can you see? The patient has diastema, the incisal edges are gone. Can you see? This is how the patient came to me. The first thing which I did was wax mopping. See, why do you do wax mopping? See, it's a very important step when you're doing any aesthetic correction. Your wax mopper will tell you what exactly your tooth is going to look like after treatment. So here at this step, if you go wrong, your complete entire procedure, how well you do it, it's going to screw up. Okay? So this was the wax mopper. Then I did veneer preparation. You know there are, how many types of veneer preparations are there? In the PGs? Okay. There are 4 types of veneer preparations are there. Partial and full. Another full is window preparation, feather, bevel and incisal overlap. In this case, I went for incisal overlap. Why? Because I had to correct the length of the tooth. All the teeth, both, I had to correct the length. So I did the preparation. Then I did the retraction. And the most important step of my entire procedure, shade selection. Okay? So I did the shade selection. Then I took the elastomeric impression. This was the veneers I got from the lab. I did the cementation. See, this is how it looked. Okay, I'll show you the 4-1 follow-up also. Can you see? This was exactly how my tooth was looking, both the teeth, they were looking when the mopper was done. So this is the 4-1 follow-up. And I'll tell you, see, whatever case you are doing, you should always keep follow-up. You know? Because that follow-up will tell you how exactly and how good work you are doing. Okay, your job is not just call the patient, do the work and send the patient. Okay? This is another case. This is the second picture which I showed you. Actually, he's my friend. He's an orthopedic surgeon. Can you see how pathetic it? Oh, I don't know. I was his friend, and I'm his friend. The moment I used to meet him, the first thing which I used to notice is teeth. I don't know. I tried to avoid. I tried everything. So one day I told him, "Acha, kuch mat kar, tu aa. I'll pay everything. I'll do all the treatment." See, I don't know who did this crown. Can you see? वो दूर से भी हंसेगा तो people can make out कि भाई कुछ तो गड़बड़ है. So let's just see. We'll see what all things. This is crown. This is composite restoration. I don't know how brilliantly done. You see, you can pick out your KVs, or the class 3 KVs are there, class 4 KVs are there. You can see. Here, I'll show you in the end how it looked. Okay. So it was a long procedure. I removed KVs. I found pulp exposure was there. The canal is done. See. Then the first thing which I did was I did composite build-up. All the class 3s, all the class 4, I did composite build-up. Also endodontic build-ups also I did. Then I went for wax mop. I don't the step in all my procedures. Then I did preparation. This and this I did veneer. These two were RCT treated, so I had to give round. See, he gave me temporary. This is how it looked. shade selection was done. And can you see the difference? Can you make out which is crown, which is veneer? You cannot make out, right? So this is what you are supposed to do. This is what you are supposed to give to your patients. And I'll tell you, you do a wonderful work. Even if little bit, glitches are there, the patient won't recognize it. What you are supposed to do? Ask your fellow batchmates. Okay? Ask the head of the department. They will definitely recognize what is wrong. Okay, so this is how you learn. Can you see? I have given crown in these two, veneers these two. The catch for me in this entire procedure was the shade selection. Okay, the veneer, shade selection and the crown. I made it very clear to the technician that this is the one thing I don't want any compromise. This is my second case. I'll go to my third case. He's my friend, so I can take how much follow I want. So this is the 18-month follow. Can you see? Can you see how he was and how his smile has become now? So see, this is the wonder you can do to your patients. This is the another case. The patient came to me for diastema closure. And in this, I treated was lateral. Somebody was telling 2-3, right? It was not 2-3, it's 2-2 and 2-1 and 1-1. In this, I didn't do much. I have just done composite build-up, so I'll just show you. But in this, the plus point for me was I used bioclear matrix. Do you people aware about bioclear matrix? See. You are hardworking, good. You have excellent hand skills, good. But the another thing that is required is armamentarium. If you don't have good armamentarium, how good you are, how hardworking you are, you won't reach the 100%. Understood? So, using the armamentarium, different types of armamentarium, you have to do in your post-graduation. Understood? So this is the time. You can experiment, you can learn, you can do mistakes. So I'll show you. First I did the lateral. Can you see? See, this is the bioclear matrix. These are transparent matrix. They are costly. Yes, they are very costly. But they'll give you excellent result. See, I have two cases in my presentation. One I have used bioclear and the other one I have used the normal metal matrix, sectional matrix. So you will see the difference. I don't know if you people will notice, but definitely I will see the difference. Okay, so this is the point for using armamentarium. Use excellent armamentarium. I'll see, even if your hand skills are not so good, but if you use excellent armamentarium, you might reach a good point. Okay. So never hesitate in using different kind of armamentariums. Can you see after all the composite? See, I didn't explain all the etching, bonding and all. I think all of you know. Interns and all of you know, right? How to do composite restoration. करते तो होगे college में. So this is exactly how it works. See, lateral build-up I did. Can you make out? My shade selection, my polishing. Okay, so these two will give me the end result. Okay, next I'll go. Can you see? See, this is the picture which I showed. Somebody was telling 2-3, right? So it was 2-2. All of you are understanding my cases. I think they are pretty simple. Okay, so this is that molar case. Somebody told 2-6, right? So it's a patient came to me. Obviously, pulp involvement was there. root canal and crown. This is what we suggest, right? This is what is a treatment plan. We'll do root canal and then we'll do crown. I'll show you what I have done. Obviously, I have to do root canal. I cannot do anything else than that. No modification. So yeah, under rubber dam isolation. See, there's another thing which I want to tell you. See, it's been, I don't know, maybe 5 years, 6, 7 years I'm into this field. So, the thing is, you will get excellent result if you do isolation. For endo, your isolation is like, it's like, how to explain? Just like you drink water. You drink water, no? You cannot live without water. It's like your procedure should not be without rubber dam. Any kind of RCT you cannot do without rubber dam. Okay? So, and I'll tell you, actually, when I was in South colleges, it's mandatory because our faculty was very strict. If my HOD will see me doing a case without rubber dam, I'll be suspended for what? Another 2 or 3 weeks. So this was a fear. Actually, yeah, this was a fear. Because of that, I started using rubber dam. But this is the one thing which I learned in my post-graduation and that has helped me till now. Once you start placing rubber dam, it's not going to take more than even 1 minute. Okay. So, using the right type of clamp, right type of sheet, that's it. Placement is very easy. See, you people try. Initially, maybe 1 cases, 2 cases, 10 cases, you might feel a little bit difficulty. But once you get the hang of it, you'll realize. And once you get used to doing cases under rubber dam, you'll feel, okay, this is the best thing which I have learned. I'll tell you my personal experience. Okay, so this is the root canal. Working length was the procedure entire, the observation. Then, rather than going for full coverage crown, I decided to go for onlay. You know the Cohen has given that now it's not necessary to give full coverage crowns. But I know in book there's a chart given. Okay. UGs you might not be knowing, PGs they also might not be knowing. 3rd year mein padhoge. Padhai ke 3rd year se start karoge, right? So I did the cavity preparation for onlay. This was the indirect restoration. Cementation. See, this is how after cementation my tooth looked. See, if I would have gone for full coverage crown, obviously I had to remove a lot of tooth structure. Okay, lot of tooth structure, the margins of crown, definitely the patient is not going to maintain the oral hygiene. It's going to be leakage and lot of bone loss. It's a huge, problem for the patient as well as for you. After some time, patient will come back to you with food lodgement or bone loss. So, I went for a more conservative method. And this is the occlusion view. Can you see? This is the occlusion, this is the buccal view. Then another case, my anterior, can you see here, class 3 is there. You know what is class 3? Undergraduates? Class 3 to pata hoga. From second year you people are learning. Okay, what is the difference between class 3 and class 4? Yeah, good, very good. So this is the class 3, this is the parietal view. I prepared, the cavity was quite deep, so I placed GIC because I was going to give composite. So this, I did isolation of the other two. Etchant was applied. See, here I used sectional matrix. You see, here, you see it's a metal matrix, it's a sectional matrix. Here, can you see? Actually, it's, in this I couldn't take the follow-up. So this was the immediate after the build-up. किसी को कोई डिफरेंस दिख रहा है? जो मैंने बायोक्लेयर से किया था और जो अभी किया? नहीं दिख रहा होगा. It's okay. this is the another. Actually, this topic is white aesthetics, right? This is the another. The patient came to me with discolored tooth. Patient was not having any pain. There was nothing. He was just worried about the discolored tooth. So I took X-ray. There was lesion here, central incisor, lateral incisor. But I did the vitality for the lateral incisor. It was vital, so there was no need for root canal treatment. I did access opening. The canal was a little bit calcified. The chamber was calcified. Even the canal was calcified. I used EDTA, a lot of materials, and then I did observation. And then this is the white office material which I used for the bleaching. This I used, can you see? Can anybody tell me what is this procedure? See, after you obturate, you do something, sealing of the canal. Whenever you are going for bleaching, you are supposed to seal the canal. Why? So that your bleaching material doesn't leach inside. So you seal it with GIC, whatever is feasible. I place GIC and then I use this barrier, gingival barrier. It's a resin, you place it and then you cure it. See, this material I had from the beginning of my post-graduation. I still have it in my kit. It's nothing, it's a small tube. It's very cheap, it's not that costly. But it helps you even when you're placing a rubber dam. There's a little bit, somewhere, some places, there's a little bit, leakage is there in the rubber dam also. And some tooth which might be rotated or, grossly decayed. In such area, your excellent seal will be achieved by your gingival barriers. Okay, so for postgraduates or for any endo faculty or endo person, practitioners, this is a must. Then can you see how it was looking? So in this, I use both extracoronal, intracoronal bleaching. You know the lot of procedures are bleaching. Is there vital bleaching, non-vital bleaching, walking bleach, all this procedure. So in this, I use both intracoronal, extracoronal. Intracoronal is, other name is also walking bleach. In that, what do? You place the bleaching material inside the coronal part of the tooth, you seal it, and you call the patient after a week. Okay? So, why it's walking bleach? Because a patient is walking with the bleach inside his tooth. Okay? So, that's how the name is done. In this, the material, the composition, obviously hydrogen peroxide, 30 to 40%. We use for bleaching. UG might not be. UGs might be knowing, right? Obviously, aesthetic, finally, or they might be teaching you. So, here, this was my immediate result. For 15 to 20 minutes, I cured with gun. And then see. This I received after a week. I did intracoronal as well, right? So the patient came to me, this was after a week. There was not much difference, but the immediate result was excellent in my case. See, can you see the pre-op and the post-op? So this is the end actually of all the cases. So I hope all of you understood. See, they were very basic cases, but they play a very, there's an impact of these cases on you. Patients, all of my patients, how my patient used to look before and how my patient changed after I did the treatment. So, the patient is walking with that is an impact on me as well. My work, how good it is. So, that's right. Whenever you are doing any aesthetic cases, be very careful, be very meticulous and use correct armamentarium. And always be in line with the patient. Because your patient has to be happy in the end. It might be very pleasing to you, but the patient might not be satisfied. So this is what happens when you are doing any aesthetic treatments. Okay, so any doubts? Anyone? Or anybody want to ask me anything? You just try this in future. Whenever you do, even the That's what I tell all my students, my BBS final year students. So I tell them, whenever they do composite, I tell them to ask each other, कि कौन सा दांत किया, क्या किया. This will help you. This might motivate you also. So whenever you do any aesthetic, just ask your colleagues, ask your batchmates how the work is going, and then you will see the result. Okay, thank you.
Thank you so much. It's a pleasure listening to you speaking on white aesthetics in dentistry. Please give a round of applause for ma'am again. Now, without further ado, it's time to invite our next keynote lecture speaker, and that is Dr. Himanshi Rana ma'am. A brief introduction of ma'am is, she is oral and maxillofacial surgeon and renowned speaker who is amongst us for our conference. Please give a round of applause for ma'am.
Hello, good morning everyone. Sleepy? पक्का से? या कल डांस करके थोड़ा ज़्यादा थक गए? चलो. My name is Dr. Himanshi and I thank Cynodent and Himachal Dental College मुझे यहाँ बुलाया. Thank you so much. So OSPDs कोई भी नहीं है? अच्छा यहाँ पे OS नहीं है. कोई बात नहीं. Interns are available, right? And this is oral surgery से थोड़ा प्यार हो. Extraction से, blood से, trauma से. Okay, है. So my topic is physics forceps, a boon in dentistry. Why a boon? What is the meaning of boon? Good. मतलब हमारे लिए फेवर में है. ठीक है? So just a bit introduction. Tooth extraction is the most common procedure done by dentist. Of course, bread and butter is endo. RCT is restoration आपका bread and butter है. But अगर endo fail हो जाए या नहीं आती है तो extraction है ना? वरना you can call for consultations also. ठीक है? For many centuries, resulting in evolution of various instruments for this procedure over time. So first of all, guiding coliac. So यह एक नाम बहुत important है जिसने first extraction के लिए forceps दिए थे. ठीक है? और इनसे argumentarium दिया था for their extractions. So in 14th century he invented the dental pellicle. Dental pellicle कैसा होता था? Just an instrument कि आपने उसको देखा और लगाया और खींच लिया. It was like that. Very dramatic. Very dramatic. ठीक है? Used through the late 18th centuries, which was replaced by dental keys. Dental keys वैसे नहीं दिखती हैं, but I guess आप सबने elevators देखे हैं, ठीक है? So elevators are like dental keys itself, and which in turn was replaced by tooth extraction forceps जो हम अब use कर रहे हैं in the 20th centuries. We have upward के लिए different, we have lower के लिए different. Tooth extraction is a surgical act that may result in immediate destruction and loss of surrounding alveolar bone and soft tissues. So we have destruction of both hard and soft tissue destruction. तो उसको minimize करने के लिए we have recent या important कुछ advances होते हैं, advancements आते हैं. That can be anything. Powered periodome, periodome, physics forceps. They are very new advancements. तो उसके लिए क्या करना चाहिए? हमें आर्टिकल्स पढ़ने चाहिए. जर्नल्स अवेलेबल होते हैं ऑनलाइन, ठीक है? एंड कुछ में पे करना पड़ता है, कुछ फ्री भी होते हैं. सो गो फॉर फ्री वंस, नो इश्यूज. Now newer instruments and techniques for extractions were developed for minimizing the trauma to pad and the structures over the period. So जो ये word है minimizing the trauma to pad and the structures, इसका मतलब क्या है? We want to minimize hard and soft tissue का damage so that हमारा aesthetic appearance, या आप implant डाल रहे हो, या आप denture डाल रहे हो, या आप bridge दे रहे हो, आपको देना है, तो उसका appearance would be good, उसका healing would be good. So in lay terms, आपका patient आपसे खुश रहेगा. So what is physics forceps? It is a type of forceps. हालांकि जो इसका मैकेनिज्म है वो एक एलिवेटर की तरह है, बट इट इज अ टाइप ऑफ forceps. I'll show you the forceps. It was developed by Golden Dental Solutions, Michigan, and is based on the biomechanical principles of first class lever. So first class lever कहाँ यूज होता है? It is used in elevators. क्या क्या mechanism and principles हैं? किसी को मालूम है? Good. Good. And lever principles. Good. So we have one class 1 lever principles over in the physics forceps. And और क्या क्या होता है? Creep and stress distribution. Without the squeezing, grasping, twisting and pulling forces to perform the automatic extraction. इस squeezing pulling क्यों आया है इसमें? आप जब नॉर्मल एक्सट्रैक्शन कर रहे होते हो, यू होल्ड इट अपाइकल एंड फर्म एंड आप उसको स्क्वीज करके आप उसको रोटेशन से बाहर की तरफ पुल करते हो. फिजिक्स फोर्सेस में यूज करने की जरूरत नहीं होती. So aim is to reduce the need for excessive force during extraction, leading to faster healing and comfortable experience. हालांकि थोड़ा सा कर्व होता है, पेशेंट डरता है बिकॉज इसका जो दिखने का जो अपीयरेंस है दैट इज अ बिट डिफरेंट, बट इट हैज अ वेरी गुड ईज ऑफ वर्क. सो व्हाट इज द मैकेनिज्म? बेस्ड ऑन द मैकेनिकल प्रिंसिपल ऑफ फर्स्ट क्लास लीवर, ये हम पहले बात कर चुके हैं. It also has 2 handles. So I'll show you. So it is autoclave and that these are physics forceps. ठीक है? हालांकि क्लास 1 लीवर है, elevated principle, but it has 2 handles. तो ये क्या बन जाता है? forcep. ये इसके 2 beaks हैं. एक ये बकल वेस्टिब्यूल पे जाएगा, ये आपका लेबियल या फिर पैलेटल पे. सो इट इज अ फोर्सेप जस्ट बिकॉज इट हैज 2 हैंडल्स, इसलिए बस ये फोर्सेप है. वरना मैकेनिज्म इसका इज एलिवेटेड. 2 हैंडल्स है एज कन्वेंशनल, वन ऑफ विच हैज अ बम्पर. ये बम्पर रिमूवेबल है व्हेन यू आर ऑटोक्लेविंग इट. अगर ये टीयर होता है, आप सिर्फ ये बम्पर भी आपका अलग से आपको मार्केट में मिल जाएगा, जो भी आपकी कंपनी का यूज करेगा. दैट एक्ट एज अ फल्क्रम एंड इज प्लेस्ड ऑन दी बक्कोलेबियल एस्पेक्ट. बक्कोलेबियल हो गया या बक्को फेशियल हो गया, व्हाटएवर. एंड एट द गिंगोजिंजाइवल जंक्शन व्हाइल द बीक इज प्लेस्ड टू द पैलेटोलिंगुअल एस्पेक्ट ऑफ द टूथ इनटू द जिंजाइवल sulcus. दीज आर द फोर्सेप्स. बेसिकली ये 4 फोर्सेप्स इन्वेंट हुए थे, बट डिफरेंट कंपनीज डिफरेंट थिंग्स, वी हैव मोर फोर्सेप्स इन द मार्केट. सो लोअर वन इज यूनिवर्सल. अपर के लिए वी हैव अपर इंटीरियर्स एंड मोलर्स के लिए डिफरेंट मोलर्स के लिए आप डिफरेंट, लाइक अपर राइट, अपर लेफ्ट, अपर इंटीरियर्स एंड लोअर वन इज यूनिवर्सल. सो दिस बीक इज ग्रास्प्ड टू एट द लेवल ऑफ PDL, which minimizes the trauma to the surrounding hard and soft tissue. ये वर्ड बार बार आता रहेगा कि ये आपका ट्रॉमा को मिनिमाइज करता है. बस एक यही वर्ड है जो बार बार आता है, इसीलिए फोर्सेस बहुत आजकल बूम में है. 2004 से इसके आर्टिकल्स पब्लिश्ड है, लेकिन पहले किसी को नहीं मालूम. Bumper, it acts as a fulcrum which creates a lever action when pressure is applied. It causes dislodging. Dislodging कैसे क्रिएट होती है? जब हम फोर्सेप्स लगाते हैं हमारे PDL ब्रेक होता है. कौन सा एंजाइम से क्रिएट होता है? हाइलुरोनिडेज. ठीक है, सो एंजाइम से क्रिएट होता है जिस विल कॉज योर टूथ टू पॉप. Force applied by the bumper in onto the gingival and bone distributed over a larger surface area and is a compressive force so that tooth and the annulus do not fracture. लेकिन yes, मैंने बहुत फ्रैक्चर किया है. मैंने नया नया सीखा, मैंने बकल प्लेट बहुत तोड़ी, मैंने ऑर्थो में रूट तोड़ा. कोई बात नहीं, तो है नॉर्मल कन्वेंशन किया तब भी तो तोड़ा था, कोई फर्क नहीं पड़ता. रिट्रीवल आना चाहिए. प्लेट हो गया है, टूट गया है, कोई बात नहीं, इम्प्लांट कर रहे हो तो क्या डाल दो, बोन ग्राफ्ट डाल दो। हमें क्या देना है, एस्थेटिक देना है। सो नाउ हाउ टू यूज separation of the travel attachment from the tooth using a mold knife or your periosteal apparatus. Placement of the beak into a secure palatal and lingual application point, that is root surface on the CEJ or below the CEJ. Placement of the bumper onto the buccal aspect of the alveolus. पहले आपका beak place होगा, उसके बाद आपका bumper. Application of a steady slow rotational force only using a wrist movement for 30 to 40 seconds. Personal practice में I have extracted within 1 minute मेरा tooth with using a physics forceps. Occlusion elevation of the tooth a few millimeters from a socket. उसके बाद you can use a hemostat, tweezer या फिर forceps itself. एंटीरियस में मुझे हीमोस्टैट जरूरत पड़ा था, मोलर में ये अपने आप ही मोलर से फोर्सेप्स से बाहर आ गया था फुल। नाउ हाउ टू यूज इट, कन्वेंशनल फोर्सेप्स हम कैसे यूज करते हैं, हाउ डू वी हैंडल इट। हमने हिंज पे पकड़ा, मिडिल फिंगर इनसाइड, ऑल द 3 फिंगर्स आउटसाइड, राइट। जो हमारा एक नॉर्मल हम उसको हैंडल करते हैं, इसका प्रोसीजर इज डिफरेंट। व्हाई इट इज डिफरेंट, अगर मैंने ऐसे यूज किया ये स्क्वीज कर जाएगा। मुझे क्या करना है, सिर्फ रिस्ट या रोटेशन मूवमेंट देना है। माय पर्सनल फेवरेट इज दिस, फिंगर्स बीच में रखते हैं ताकि ये स्क्वीज ना करे, ठीक है। देयर आर डिफरेंट पैटर्न्स, लोअर के लिए वी हैव 2, अपर के लिए 4, हाउ यू कैन होल्ड इट। बेसिक चीज इज वी हैव टू नॉट गिव इट अ स्क्वीजिंग मोशन, बस, ठीक है। यू कैन मेक योर ओन एडवांसमेंट्स टू। माय पेशेंट, आई एम वेरी बैड एट फॉलोअप्स, आई एम सो सॉरी, एंड आई एम वेरी बैड एट पिक्चर्स। सो इनमें हमने इम्प्लांट किया था, माय फर्स्ट इम्प्लांट पेशेंट, इमीडिएट इम्प्लांट पेशेंट, जिसमें हमने फोर्सेप्स भी यूज किया एंड इम्प्लांट किया, अपर लोअर बोन, वेरी गुड। alveolar bone fracture नहीं हुआ था। Now how is it different from the conventional ones? Conventional, आपने physics forceps वाला डिजाइन देख लो। See, we have a bumper. This is the principle of usage. We have first class level principle. Conventional में क्या यूज करते हैं, wedge principle. Forceps apply 2 equal forces to the tooth and additional third for the movement of arm. Original third कौन सी होती है यूजुअली, या तो हम बक्कल ट्रैक्शन दे रहे होते हैं या फिर हम प्रीमोलर्स में या सिंगल रूटेड में रोटेशन दे रहे होते हैं, ठीक है। सो दिस इज योर फर्स्ट क्लास मेथड। जैसे हमने क्लॉ हैमर यूज किया, नेल्स तो निकाले हैं सबने, वी पुट इट एंड जस्ट, जैसे हम एलिवेटेड यूज करें, जो मैं स्टार्टिंग से बोल दिया, ठीक है। The force application and trauma. Physics forceps allows a controlled and precise force. कितने मिनट के लिए दे रहे थे हम? Just for 30 to 40 seconds. Only wrist movement. That's it. कोई trauma नहीं। Reduced trauma, steady trauma to the medial ligament. इसलिए इसमें reduced trauma है, and in conventional we require a strong gripping force, and वो strong gripping force कभी-कभी cervical plate तोड़ देती है। It has increased trauma due to intermittent release of the enzyme. Which enzyme? So you are not sleeping, thank God. But सिर्फ एक ये चीज, we require training and experience. But हमें तो ये कन्वेंशन में भी चाहिए होता है। थर्ड ईयर में, फाइनल ईयर में भी लर्न कन्वेंशन। अगर कॉलेज वाले हैं या आप खुद अगर आपको इंटरेस्ट है तो यू कैन गो लीन टुवर्ड्स मोर। सिर्फ इसकी बात नहीं, टू ऑल दी एडवांसमेंट्स दैट आर कमिंग, गो फॉर पीजोस। इन टर्म्स हो पीजो स्टार्ट करो यूज करना, पेरियो वाले पीज के साथ गो फॉर पीजो सर्जरीज, दे आर वेरी गुड। So these are the types. Physics के लिए upper anterior, upper right, upper left, then we have universal for lower. And conventional we all know anterior, we have premolar, we have left, we have right, anteriors, premolars, molars, जिसमें हमारा बहुत ज़्यादा वाइवा भी होता है ना? So again, this is the ortho patient. जिसमें मैंने दोनों में फिजिक्स वर्सेस यूज किया. लेफ्ट साइड पर अनफॉर्चुनेटली इसका रूट फ्रैक्चर. अगेन वन मोर केस, फिर से ऑर्थो, बिकॉज मुझे हारना नहीं पसंद. ओरो सर्जन्स हार नहीं मानते हैं, बस यही बीमारी होती है उनकी. हाँ, इस पेशेंट ने मुझे बोला कि मैं डर गई इस फोर्सेप को देख के, बिकॉज ये पहले वालों से डिफरेंट है. बट जब इसको हमने यूज किया, शी वॉज सैटिस्फाइड. शी हैड नो पेन and she had no ecchymosis on the vestibule. So she was satisfied. One more patient of physics forceps and cells. Very good. This was my favorite patient. Lower molar किया and 2 minutes के अंदर patient was out of the OPD. कोई problem नहीं, दवाइयाँ समझा दी. Full molar was inside the forceps. ये ऐसा नहीं था कि लग्जेरियस था, मेरे को डिलीवर आउट करने के लिए एक्स्ट्रा करना, कुछ भी नहीं. Now, special considerations. Proper training and familiarity. Correct forceps selection. आपको मालूम होना चाहिए. लेफ्ट का राइट में नहीं, राइट का लेफ्ट में नहीं. कन्वेंशन जैसे पोजिशनिंग एंड अलाइनमेंट. अगर सीजे से या रूट से ऊपर हो, यू माइट ब्रेक. ग्रेजुअल कंट्रोल फोर्स, ये बहुत इंपॉर्टेंट है. हम कभी भी जो स्पेशली इन लोअर मोलर्स, वी डोंट गिव अ बकल मूवमेंट फर्स्ट, वी ऑलवेज गिव अ लिंगुअल ट्रैक्शन. व्हाई? बकल प्लेट थिक होता है, लिंगुअल प्लेट थिन होता है, एंड मैक्सिलरी के अंदर बकल प्लेट थिन होता है एंड पैटर्न इज हार्डर. तो हम पहले वहाँ पे बकल की तरफ जाते हैं, बट लोअर में ऐसा नहीं होता. बट फिजिक्स फोर्सेस में सिर्फ जाएगा बकल ही, बट फिर बकल में फ्रैक्चर नहीं होता, ना कुछ फ्रैक्चर होता है. चेक फॉर एडिक्वेट लूजनिंग. मेंटेन पेशेंट कंफर्ट. पेशेंट आपका बोल रहा है कि नहीं मेरे को डर लग रहा है, मेरे को डर लग रहा है, ईज. आप भी स्लीप आराम से ब्रीथिंग करो, उस पर बोलो सांस लो. रेगुलर मेंटेनेंस एंड इंस्पेक्शन फॉर द मटेरियल. Advantages: minimal trauma, efficiency, easier for multi-nutrient extractions, reduce need for excessive force, and versatility. Disadvantages: learning curve. सबसे important, initial cost, थोड़ा महंगा. Case dependent, we cannot do ankylosis की patient, fenestration की patients में आप नहीं कर सकते. Solitary tooth है, उसमें हमें थोड़ा सा ध्यान से करना पड़ता है. Solitary tooth is, we don't have adjacent to structures. बहुत टाइम से एक सिंगल पड़ा है. That's maintenance and care. And thank you so much for not sleeping.
Thanks keynote speaker, Dr. Shweta Verma ma'am. She is a professor, Department of Conservative Dentistry and Endodontics from Himachal Dental College, Sundarnagar. Kindly welcome ma'am with a round of applause.
Very good morning to one and all present here. It is an absolute privilege and pleasure to be with you all and interact with you all. So I'll start my presentation with this quote by H.G. Wells. H.G. Wells is actually father of science fictions. He said that we should strive to welcome change and challenges because they are what help us grow. Without them, we grow weak in our comfort and security. And we should keep constantly challenging ourselves in order to strengthen our character and increase our intelligence. So the two words which are most fascinating in this quote is change and challenge. So all of us, we should keep challenging ourselves so that we can change for better. And for that, we need to constantly keep ourselves updated. And restorative dentistry as a branch, it is constantly changing and it is going constant evolution in terms of materials, techniques and all the equipments which we are using. So today I will be, my session is going to be about the problems that we encounter while placing class 2 direct composite restorations. I will be giving you some practical tips for a predictable and for a successful class 2 direct composite restoration. So this is our journey. We are all very familiar with this exercise. This is the very first exercise that we perform in our dental schools when we are in pre-conservative, and I think this is the very first exercise which we perform in pre-prosthetics as well. That is making a 1-inch plaster tube. This exercise, it seems to be, very frustrating, very uninspiring kind of exercise it is. But the basic idea for including this in the dental curriculum is to learn about the manipulation of the dental materials, to study them better. And then we start working on these phantom head models, these typhoid teeth. We make class 1, class 2 cavities, then we restore it with dental amalgam. And whenever we go to our teachers for getting it approved, in our time, the favorite sentence which our teachers used to say was, repeat the exercise. And we used to hate our teachers like anything. But believe me, a good dentist is not one who is talented. Over my teaching experience of 14 years, I have learned a good dentist is one who has passion and who has perseverance for continuously enhancing the skills. Dentistry is an ever-learning branch. When we move out of the dental school after BTS or after MTS, we should think that we have सब कुछ सीख लिया. It is an ever-learning process, and this is the quote by Rudyard Kipling. We all know him for his famous work, that is Jungle Book. These 4 lines from his work: I keep 6 honest serving men. They taught me all I knew, and their names are what, why, when, how, where, and who. If we keep questioning ourselves, these six things, we'll learn most of the things of our curriculum. So this is the best way of learning, that is, we should keep on questioning ourselves. And if you are still confused about the future of the dentistry, let me tell you, the future of the dentistry is very bright in the coming years. There was a survey conducted by Planning Commission of India. They wanted to find out the disease load of dental caries. This is also known as disease burden. And they found that on a minimum of 1 and on an average 2 patients from the urban population, they are going to have a minimum of 1 and on an average 2 restoratively involved teeth. So this is the entire restorative and endodontic burden which we are going to deal with in the coming 15 to 20 years. So class 2. We all know that the restorations, the lesions which are present on the proximal surface of the posterior teeth, they are the class 2 restorations. These are the various clinical pictures of class 2. The first picture, you can see a premolar where we have white opaque discoloration of the marginal ridge and decalcification present in the contact area. In the second one, we can see there is extensive class 2 lesion with probable pulpal involvement. And there is a third one, it has a dental amalgam restoration associated with recurrent caries. So each class 2 case is a unique case. For all the class 2 patients, we cannot just follow a similar line of treatment, and it is a very demanding clinical situation when a class 2 patient comes to us, and we have to provide adequate skill to that patient in order to give a good long-lasting restoration. These are the various radiographic presentations of the class 2 lesions. And just a correction, we don't do cavity preparation. Cavity preparation is the common term which we use, but it is incorrect. The better term is tooth preparation, because the cavity is already present. What we are doing is we are mechanically altering the tooth structure. We are removing the diseased and defected part from the tooth and making the tooth receptive for receiving a restoration. And this restoration is going to restore the form, function, aesthetics and the healthy state of the tooth. And once a class 2 patient comes to us, basically we have to decide whether we have to give a direct restoration or a indirect restoration to the patient. And the decision, the choice between the two is dependent upon the extent of the various involvement, the extent of the defective tooth structure that is present. If the defect is minimal to moderate, we will go for direct, and if the defect is extensive, requires lot of occlusion corrections, then we will go for indirect restorations. Direct restorations are the one in which the tooth preparation is done in the patient's mouth, and in the same sitting we restore it as well. And indirect are the one in which the tooth preparation is done in the patient's mouth, then we make an impression of that prepared tooth, then we prepare a cast and dye mortars, and then we process the restoration in the lab. So obviously these restorations, they are better than the direct one because they are lab processed. They are made out of the materials which have better physical and mechanical properties, and we have better control over the contact and the contours when we are working on a dye or on a cast in the lab. And for the success of the restoration, the two most important R's are the resistance form and the retention form. In simple words, resistance form means the form of the preparation that resists the fracture of the tooth as well as the restoration under the masticatory forces, which are principally acting along the long axis of the teeth. And retention form, it prevents the dislodgement of the restoration under tipping and lifting forces which are constantly acting upon the oral cavity. And together they are very difficult to achieve. If you have good resistance, retention form will suffer. And if you have good retention, the resistance form is going to suffer. And as a rule, all the direct restorations, they are retentive, but they lack resistance form. And all the indirect restorations, they have good resistance, but they lack the retention form. Once we have decided, my lecture today will focus only on the direct composite restorations. So once we have decided that we are going to deliver a direct restoration to the patient, we have to decide about the restorative material. And the main choice is between dental amalgam and dental composites. Dental amalgam, it has been used for restoring the class 2 lesions for over a decade now, and it is a very forgiving restorative material, highly predictable, has very good physical and mechanical properties, and easily we can learn it and quickly we can place it in the patient's mouth. But it is constantly undergoing corrosion in the oral cavity, and also there are issues regarding the mercury health hazards and waste disposal of mercury. So it is being largely replaced by the dental composites. Now this is question for all of you. What is the main cause for the failure of the amalgam restoration? Anybody can answer except for endometriosis. Marginal leakage, fracture of restoration, filling dislodgement, or post-operative sensitivity. Marginal leakage. Second, any other answer? All these, all four of them, they might be the cause of amalgam failure, but the most, still anybody wants to answer? Huh? Cause of failure. So it is fracture of the restoration. 70% of the amalgam restorations, they fail because of fracture. Why? Because amalgam, it lacks the flexural strength, and while the tooth preparation, we don't care about the resistance form. The cavity preparation for the amalgam, it has to follow all the principles of resistance and retention form to be successful. And this also comes out to be the major drawback of amalgam. That is, for placing amalgam restoration, we have to sacrifice a large amount of the healthy tooth structure. And for composite, what is the main cause for failure of the composite restorations? Yes, but how does it clinically manifest? Polymerization shrinkage, patient cannot see it. Clinically, the patient has recurrent caries. So the most important cause for failure of composite restoration is recurrent decay associated with it. But why still the amalgam is being done? Amalgam is being done, you are supposed to perform the class 2 amalgam restoration in your final year exam also. Why is it being done? It is being done because to improve the skill, precision and to have perfection. If you want to learn all the fundamentals of the tooth preparation, understand the tooth structure better, enamel, dentine and pulp, then we have to practice the amalgam tooth preparation. The basic difference between dental amalgam and composite is our approach. In case of composite, here you can see the cavity, the tooth preparation, it does not have any specific geometry. The tooth preparation is dictated by the carious involvement of the tooth, the amount of the diseased tooth structure that is present, and we don't care much about the line angles, the point angles and the configuration of the pulpal floor or the axial wall. Whereas in case of dental amalgam, we can see the exacting cavity preparation with well-defined outline form, initial depth, we have flat pulpal floor, flat gingival seat, and all the line angles and the point angles are rounded, and all these susceptible pits and fissures which have the potential for the caries involvement in the future, they are included in the tooth preparation. So we can see we sacrifice a lot of healthy tooth structure in order to do an amalgam restoration, but in case of composite, our approach have changed our concept from extension for prevention to minimal invasive dentistry. But this transition from amalgam to dental composite had not been easy. Most of the dentists, they state that placing a class 2 dental composite is very challenging, and the most important reason is that it is very time consuming, it is very tedious. It is the critique that is often associated with direct composite restorations is that they are technique sensitive. And most of the restorative dentistry that we are performing today is the replacement dentistry, in which the previous dental amalgam restorations, they are being replaced with aesthetic tooth colored composite restorations. So it's the time to rethink about how we are doing the direct class 2 composite restoration and what do they really mean to us. Because most of the restorative work that we are doing is direct composite restoration, and out of that 50% is class 2 restorations. We need to understand that dental composite, they have some certain inherent drawbacks which we always need to keep in our mind. The first is polymerization shrinkage, because whenever the curing reaction of the composite takes place, the monomers are converted into polymers. There is associated polymerization shrinkage that creates stresses within the restorative material, and hence it leads to micro leakage and secondary leaks. Second, building up the contact with dental composite is very difficult because they cannot be condensed like amalgam. They have long biodegradation in the contact with the oral fluids, and also they have excessive wear associated with them. So this is what happens because of the polymerization shrinkage. There occurs micro leakage, which results in secondary caries and post-operative sensitivity, and also there is formation of internal gaps in the restoration, and marginal staining also takes place. Now these are the tips also. These are certain factors which we have to decide before we place a class 2 direct composite restoration. First is the restoration, it should have preferably enamel margins. The significance is that the strongest bond is with enamel. Second, we should avoid the cases where the restoration extends on, the lesion extends onto the root surface. Because on the root, the substrate which we will be using for bonding is dentine and cementum, and it's been proven that the bond strength with dentine is comparatively lower, and because of the polymerization shrinkage stress is acting there, V-shaped gaps are formed when we do the composite restorations on the root surface. So the best treatment alternative in that case is sandwich technique, where the root part, the dentinal part of the root surface should be restored with glass ionomers, and the rest of the restoration should be done with dental composites. And because the composite materials, they lack the wear strength, so the occlusion assessment should be done prior, and it should be avoided that we don't have the occlusion contact at the junction of the restorative material and the table surface margin. And the easiest way to do so is that we should take an articulating paper before doing the restoration, and we should identify which are the areas of the occlusion contact. And last thing is pre-wedging. Pre-wedging, it should always be done in order to achieve the initial tooth separation, and also in order to compensate for the thickness of the matrix retainer, which we are going to place at a later stage. So these are some of the basic designs for class 2 lesions. This is the traditional class 2 preparation that has both occlusion as well as the proximal involvement. And the second approach is the slot preparation, where we don't involve the occlusion surface, only the proximal box is prepared. And the next one is the tunnel preparation, in which we approach the lesion from the pit, whichever proximal surface is involved. From that pit we will approach the lesion. The lesion here is mainly present in the contact area, and your occlusion surface is not involved, and also the marginal ridge is intact. So we try to conserve as much tooth structure as possible, and we approach the lesion in a way that the marginal ridge is left behind. So the three important things which are critical for a successful class 2 composite restoration is: one, that we should be able to achieve predictable contact. Second, we should be able to deal with the post-operative sensitivity. And third, the entire process of placing a composite restoration, it begs simplification. It should be made quick, easy, simpler, and predictable. So the factors that affect the success of composite restoration, I have, for easy understanding, I have grouped them under 3 categories. One is material related, second patient related, and third are the operator related. The patient related factors, it includes the socio-economic status of the patient, the oral hygiene status, and the caries activity of the patient. Now I will be discussing the material related factor. Since we are dealing with composites, so I will be covering only the posterior composite. The posterior composites, they need to have good strength and high wear resistance. We have different posterior composites available in the market. They can be used either in an incremental technique, or we can use them in the bulk fill technique. Incremental means we add them in small increments of 2 mm and then we cure them. Whereas in case of bulk fill composites, we can put them in an increment of 4 mm, and we can make our process of composite placement simpler. And we also have single shade composites which are omnichromatic, and they take the color of the adjacent tooth structure, so we don't have to worry much about the shade selection as well. Now the first step is in the composite, in doing a class 2 composite restoration. Once we have done the tooth preparation, the first step is isolation. It is imperative to do all the class 2 composite restoration under rubber. If you want a durable bond, all the restorations, they should be done under rubber dam. And if there is any contamination of the etched enamel or dentine, the bond strength is going to be affected. And if there is any contamination of the dental composite material at the time of insertion, then also the failure is going to happen. Because the composite material has been designed in the way that it should be placed in an environment that is free of saliva, blood and any kind of moisture contamination. So these are the various studies. They have advocated that the restoration, class 2 or any composite restoration, it must be placed under rubber dam. In some cases, for example, if the teeth is rotated, we can use cotton rolls, but along with that, high volume evacuation must be used. Now the second step is pre-wedging. As I already said that pre-wedging should always be done. Earlier the pre-wedging was done by using the wooden wedges. The major disadvantage of using the wooden wedges was that it resulted in bleeding, and we could never control this bleeding actually during the placement of the restorative material. So today we have flexible plastic wedges which can be used, and this is the latest thing which we have available today. These are known as the wedge guards. You can see there is a metal film that is attached to a wedge. This wedge is anatomically contoured and we have a metal film associated with it. So it is going to protect the adjacent tooth from the iatrogenic damage, which is caused in 70% of the class 2 tooth preparation by us. We nick the adjacent tooth. And so in order to prevent it, so this will do a dual function. It would prevent the adjacent tooth from the iatrogenic damage, and at the same time will be able to achieve our tooth separation as well. Tooth separation is needed so that we can appreciate all the restorative margins, especially the gingival margin of the restoration. Now the next important step is to create a predictable contact. The contact, it should be natural, it should be tight. We don't want to have open contacts, and for that we need a good matrix system. The traditional matrix system which we were using were the Toffel-Myers, but these Toffel-Myers, they resulted in a flat proximal surface in the restoration. Most of the time the contacts were open, and they also shifted the position of the contact area. So the preferred one these days are the sectional matrices. The sectional matrices are the one which are only placed on the restorative on the surface that is to be restored. And in this picture we can appreciate that this is a flat contact which is undesirable. This is the kind of the contact which we achieve with the Toffel-Meyer. Normally the exact position of the contact area is in the middle third of the proximal surface. These matrix systems, they shift the contact point more occlusally. So as a result of this, what happens is that we have a larger gingival embrasure. There is continuous food impaction, and this results in the periodontal. It compromises the periodontal health of the patient. So the one more reason for the failure of the class 2 restoration is the loss of the attachment apparatus. And in this case, with the sectional matrix, what we achieve is a desired contact which is broad, convex, and is located in the middle third of the proximal surface. These are the various matrix systems that are available. I have not included the old ones. These are the latest ones which are available, and only these should be used preferably. The first one is a sectional matrix. This one is a circumferential matrix. This is the auto matrix. Here we can appreciate that all these matrix systems, they are retainerless. They are very simple to use, very convenient, and they are patient friendly as well. Okay? And if you want to simplify your choices, the default matrix system for the class 2 restorations is Cynodent. It is marketed by Dentistry, and this system It basically consists of this ring. This system, it consists of this bitine ring. It has these glass fiber tines are present. This ring, it helps in the tooth separation. And then these are the various matrix bands which are available in this system. We can see they have this plastic, this hole for the placement of the forceps, for the easy placement, and they are available in different heights. So they can be used in different clinical situations. 7.5 mm, it has an elongated gingival apron, and it can be used in the subgingival class 2 restorations as well. Then we have these wedges. These wedges, they are available in 3 sizes. They are all anatomic wedges. They prevent the bleeding, they detract the gingival tissue away from the gingival margin of the class 2, so that we have minimal or no bleeding in that area. And at the same time, the insertion of these wedges, it is very easy. When we insert it from an abrasion, on the entry they are tipped, but when they exit from the opposite abrasion, they tend to fan out. And these wedges, they are also reflective, so they also help in the better curing in the gingival margins of the class 2 restorations. This is the entire assembly. This is how we place it on the class 2. It can be appreciated here. This is the retainer in place, this is the bitine ring, and this is the wedge which is being placed. And the entire process, it is being done under rubber. Now the next critical thing which we have to consider is to create a durable bond. When we are dealing with the cavity, we have 2 surfaces basically which we have to treat. First one is enamel, and the second one is dentine. Enamel, it is easy to treat with the adhesive systems because it is principally inorganic in nature, and the bond strength is quite high with the enamel margins. But dentine, it is difficult to treat because it is intrinsically hydrated tissue. It also has collagen and moisture content present in it. So we have different choices for adhesion. We have total edge systems, we have self-edge systems, and today we also have universal adhesives which are available. To choose between these all systems which are available, we have to keep in mind the advantages and disadvantages of all these systems. So the total edge is the one in which the entire surface is treated with the etchant, and the most commonly used etchant is phosphoric acid 37%. The entire surface, both enamel and dentine, they are etched simultaneously, and hence the name is total edge. Then we have self-edge. Self-edge means we don't have separate etching or priming step. In this, the monomer which is being used is acidic in nature, and it is going to condition the tooth structure instead of etching the tooth structure. And the next one is the selective edge. Here we can see only the enamel margins, they have been etched, and the dentine is left behind. The dentine is not going to be etched, it is going to be primed, and then the adhesive agent is placed. So this is the simple way to understand the total edge technique. The first step is, this is a smear layer. This layer is always created whenever we treat the tooth, whenever we prepare the tooth with a burr or with a hand instrument. The smear layer is always created, and this plugs the dentine. Dentinal tubules, they get plugged with the smear layer, so the bonding with the dentine, it becomes even more difficult. So what we have to do is that we have to condition this surface in order to remove this smear layer. In the total edge technique, what we do is that we apply a etchant, that is phosphoric acid, on both enamel as well as dentine. Then we rinse it, and then what we achieve are the open dentinal tubules in which the entire smear layer has been removed, and there occurs the decalcification of the dentine, and all the collagen fibers, they get exposed. Then we apply, in the third step, we apply the adhesive, and what happens is that in the open dentinal tubules, these adhesives they penetrate and the resulting formation of the resin tags. So this is how the total edge systems work. The biggest advantage is that because the enamel is etched, the complete smear layer is removed, so we have better formation of resin tags. The resin tags, they are this zone which is formed, this interdiffusion zone which is formed is known as hybrid layer. The depth and the thickness of the hybrid layer which is formed in case of the total edge technique is highest. So the most durable bond which is formed is with the total edge technique. We can use this system, but the disadvantage is that first there is post-operative sensitivity associated with these systems because we are etching the dentine with phosphoric acid and the dentinal tubules they are getting opened up. But in this case, there is one more alternative that we can combine the two steps together. That is, etching and priming may be combined in one bottle and we can have a separate bottle of adhesive. So practically we have two total edge systems in which we have three steps of etching, priming and application of adhesive, or it can be simplified to a two-step procedure in which the etchant and the primer is present in one bottle and we have a separate bottle for the adhesive agent. This entire procedure is very technique sensitive and we have to take care of the over drying and over wetting of the dentine. Now in case of self etch, we don't etch the dentine, and by virtue of which what happens, we don't remove the smear layer, we just alter it, we just modify it, we make it more receptive for the penetration of the bonding agent. And in this case we can see that the hybrid layer which is being formed, it is of less depth and the resin tags, they are not that better which were formed with the total edge technique. So in this step no etching is required and no rinsing is required. So obviously this entire technique is simple. There is no post-operative sensitivity associated with this technique, but the disadvantage is that the bond strengths which are achieved with these self-etch systems, they are not great, they are low. So now we have selective etching in which we have etched only the enamel margin, the dentine is left behind. This will be conditioned, not etched. And these etchings which we use for selective etch technique, they should not be liquid. They should be in gel-like consistency so that they don't fill the entire cavity. Now how to choose? Now we understand what are the total edge systems and self-etch systems. We need to make our entire technique of this adhesive application simpler. So now in market we have these single bottle systems in which all the components, that is the etchant part, the priming part and the adhesive part, they are present in the same bottle. The techniques become very simple. There is no issues of over-wetting or over-drying associated with this entire method. We can just apply a coat of this single bottle system. The most popular ones are the prime and bond elect and one coat 7. They are also known as universal adhesives. And their biggest advantage is that they offers the good properties of both total edge systems as well as the self-edge systems. Then next step is the placement of the restorative material. In this we have to keep in mind two things. One is the adaptation of the material in the prepared tooth, and second is the incremental filling of the cavity of the tooth which we have prepared for class 2 restoration. In this picture you can see here the material, it fills the entire mold. It has taken the shape of the mold and is well adapted with all the walls of the mold. But in the second one we can see the restorative material has not filled the entire mold. We can see lot of gap and lot of space present between the walls of the mold and the material that we have placed. So the same thing is applicable to the adaptation of the composite material in the prepared cavity. So what we need to have is that the materials which we are using, they should take the shape of the cavity. But the composites which we are using, they are more viscous, so they don't adapt well to the restoration margin, cavity margins. So to simplify this, what we have to do is that we have to use a flowable liner at the base of the class 2 preparation, and on top of that we should use a high viscosity composite material. We should take utmost care at the time of the composite placement. Composite material should be placed in the increment. Increment should not be larger than 2 mm if you are using microfilled, nanofilled or nanohybrid materials. It is recommended they should always be filled in the increments of 2 mm in order to achieve the desired depth of cure. So these are the various placement techniques. The first is the incremental technique. We can see different increments are placed here. This is the first one. The second is oblique and the third one is again oblique. And then the other option with the newer material is bulk fill. They can be placed in the entire cavity can be filled with these bulk fill materials. But obviously after the placement of a flowable liner, which could be either a resin modified glass ionomer cement, or it could be a flowable composite, or it could be a flowable consistency of the bulk fill composite. These are the various studies which have shown that the micro leakage at the occlusion margin is less as compared to the gingival margins of the class 2 cavities, and all the incremental techniques they are associated with less micro leakage as compared to the techniques when we don't follow this incremental method. So this is the material which is available known as SDR flow. It is basically a material which is placed at the first increment has to be with this SDR flow material. It has excellent self-leveling capacity. Then the next step is curing of the composite. These are the various curing lights which are available. The first one is the QTH. This is the oldest one. In these lights, most of the energy is converted into heat, and so we have fans present in these lights for cooling, and they deliver a light of very low intensity, which has been stated by the manufacturer. So they are being replaced nowadays by these LED lights. These lights, they are very handy, and at the same time they deliver the light of a very high intensity, which is collimated, which is focused, and we have multiple wavelength options available with these light systems. Multiple wavelength means depending upon the photo initiator that is present in our composite material, they offer different wavelengths of light. Most of the composite materials, they have camphloquinone as a photo initiator, and it is sensitive to the light in the area of 460 to 480 nanometers. But the newer composites, they have TPO photo initiators, and they are sensitive to the light of a lower wavelength, that is less than 420 nanometers. So these latest curing lights, they give us multi-wavelength option. They are available in pen style, so they can be taken to the back of the mouth easily, and they can cure the entire restorative surface. They have good energy output as well. But these LEDs, they require a lot of maintenance, which we tend to overlook in our clinics. So if you have a good light, you will have a good depth of cure, and the composite restoration is going to have better function and better physical and mechanical properties. The most critical area of the class 2 composite restoration is the proximal box, and in the proximal box, the most important is the gingival seat. The gingival, because the light is not able to reach to this depth of A level. So the curing there is not complete. Now these are the various methods how we can prevent the post-operative sensitivity. We should prevent over-etching of the dentine. Over-drying of the dentine should also be prevented. And the solvents, if they are not removed during the drying step, they also result in post-operative sensitivity. If the material has not completely covered the prepared tooth, then also the post-operative sensitivity takes place. And if the material is not properly cured, this also results in post-operative sensitivity. Then the last most important thing is finishing and polishing. Our restoration should be well finished, well polished, so that it does not offer a surface which is plaque retentive. To prevent the failure of the restoration, the good finishing and polishing of the restoration is a must. These are the various finishing and polishing systems which are available, and the best one out of them is this enhanced Pogo system. They are not polishing tips नहीं कहते हैं, हम इनको polishers कहते हैं. They have simplified the entire process of finishing and polishing. After removing the excess, we can directly use these polishers from the Pogo system, and they give a very good luster and a very good surface finish to the composite restoration. So this is the case where we have taken care of all the steps which I have mentioned while doing the class 2 restoration. This is the class 2 lesion which is present in the patient. Pre-wedging has been done by using wedge guard, which have resulted in tooth separation. We can appreciate all the margins of the cavity well. Then this bite-time ring of the matrix system has been placed, and the composite restoration is being done in the increment. This is the final curing of the composite. This is the final finishing and polishing, and this is how a well-placed composite class 2 restoration looks like. This is another case which is actually a replacement. The patient had an amalgam restoration with secondary caries associated with it. The entire old restorative material has been removed under rubber dam isolation, and with the entire assembly of the matrix retainer in place. This is how we look for the entire depth of the proximal box with the help of a mark probe. Here it comes out to be 8 mm. Ideally it should be less. 8 mm, the level of the difficulty increases. जितना ज़्यादा हम subjectively जाते हैं, उतनी ही ज़्यादा class 2 restoration difficult होती जाती है. And then the adhesive is being applied here. It is being light cured. And then the composite material, the first layer which is being placed here is a bulk fill flowable material. And after that the composite is being filled in the prepared tooth. Light curing is being done. Then the occlusion is being adjusted. We should have minimum access so that the finishing and polishing time is reduced. Otherwise, 1/3 of the time is consumed in finishing and polishing only. This is the final restoration, and this is the follow-up radiograph. So here I conclude. All our composite restorations, they should be well contoured, they should have good contact, and they should have proper anatomy. We have many new developments in terms of materials as well as the equipment, and we should use them in order to make the entire process of placing a direct composite restoration simple, easy and more predictable, so that we can deliver long-lasting restorations to the patients. Thank you.
For sharing your knowledge with us. Before moving forward to our next keynote lecture, as Sir and Ma'am is present here, we would like to felicitate the speakers of today. I would like to invite Dr. Anmol Bagaria Ma'am, Dr. Ashish Chandra Sir to felicitate the guest speakers. Himanshi Rana ma'am. Please give a round of applause. Dr. Shweta Verma ma'am. Please give a round of applause again. Dr. Archana Nagpal ma'am. Dr. Vasundhara Pathania ma'am. The speakers, we would like to present the first prize from the Rangoli competition that was held in the cultural program, and it goes to the Rangoli team consisting of Pooja Sandhu, Pooja Rani and Pratya Gupta. Please give a round of applause for them. They have secured the first prize in Rangoli competition. A hearty congratulations to all three of them. Thank you, Sharon ma'am. We will proceed with the lectures.
Keynote speaker, Dr. Archana Nagpal ma'am, a brief introduction about her. She is a professor and head Department of Maxillofacial Prosthodontics and Implantology from Himachal Dental College, Sundarnagar. Please give a big round of applause for her.
So now moving from endodontics to prosthodontics. Is everybody ready to listen?
Yes, ma'am.
Once in the back side of the seats, are you ready to listen to prosto? Okay. So the aesthetic procedures, they have changed so much during the past few years. But still the basic fundamentals of prosthodontics, they are helping a lot many patients which visit our clinics or colleges in day-to-day practices. So today I am going to discuss with you basic fundamentals of prosthodontics that are applicable in the field of aesthetic dentistry. So today I am going to unveil the artistic approach and meticulous craftsmanship of a prosthodontics in the field of aesthetic dentistry. So aesthetics can be defined as the branch of philosophy dealing with beauty. In prosthodontics, aesthetic doesn't mean putting teeth merely in the occlusion rings, but we all must understand the science and physiology of oral structures, anatomy and physiology very well, and then apply this knowledge to create beautiful, natural looking prostheses to the patients. So aesthetics in prosthodontics can be covered under four main headings, that is aesthetic approach in complete dentures, aesthetics in fixed partial dentures and implants, aesthetics in removable restorations, and aesthetics in maxillofacial prosthodontics. So let's cover the complete denture aesthetics first. So, fundamentals of aesthetics are covered under five main headings, that is visual perception, that is the subjective evaluation of beauty by individual. Second is composition of dental aesthetics, that
prosthesis. Third is proportion, that includes the form, size and positioning of the teeth and inter-arch and intra-arch relationships of the teeth to each other. Then there is dominance. Dominance means positioning of the teeth so as to give more pleasing appearance to the anterior teeth. For example, central incisors are the dominant teeth in a pleasing smile, so they have to be given dominance. Then illusion. Illusion is art of creating something which is not actually present. So we are mainly encountering many cases where we don't have enough space or we have too much of space. So we can give aesthetically pleasing restorations by creating illusion in those kind of cases, which I will show you later on. So you see this smile and now you see this smile. See, after giving the denture, the smile has totally changed. So when we talk of complete denture prosthodontics, we all must have heard about the dentogenic concept. Have you all heard of the dentogenic concept? It was given by Frush and Fisher. It says the teeth are selected according to the the teeth are selected according to the sex, personality and age of the patient. Under sex we have females and males. So for females we have rounded teeth and for males we have square teeth. Similarly, under personality we have two types of personalities, either delicate personalities or we have vigorous personalities. So we choose delicate rounded teeth for delicate personalities. Some males also have delicate personalities, some females also have vigorous personalities. So you judge those personalities and choose the teeth accordingly. And then according to the age, we can choose teeth. We can, for the giving appearance of age, we will choose teeth that are that have good anatomy in younger patients, and we will choose teeth that have worn out margins, or we can create those margins, incisal edges in the patients who are not so young. So then second is your diagnostic interpretation of the dentogenic concept. This is the actual application, dynamic application of the dentogenic concept, which includes tooth, its position and the denture matrix. So dentogenic concept is a static thing जो आप predict करते हैं कि आप ऐसे करोगे. Then diagnostic interpretation is the dynamic thing कि आपका denture मुंह में function कैसे करेगा, ठीक है? So उसमें आपका सब कुछ आता है, दांत भी आते हैं, उसकी पोजीशन भी आती है, और जो आपका डेंचर मैट्रिक्स होता है, जो आपका जो डेंचर बेस है, that is also included in that. So अगर आपका tooth है, tooth mold you choose according to either females or males according to the personality. Then you can change the position of the teeth. ठीक है? अगर आप दोनों सेंट्रल जो teeth arrangement है, that is also a very artistic approach. ठीक है ना? तो अगर आप एक बहुत विग्रस पर्सनैलिटी का पेशेंट है, उसको आप सेंट्रल इंसाइजर्स और लेटरल इंसाइजर्स दे कैन बी सेट एट द सेम ओक्लूजन प्लेन, so that will give more vigorous nature to the tooth arrangement. Similarly, if you have a female patient with very delicate appearance, then you will set your lateral incisors slightly above the plane. They will not be at the same level as your central incisors. Similarly, the canines, if you have to give dominance to the canines in the vigorous personality patients, you have to set your canines at the occlusion plane level. If you want to give delicate appearance to the dental arch, then you will slightly raise the canines above the plane. ठीक है? और अगर आप बहुत ज़्यादा vigorous personality का patient है, तो आप central incisors और lateral incisors of the same width can be used. So आपके patient को ज़्यादा vigorous appearance देंगे. Similarly, ज़्यादा
for slightly yellow color of the teeth. Then we come to the denture matrix. Denture matrix is the denture base, जिस पे हम जनरली बहुत ज़्यादा ध्यान नहीं देते हैं, बिकॉज हमें लगता है कि ठीक है ये तो लिप्स के नीचे छुप जाएगा, बट ऐसी बात नहीं है, ठीक है. We have to see if the patient has got a very high smile line. So most of the teeth as well as the denture base is also visible during the smiling of the patient. So in that case, you have to pay concentration to the denture base as well. So you have to carve exact anatomy of the denture base as is present in the natural teeth. If the patient is young, the root carving has to be more prominent. If the patient is slightly older, then the root carving can be little less. Then you can give stippling. Then you have to carve the gingival margins accordingly. They have to be well defined. Okay? And you have to see the complexion of the patient also. If the patient is fair, then your denture matrix has to be lighter in color. And if the patient is darker, then the denture base has to be darker in color. So you can also give pigmentation into the denture base area. So all these things will add more aesthetics to your complete denture prosthesis. So the secondary factors of dentogenic are called dianesthetics, and dentogenic concept and dianesthetic concept together, they contribute in denture aesthetics. So next, there are the factors of anterior tooth selection. We all have studied in our prosto classes, so no need to repeat them too much, but still for your knowledge I am repeating. Teeth selection, then we have to choose the size, form, color, shape and composition. ठीक है? Size मैंने आपको बता दिया. Size depends upon the size of the dental arch also. Then size of the face, personality of the patient. Then form, either ovoid, squarish, depending upon the personality of the patient and sex of the patient. Then color, depending upon the age of the patient and complexion of the patient. And shape, again ovoid, that also depends on the personality of the patient. Composition, we have two types of teeth available, acrylic teeth, porcelain teeth. So you can choose accordingly. Acrylic teeth are more commonly used because they are easily available. They can be adjusted anywhere in the dental arch without much of grinding. Grinding is easy, whereas for porcelain teeth it is very difficult. So now we have structure of aesthetic components. So first is your facial component, tooth visibility. That is very important. If the patient is young, the maxillary teeth are more visible. Okay, so if you are giving teeth to the young patient, then you have to give 2 to 4 millimeters of visibility to the maxillary anterior teeth. When the patient becomes older, the visibility of the maxillary teeth reduces and the visibility of the mandibular teeth increases. That is because of the musculature becoming weaker. So आपका जो upper lip है, that tends to droop, and lower lip also tends to droop. That's why more visibility of the mandibular teeth is there. So आपको अपने patient में यही चीज replicate करने की कोशिश करनी है. Then anterior tooth position, that I told you. If you want to give dominance to central incisors or canine dominance is also very important. So that position has to be taken care of. Then you have to see the smile line. Smile line, there should always be a convex smile line should be there. Concave smile line does not give a pleasing smile line. Then very important, your smile should follow the curvature of the lips. And there should be a buccal corridor, that is the negative space. Buccal corridor is the space between the buccal surfaces of your maxillary teeth and the inner side of your cheek. So if you create buccal corridor in your teeth arrangement, that gives a very pleasing smile. ठीक है? तो इसीलिए आप जब यहाँ सेकेंड ईयर के स्टूडेंट्स हैं, BDS सेकेंड ईयर स्टूडेंट्स आते हैं, so आपने BDS सेकेंड ईयर सबने किया है ना? So we are always after you
कि आप अपने ग्लास प्लेट रिलेशंस देखो. So if your glass plate relations are correct, then you will be able to give that buccal corridor to the patient. आपने देखा होगा कि patient कई बार ऐसे होता है कि patient always appears to be smiling even if he is not smiling, क्योंकि there is lack of buccal corridor in your teeth arrangement. So that should not be there. So you should always follow your glass plate relationships in which the distal surface of the canine, buccal surface of the first premolar, buccal surface of the second premolar, and mesio-buccal surface of the first molar lies in the same line. That has to be taken care of. Then lip support should be there. When you stand at the side of the patient, your lips should be slightly incisely tilted. Okay, so that has to be given. And then you have to see dental midline, and you have to see golden proportion or red proportion in your teeth. इसमें क्या होता है कि width of the anterior teeth, they are in a constant ratio with the width of the adjacent teeth. ठीक है ना? So golden proportion is that your central incisor, lateral incisor, and the visible portion of the canine from the front, they are in a constant proportion. That is ratio होती है उसकी, that is 1.618 is to 1 is to 0.6. ठीक है ना? तो आपको यही proportion create करने की कोशिश करनी चाहिए in your artificial dentition also. Either or we can give red proportion. Red proportion is your lateral incisor, width of the lateral incisor divided by the width of the central incisor multiplied by 100. So आपकी जो central incisor की width है, जो lateral incisor की width है, that should be 60% of the width of the central incisor. ठीक है? 10 is your golden proportion. You can apply any one of these proportions. 10 is your golden proportion. That is width of your particular single one anterior tooth divided by width of all the 6 anterior teeth multiplied by 100. So it should come in the ratio of 10, 15, 25%. Okay. So in a study conducted by our department in the local area, it was found that in this population, most applicable proportion is your golden percentage. So either of the ratio has to be followed while you are designing the smile or giving artificial teeth to the patient. So this has to be taken care of. Then I have talked about dental characterization in detail already. So why do we, in which case patients do we need to give dental characterization? If the patient has a very high smile line, or if the patient is a celebrity who appears in the public for very frequently, then you have to take care of this, or you have to understand the aesthetic demands of the patient. Because the aesthetic first visit is very important. उसी में आपको patient की aesthetic demands का पता लगाना जरूरी है. So in these cases you can give. Then after the complete dentures, we move on to the removable dentures. So it also, the aesthetic starts from the diagnosis phase only. Correct diagnosis, then correct surveying mouth preparation is very important. जहाँ पे आपको लगता है कि path of insertion, path of removal same नहीं है, आपको mouth preparation करनी जरूरी है. Where you feel you have to give crowns in order to improve the height of contour, you have to plan that also, and you have to plan your framework and your components so that minimum display of metal is there. Otherwise, that is going to hamper your aesthetics in the patient. Then similarly, prosthetic teeth and denture base and flanges have to be designed accordingly. So this is a case where we can see partial edentalism. And this is a case that has been corrected by giving a removable partial denture. So after the removable partial denture, we move on to the fixed dental restoration aesthetics. So if the patient wants a fixed solution for his edentalism, then we have to think about giving a fixed partial denture, that is in common language known as dental bridges, or we can go in for implants. So the most important from the point of view of aesthetics is our appearance zone, that is your anterior teeth till your premolars, and sometimes if the patient has a white smile, it is till the molars. आपने बहुत बार देखा होगा, बहुत सारे मूवी स्टार्स मूवी में आते हैं ना, they have got veneers, but generally they do it till the canines only, or maybe till the first premolar only. So you have to see the patient smile, and then you have to correct if you need to correct up till the first molars also. Then only you can achieve the best of aesthetics. So here we have facial components, dental components, gingival components, and prosthetic or physical components. They all have to be taken care of. So mainly we have to see three factors, that is soft tissue management, and सबसे important है formation of the finish line. We have to see where we have to give our finish line and which type of finish line we have to give. If the patient has a very high smile line and if you are restoring the anterior tooth, then you have to go in for subgingival finish lines. क्योंकि otherwise your restoration tooth margin is going to be visible and that is going to be very unaesthetic to the patient. So when you are giving a subgingival finish line, then you have to take care not to damage the gingiva. For that thing, you have to use very narrow end cutting burr to prepare this margin so as you don't damage the gingiva. Secondly, if you have given a margin, it has to be recorded in the impression correctly. Only then your final restoration is going to be correct. Okay, so you have to record the impressions correctly. In order to record correct impressions, you have to do the gingival retraction, and you have to be careful not to damage the gingiva while you are doing placing the cords. ठीक है? So इसमें जो है आपकी जो foam cords होती हैं, they damage the gingiva to a lesser extent. Otherwise, what you can do if you have to go for 2-cord technique, then you can place 000 cord first, and then above that you can place the foam cord also. Then thirdly, you have to give temporary restorations which have correct margins. Otherwise, that will also damage the margins of your gingiva, and the final restoration margins are going to be affected. So you have to take care of all the three things. Then your tooth preparation has to be correct. ठीक है? उसमें आपको you have to follow the anatomy of the tooth that is going to be prepared. इसमें आपको 2 plane reduction देनी पड़ेगी. Two-plane reduction is to be followed so as to give sufficient bulk of the material in order to achieve proper anatomy of the tooth and in order to give proper color to the final prosthesis. So you have to be very careful about that. Then shade selection in FPD is also very important, because अगर आपने बहुत अच्छी tooth preparation भी कर दी है, if your shade is not matching correctly, only even then it is not going to be very aesthetic. Okay, so for shade selection,
Hello.
starting from the CD till the FPD or veneers or anything else. You have to take into account all these prosthodontic principles to give a aesthetically pleasing restoration to the patient. Just wait.
So for shade selection in FPD, we have to take into account first thing where the teeth where you're selecting the shade, the adjacent teeth, they should be free of any dirt, any calculus, any stains. Only then you will be able to choose the shade correctly. Secondly, any contrasting mediums like lipsticks, dark makeups, dark gloves should not be there in the field of working. Otherwise, that will also interfere with the shade selection. And walls of your operatory should be also be in light color. Very dark walls will also interfere in shade selection. Then it has to be, generally it is advised that it has to be done in the beginning of the appointment so that your eyes are not tired, and it has to be done quickly. So that will give you a correct shade selection. We have so many shade guides, Vita shade guide, then 3D Vita shade guide, or we have digital methods of shade selection also. So correct shade matching is very important. Then translucency has to be in the restoration. Translucency is the tendency to, so it gives a very lifelike appearance to your restoration, especially in the incisal edges. The translucency has to be. The translucency has to be maintained. So we should use the materials which are more translucent like zirconia, and we should give sufficient reduction in order in the incisal edges. Sometimes in some patients only the incisal edges are visible. In that case, you have to take care of translucency so as to give more lifelike appearance to your Dilation is also very important. If the patient is young, we have to give more anatomy. We can give more ridges. If the patient is older, then we can go for slightly flatter. So आपको ये सब चीजें लैब वाले को communicate करना भी बहुत जरूरी है, ठीक है? So you can tell the lab person that I want this type of anatomy. You can send good pictures so that he replicates the same in your final restoration. Then, as we have talked about optic illusion, if you have very less space or if you have too much of space, you can give contours to your restoration so as they are more aesthetically pleasing to the patient. So you can make your teeth appear narrow by giving more convex surfaces. You can make them appear wider by giving flatter surfaces. Similarly, longer or shorter teeth or optical illusion can also be created. So dental, lot more is talked about dental implants these days, so I am covering it in a small 1 or 2 slides because dental implants are also very good alternative to fixed restoration nowadays because we don't have to touch the two healthy abutments which we used to do earlier. So we can place one dental implant, attach abutment and give a crown over it. So this is a case restored with dental implants. So whatever restoration we are planning, we should know the patient preference beforehand. So patient prefer minimum display of the metal collar. Then maximum thickness of porcelain material will enhance the shade of the restoration. For that, if you give thickness of the porcelain material, that will alter the contour of the restoration. For that, sufficient tooth preparation is necessary so that you give sufficient bulk to the restoration and also there is proper shade matching of the restoration. Then correct shade selection is also very important. And porcelain occlusal surfaces should be always given because they are more aesthetically pleasing to the patient. We should avoid giving metal occlusal surfaces. Sometimes we do that if the space is less, but wherever we can avoid, we should avoid it. and we should give subgingival margins whenever it is of esteemed importance, because subgingival margins are very difficult to clean by the patient. So if they are not required anywhere, they are not necessary, then you should avoid it. But when the aesthetics demand, we should go in for subgingival, gingival finish lines. So one more modality is your veneers. Veneers are shell-like structures which are attached to the surfaces of the teeth, and they correct small defects in the teeth like chipped teeth or discolored teeth, or if the teeth are less than normal height, they can be corrected with the help of, or midline diastemas can be corrected with the help of veneers. So these are some pictures of the cases corrected with the help of veneers. Then we talk about maxillofacial prosthesis. Maxillofacial prosthesis, 4 factors that matter the most are color, heterogeneity, translucency and texture. Color, basic color, we are all aware of hue, chroma and value. So we must choose the basic color first, and we can give heterogeneity to our prosthesis to give it a more lifelike appearance. Heterogeneity means age spots, freckles or moles can be given if they are already present on the other side of the face. Suppose if we are giving some prosthesis on the face, if patient has some features on the one side, then that can be replicated on the other side as well. Then we should give translucency to our prosthesis. Generally, if you hold your hand against light, it gives slightly red appearance. That has to be given to your prosthesis also. Suppose ear prosthesis, so your ear lobule is more translucent. So if you are replacing ear prosthesis, you have to give that character to your prosthesis. Then texture, we should replicate wrinkles, fine lines or folds in our prosthesis. So most important in maxillofacial prosthodontics is the coloring of the prosthesis. We generally prefer to give extrinsic staining, which is actually not that good as compared to the intrinsic staining, because extrinsic staining is not that long lasting. Intrinsic staining is more long lasting, so we can add pigments, threads, etc. and we should try to give intrinsic staining first and try to correct slight color discrepancies by giving extrinsic staining. And extrinsic staining can be done in the form of stippling or spray painting. Then we can add enhancers which will add more aesthetic appearance to your prosthesis. Enhancers are your eyebrows, eyelashes, mustaches or spectacles. So these are some of the cases that are being corrected by giving maxillofacial prosthesis. So these are some of the cases done at the Department of Prosthodontics, Himachal Dental College, Sundanagar. This is the cheek plumper prosthesis. If a very old patient comes to you, generally there is lack of muscle tonicity, and so your cheek muscles try to sink in. Okay, so in order to restore that facial defect, we can give cheek plumper prosthesis. जो conventional cheek plumpers थे, they were made of single piece only, but that made the prosthesis very wide, and it was very tiring for the patient to wear that prosthesis all the time. So now we can go in for detachable cheek plumpers, which can be attached to the dentures with the help of either magnets or teeth buttons. So they can be removed by the patient if the patient feels tired during the day, and other time he can wear it. So you can appreciate the correction of the defect, the cheek defect, by giving cheek plumpers. Then to this patient we gave denture characterization because his lips were very black and he didn't want that pink type of denture for himself. And this is the anterior tooth replacement with the help of cast partial dentures. Then this is the maxillary arch rehabilitation with the help of PFM crowns. And this is again a case of anterior crown, PFM crown, all ceramic crowns. Then this is the, can you see the discolored restorations? So this is being corrected by the help of veneers. And this is a very interesting case. He reported to our department for fabrication of complete dentures, but we observed he had defective ears also. So we motivated the patient and made him dentures as well as ear prosthesis, and see the change in his personality after getting the ear prosthesis. So this is the diastema closure with the help of veneers, and this is anterior post and core. If you have a broken tooth, then you can restore it with the help of post and core. So this is an anterior implant placement, and this is the department. It is well said that God creates and we recreate, and this is the department where we create beautiful smiles every day. And this is my team of efficient doctors and my dear students. We work together and give beautiful smiles to the patients. 6 more faces have been added to this. Now we will add them to the picture soon. And thank you for your patient hearing.
Good afternoon, everyone. You all must be tired, waiting for the lunch. So, when you know me, I am Dr. Vasundhara from the Department of Periodontics. I am the professor there. Now speaking, I keep on taking lectures in the classroom, but speaking in front of my teachers, Dr. Devendra is sitting here, Dr. Archana is sitting here, Vijay sir is sitting here, Manjeet sir is sitting here. It is really scary. I can understand how you people present in front of us.
We all have got so much confidence in nobody.
So, I am really thankful to Cynodent, Dr. Anil Sinha sir, Dr. Baljeet sir, Dr. Sahil, Dr. Shweta, who has given my name for the presenter. Otherwise, I was not going to present in the conference. So, before starting my presentation, I will want you to know about the making of the presentation. आप लोग देखते हो ना मूवीज में आजकल आता है मेकिंग ऑफ द मूवी, तो मेरी प्रेजेंटेशन की भी एक मेकिंग ऑफ द प्रेजेंटेशन स्टोरी है. What happened yesterday, day before yesterday, my laptop crashed. जब मेरा लैपटॉप क्रैश कर गया तो I was thinking कि बस अब no presentation, I won't be giving any presentation. कल रात को पार्टी में नाचते रहे 11 बजे तक with you all. 11 बजे मैं घर गई, मुझे देवेंद्र सर की बात याद आई. देवेंद्र सर was praising me day before yesterday only. वसुंधरा किसी काम को ना नहीं करती है, तो मेरे ख्याल ये पहली बार ही ना हो जाएगा from my front. So I arranged for the laptop at around 11 o'clock. सुशांत gave me a call कि मैं लैपटॉप लेके आता हूँ, तो मैंने कहा नहीं कोई बात नहीं, मैं अरेंज करती हूँ. मैंने अपना मिनी लैपटॉप ढूंढा and I started making my presentation, and I made my presentation till 2. 2 बजे तक मैंने प्रेजेंटेशन बनाई. अभी स्टोरी बाकी है. 2 बजे लाइट चली गई. आप लोगों को पता हो तो रात को 2 बजे देर वाज अ ब्लैकआउट. लाइट चली गई और मैंने अपनी प्रेजेंटेशन को सेव नहीं किया था. सो माय प्रेजेंटेशन अगेन एट एंड. तो 2 बजे के बाद 3 बजे तक मैंने मोबाइल पर अपनी कोरियन सीरीज देखी. 3 बजे लाइट आई. अगेन आई स्टार्टेड मेकिंग माय प्रेजेंटेशन and till 5 o'clock I made this presentation. So I am standing here कि मैंने भूमिका बताई है आपके सामने. ये एक भूमिका है कि इस प्रेजेंटेशन में बहुत सारी कमियां रहेंगी. So please bear with it and listen to it carefully. Now I want to thank my PG students, Dr. Sushen, Dr. Ayman, Dr. Sakshi, who has helped me a lot in arranging the radiographs. इन्होंने मेरे लिए हेल्प करा और ये radiographs को अरेंज किया है. And of course with the help of my teachers, my friends, Dr. Ankita is sitting here, Dr. Kamal Kishore, Dr. Amit, they all were very supportive and they helped me in making this presentation. So I am standing here smiling in front of you because life is short. Smile while you still have teeth. Okay, so I'll start my presentation. So when a systemic review in 2019 was done, it was found that the prevalence of dental caries, early childhood caries in India was found to be 49.6%. Similarly, systemic review and a meta-analysis which was performed in 2022, we found that the prevalence of ECC was 46.9%.
That means every 2 children in India, they are suffering from ECCs, which is a huge number. So, there is again a common myth among the people in India that milk teeth, they are not important and they will fall off soon and they will be replaced by the permanent teeth. So, in reality, this concept is far from the truth. So, my aim of my paper presentation is I will tell you about the importance of the deciduous teeth and how we can save these deciduous teeth. So, I will be speaking on let your teeth live their life. We all know deciduous teeth, they are highly important. They are very important for mastication, for aesthetics, for eating food. And if we lose the deciduous teeth early in life, we can have space loss. That means we can lead to future orthodontic problems, future endodontic problems, and future conservative problems as well. So, our main intention is to save the deciduous tooth. So, we'll be discussing about various procedures we perform in our department for the safety or the protection of these pearly smiles. So, the first and the utmost important thing is prevention. Prevention is better than cure. As we all know, we have heard of this. So, how can we prevent the disease? How can we prevent the caries? The most easiest way is brushing. Brushing twice, as we all know. आपने सुना होगा quote, eating apple keeps a doctor away. So brushing twice a day keeps a dentist away, and I think dentist is more scarier than your doctor. Another, fluoride applications. Frequent fluoride application will definitely prevent you in the progress of dental caries. And another most important aspect is the diet counseling. The diet counseling to the students, the children, and diet counseling to the parents, because parents are the people who are providing the toffees, chocolates, and the sticky food to the children. So I believe it is more important to counsel the parents than to counsel the children. Now, if the patient has suffered from caries, he has started initial caries, then you can call since we are in the pediatric departments, we often encounter the children which we cannot control. So for these children, there is a recent material which is the STF. You must have heard of this silver diamine fluoride. Silver diamine fluoride is a recent material which we apply on the teeth. This is a carious tooth. So silver diamine fluoride, when we apply, all these cases which I will show, they are done in the department. Except for 1 or 2, all the cases they are done in the department of periodontics only. So this is the case of the STF application. This is the carious tooth. This is the early childhood caries patient. So when we apply STF, this is the immediate result. Now the biggest disadvantage of STF is that it causes a discoloration of the tooth. But I am telling you, this is the only remedy and the best remedy for the child. If you will not do this, then your child will ultimately go for the pulpotomy procedure or the pulpectomy procedure, which will be very difficult to handle. Okay? This black discoloration can be handled by the application of the potassium iodide, but potassium iodide will definitely reduce the potency of silver diamine fluoride. So this is the easiest way to handle, even in the child of 1 year of age or 2 year of age. If you apply this STF, you can arrest the caries. STF will burn the caries. It will arrest the caries. जहाँ पे caries है, caries वहीं पे रुक जाएंगी. It will basically burn the caries, and there will be no progress of the caries. Fine. Similarly, if the child is cooperative, then our standard protocol GICs. You can go for GIC treatments whenever the patient comes. Then you go for the GICs. Now, the next approach will be the composites. Composite restorations, you must have heard of composite restoration in children. Since the salivary contaminations are more in children, because you cannot, rubber dam application is not an easy task in children. You have to go for the cotton plugs or the cotton pellets, but salivary contaminations are there. So the easiest method is the use of the strip crowns. These are the strip crowns, these are the celluloid crowns, or you can say these are the plastic crowns. What we do is, whenever the patient with the caries come to us, we remove the caries. After etching and bonding, we put the composites in these crowns, in strip crowns, and then we apply these crowns on the tooth. After curing of these crowns, then we can easily remove, we can Zirconia crowns are also there, though they are expensive. If you can afford, you can go for the zirconia crowns. Again, the patient with the caries has come. If the caries are deep, go for the bulbectomies first. You can give post, fiber post, and finally the zirconia crowns you can give. Of course, it is very costly. As I told you, people are not willing to save the deciduous teeth. So the initial cost price of the zirconia is 1800. 1800 रुपया में एक क्राउन आपको मिलता है. और when you say to the patient कि आपका हम will charge 10,000, तो वो अपने आप ही रिफ्यूज कर देता है for this treatment. But of course, zirconia crown is the treatment of choice. Okay. Then comes the pulpotomies. Now, what is a pulpotomy? Now, if your infection has from the crown, the infection has spread to the pulp, and your patient has gone into the cases of irreversible pulpitis, then the treatment of choice, initial treatment of choice is pulpotomies. Now, in pulpotomies, what we do? We remove the infected coronal pulp. This is the coronal pulp. We only remove the infected coronal pulp, and the reticular pulp, the healthy reticular pulp is left over. What we do is, after removing the coronal pulp, we stop the bleeding with the help of the saline pellets, and if the bleeding stops, then only we apply the medicaments. The medicaments like you can apply formoprazole, you can apply MTA, you can apply Biodentine. That is the material of your choice. Whatever material you want to choose, you can go for the pulpotomy procedures. And finally, this is only you will do if you are able to stop the bleeding with the normal saline pressure, not with the medicament. This is the key rule. You will not stop the bleeding with the medicament. You have to stop the bleeding with the saline. Okay. So this is the case. This is the case of irreversible pulpitis. When the access cavity was made, we entered the pulp chamber. We arrested the caries bleeding with the help of the cotton pallet dipped in saline. So finally, the pulpotomy procedure was performed, followed by the stainless steel crowns. Stainless steel crowns, they are important because if the filling or the restoration it breaks, it can reinfect the tooth, and finally your tooth can lead to pulpectomies. Okay. The next is the pulpectomies. Now, if we are not able to stop the bleeding, we are not able to achieve the goal which we want, then we go for the procedures of the pulpectomy. In pulpectomy procedures, we will remove the pulp from both the crowns as well as the reticular pulp. Fine. You will take the working length. After taking the working length, you will obturate the tooth, and finally, the material of choices can be again your choice. You can fill the tooth with zinc oxide fusinol. You can fill the tooth with Metapex. You can fill the tooth with any other material, endoflast, cry, paste, Myosto paste. There are so many materials which are present. Whatever material you have, you can obturate your teeth with the material of your choice. So here comes the patient with the irreversible pulpitis. Working length was taken. After copious, one more thing I want to say, there is a difference between the BMP procedures in the routine endos, RCTs and the pulpectomy patients. In the pulpectomy patients, we prefer more of a chemomechanical. Chemomechanical means more of a irrigation than your BMP, than your mechanical use. Filing and removing less, more irrigations. हमको सिर्फ उतनी ही फाइलिंग करनी है ताकि we can make a room for the obturation. Okay, so you don't have to आपको proper step back, step down वो वाला techniques follow नहीं करना है. You just have to do the BMPs minimal and then copious irrigation. Irrigation is the key factor for the success in the pulpectomy procedures. So this is your working length. After working length, obturations with zinc oxide fusinol. This is the case I've done. This is the obturation with zinc oxide fusinol. Stainless steel crown, which is mandatory in a pulpectomy procedure. After this, as you can see, there is no tooth here and permanent. There is a time for the eruption of the permanent tooth. So this was followed by the presence of the space maintainer, followed by backing tooth. One more case. This is the case of irreversible pulpitis. You can see working length has been taken. Same rule as we used in the endo. 1 mm short, 2 mm short. As per the Cohen, you can take 1 mm short. As per the Inger's method, you can take 2 mm short. There is another method which is the Garcia-Godoy method, which says you have to take the working length above the line imaginary line to be drawn above this tooth because there are chances of resorption of the roots. So you will obturate till hair, not till hair. Okay. So this is the obturation again with zinc oxide eugenol, and this is the stainless steel crown. These are my cases. हमारे टाइम पर zinc oxide eugenol ही मिलता था डिपार्टमेंट में. So we have done most cases with zinc oxide eugenol. अब कल के बच्चे करते नहीं हैं. This is tedious procedure. अभी मेटापेक्स का प्रचलन है. I always think zinc oxide eugenol is definitely a better material than metapex. Now next comes are the young permanent teeth. अभी तक तो deciduous था. Now young permanent teeth, which also we see in the Department of Periodontics. So in young permanent teeth, the traumatic dental injuries are the most common cause of the cases which we encounter, and these generally occur in the children between 2 to 3 years of age, okay, in the deciduous dentition, but in the permanent dentition at the 8 to 12 years of age, it is the most prominent age for the traumatic dental injuries. The teeth most frequently encountered are the maxillary anteriors. Now what happens in the young permanent teeth? How they are different from the permanent teeth? They have the open canal, open blunderbuss canals. These are the blunderbuss canals. What are they? They are wider at the apex than the cervical areas. So the treatment has to be different from the, as in the permanent dentition we go for root canal treatments, whereas in the deciduous, in the young permanent dentition, as per the vitality of the tooth, the treatment will differ. If your tooth is vital, then we go for the procedures of the apexogenesis, and if your tooth is not vital, then the procedures of apexification will take place. So as I told you, the treatment of the crown fracture will depend upon the degree of the pulpal exposure, how much is the pulp is exposed, what is the time interval between the accident and the examination. This will determine whether your case will go for the apexogenesis or apexification, and the stage of the root development. As I told you, these are the cases in which we have the open apex. So first of all, in the teeth which are the open apex, the vital tooth. In the vital tooth, the procedure which we perform is the Schweck's pulpotomy. This is the procedure Schweck's pulpotomy. So whenever a patient comes to you in a traumatic Ellis class 3 fracture, in which the exposure time is less than 24 hours or say 48 hours is okay, then what we do is we enter the pulp chamber. Only enter the pulp chamber, we remove the pulp, around 2 mm of pulp has been removed, and then we try to stop the bleeding again with the normal saline. If the bleeding stops, it is okay. If the bleeding doesn't stop, then again go below 2 mm more. Fine. Again then you go 2 mm more. Again if you keep the saline pack, cotton pack, if the bleeding stops, then again it is okay. If it does not stop, then again go down. You can go till here. अगर आपका थोड़ा सा भी पल बचता है, आपको बचाना है, आपने उसमें ये नहीं करना है कि बुक में लिखा है कि 2 mm तो बस 2 mm. Keep on going down. जहाँ पर भी आपको ब्लीडिंग स्टॉप हो जाता है, that is the point जहाँ पर आपका healthy pulp है. And our main aim is to preserve that healthy pulp. Okay? Now when you stop the bleeding, after that you will place the medicament. Now again the medicaments you very well know: calcium hydroxides, MTAs, biodentines, lasers. You can use any product whichever you like, followed by a good restoration or a good steam. This good restoration is very important because if you are using calcium hydroxide and your filling or your restoration breaks, your procedure is going to fail. Fine? So I will be showing you two cases. So this is the first case. This is a vital tooth with Ellis class 3 fracture. In this we performed the Schweck's pulpotomy. Schweck's pulpotomy by the help of calcium hydroxide. You can very well appreciate the bridge which has been formed. With calcium hydroxide, there is the only one drawback is there. It takes minimum 6 months to 12 months to form this barrier. जब तक ये barrier नहीं बनता है, there are chances of the reinfection of the tooth, which we will not encounter with MTAs or biodentine because they set within the period of 2 hours. Up 2 hours के बाद, they are your tooth is safe, you can say. But if the procedure fails, then it is very difficult to reassess the tooth in which you have used MTAs, and it is very easy to use calcium hydroxide. You can easily enter the enlarged if the procedure fails. Okay, so I prefer to do apexiogenesis with calcium hydroxide rather than MTAs. Of course, we have to give a good restorations. So you can see this is the post-op after 6 months. There is an increase in the width and length of the root. Apex is closing. All the patients are under follow-up. One more case. Again a case in which you can see an open apex. Schwetzman botany has been performed. Again with calcium hydroxide. This is the follow-up after 3 months. Follow-up after 6 months. And this is the follow-up after around 12 months. The patient is still under observations. We have to keep these patients under observation for at least 2 years or 3 years. This is a case with MTA. And this MTA has been placed and the apex is closed. These are wonderful procedures. You can save your teeth. See, open apex and the apex they are growing. Now this was the scenario for the tooth if it is vital. Now if your tooth is not vital, then of course the opposite procedure, that is the apexification, we go for apexification. Now in apexification, what is the method in which, this is the method in which we induce a calcific barrier here. Now there is no pulp, there is no chances of growth of the root, so we have to artificially induce a barrier here. Now again, same materials can be used, calcium hydroxides, MTAs, biodentines, bone morphogenic proteins, whatever material you want to use, you can use. Now in apexification, like in apexogenesis, I suggested you calcium hydroxide. In apexification, I will suggest you MTAs, because when you place calcium hydroxide, as I told you, it will take around 1 year to form the barrier. Until then 1 year you cannot obturate the tooth. But if you use MTA, the barrier will be formed within 2 hours. The next day you call the patient and you obturate the teeth. Or the recent materials have come, biodentine. In a single visit also you can obturate the tooth and it will be free. आपको पैसे चाहिए जल्दी जल्दी, use MTA or biodentine. आराम से काम करना है, go for calcium hydroxide. Calcium hydroxide is I think 10 times cheaper than MTA. So it is of course what is the paying capacity of the patient and how much do you want to earn. The treatment will also depend on that factors also. So let us see few cases of apexification. Open apex, working length has been determined. This is the placement of the MTA. MTA plug has been formed and obturation in the same visit or next day. Quick relief to the patient. This is the case with calcium hydroxide, open apex in a premolar. You can see so much of infection is there. Calcium hydroxide, we place calcium hydroxide to reduce the infection. After calcium hydroxide, we repeatedly kept on putting the calcium hydroxide for a year because it keeps on dissolving. After 3 months, 6 months, we changed the calcium hydroxide, and after the bridge was formed, finally the obturation was made. One more case of apexiogenesis in second permanent molar. You can see working length. Again calcium hydroxide push. These are my cases. उस टाइम पर MTA नहीं था. पुराने cases obturated with. After we waited for a year, after a year we found that stop जब नहीं किया, we felt the barrier has been formed, then obturation was done. Again a lovely case, open apex, working and determination, placement of the MTA and obturation. Now the last topic, revascularization, which is a very in topic. So it is a procedure, revascularization. Simple language में मरी हुई चीज को जिंदा करना is revascularization. Okay, so it is a procedure to is that if a sterile tissue matrix is provided in which new cells can grow, pulp vitality can be re-established. So the success of the revascularization, it depends on three main factors. First one is the root canal disinfection, the presence of the scaffold, and the hermetic coronal seal. Now this is again the most important step. आपको कुछ भी procedures करना है, I think disinfection is the most important step in every aspect. So in the revascularization cases, as I told you, calcium hydroxide is a very good source of disinfection, but it dissolves. So the recent thing which we are using is the 3-mix. 3-mix is the antibiotic paste in which we generally mix these three antibiotics: metronidazole, ciprofloxacin, minoxidil. In the ratio of 1:1:1, we take these antibiotics and then we mix it with either with propylene glycol or with the help of the saline. You will mix them and you will place them in the canals. You will let the tooth disinfect for at least 15 days. If your patient comes to you after 15 days without any clinical signs, all the clinical signs like abscess will resolve. If abscess is still there, again go for the antibiotic paste, put antibiotic paste for another 15 days and again recall the patient. Now, if there is no clinical signs and symptoms to persist after 15 days, we will go for step 2, which is again the most important step, number 2. Now what we will do is, this is the periapical areas. Our intention is to introduce the bleeding. Now, if you all have read the dental anatomy and we know this area, this periapical areas and this rotary sheath areas, these areas they are the home for the stem cells. Many stem cells or the maximum stem cells in the body you can find in these areas. So what we do is basically our aim is to stimulate these stem cells. What we do, we will take a working length, say the working length is 15 mm, okay, then we'll keep the working length to at least 17 mm. After we have to give local anesthesia, again we prefer the plain local anesthesia without vasoconstrictor. We prefer not to give adrenaline so that we can have ample amount of bleeding. We want blood. So what we will do is we prick here and poke or keep on pricking at the index. यहाँ पर आप चुभोएंगे उसको बच्चे को. And after this, we will let the blood come into the canal. When the blood comes into canal, wait for 5 minutes, 10 minutes. पीछे लोग हमारे भी बड़े worried हो जाते हैं, खून नहीं आ रहा, blood नहीं आ रहा, blood नहीं आ रहा. We always tell them, wait, relax, wait for 5 minutes, let the blood come. You will see the blood. When the blood comes, you can see it. Let the clot form. Once the clot is formed, place the MT over it. Now, why MT? Again, you can place calcium hydroxide. Of course, you can place calcium hydroxide, but again, I am telling you, if calcium hydroxide, if your restoration breaks, your calcium hydroxide is going to break and your procedure will be a failure. So again, in this procedure, I will recommend the use of MTAs or bio-MTAs. So use this MTA, place MTA, and then close the tooth, and then keep on asking the patient, recall the patient after 3 months, 6 months, 9 months, till you find the growth of the root. Now, this is a simple procedure. Again, the concepts of PRPs and PRS we have discussed yesterday. Another important things for the growth factors, they are the PRPs. Now, do you know how these PRPs and PRS are made? आप लोग सब कल से PRPs and PRS सुन रहे हैं. Do you know what is the procedure of forming these PRPs and PRS? I'll tell you in small, छोटा सा बताती हूँ आपको. What we do is, we take the blood of the patient. आप बच्चे से blood लेते हो, okay? Then we put the blood in a tube, test tube. Then after putting the blood, what we add in it? Anticoagulant has been added. ताकि आपका blood एकदम से coagulate ना कर जाए. We put anticoagulant, and then first we go for a soft spin. First soft spin, धीरे धीरे वाला spin. When we go for a soft spin, these three layers will come. First of all, these RBCs will settle down at the bottom. Then this plasma will come there, and this small buffy layer. This layer is the source of the platelets. यहाँ पर आपको platelet मिलेंगे, and this is the layer which you want, PRPs. Now what we do is, it is very difficult to get this layer at this stage. What we do is, we take a test tube again, then we take this plasma and this buffy coat, we will discard this RBC. RBC को फेंक देंगे आप. We'll take this PRPs, this buffy coat, and this stage you will throw this platelet poor plasma, इसको फेंक देंगे आप, and these two layers will be left. You will use these two layers. This is the PRP. हम जो यूज करते हैं, this is that layer. अभी भी खत्म नहीं हुआ है प्रोसीजर. इस PRP में then you will add the thrombin, bovine thrombin you will add. You will add calcium chloride. आपको hemostasis की अपनी clotting cycle अगर याद हो, तो to produce the fibrin, there was a cycle. So to induce that cycle, we will add thrombin and calcium chloride, and finally the fibrin will be formed, which will help in the hemostasis. Okay, so this is a very complicated procedure. The other one is the PRF, simple procedure, nothing has to be done. Blood निकालिए, no anticoagulant has to be added. Since we are not adding any anticoagulant, that means immediately we have to go for the centrifugation. Within 20 seconds, 30 seconds, go for the centrifugation procedure. After centrifugation, you will get these three layers. This is the plasma poor layer, this is the fibrin clot, and this is the RBCs. Now we need this fibrin clot PRF. See, this is the PRF. It can be easily removed. Okay, this fibrin PRF, it has excellent number of growth factors, maximum number of growth factors, better than your PRPs, but they are very difficult to manipulate. So if you keep on studying the articles, you will find that they always say PRFs, they are better than your PRPs, but the manipulation of PRF is very difficult, so we often use PRPs for the patient and not the PRFs. Okay? यदि कोई पूछेगा तो definitely PRF is a better option because it has maximum number of growth factors. Another thing I want to say, अगर आप लोग studies पढ़ेंगे तो it has been quoted that if you do not put PRPs and PRS and simple blood clotting thing as we do that simple pricking thing, they also give the 100% same results as these things are giving, except अगर इसका रिजल्ट एक साल में आएगा तो विदाउट दिस द रिजल्ट विल कम इन 1 year 15 days मोर, तो 15 दिन का फर्क पड़ जाएगा. ठीक है, तो आपको 15 दिन 20 दिन का फर्क पड़ाने के लिए बच्चे को प्रिंट करके उसका ब्लड निकालना है, उसको तंग करके परेशान करना है, बिकॉज वी नो चिल्ड्रन दे आर नॉट वेरी कोऑपरेटिव. आप पहले उसको इंजेक्ट कर रहे हो, देन अगेन यू आर सकिंग हिज ब्लड, तो child is not going to cooperate. So the results are the same, the difference is only in the time period. Okay, so let us see few cases. These are the cases again in our department. Open apex case, we induce the bleeding, MT has been placed, and you can appreciate the growth of the root. Apexogenesis. Apexogenesis in a non-vital root. मरी हुई चीज को जिंदा करना. Open apex, working length नहीं बोलो, induction of the bleeding. This is a case in which PRF has been placed. Mild calcification you can see. One more case, open apex case, non-vital tooth. We induce the bleeding. MT has been placed. And you can appreciate the closure of the apex. Open apex, bleeding has been induced, MTA placed. Very well you can appreciate the growth of the root. So this is the wonderful procedure. But it needs time and patience. Because the results are not going to come in a day. It can take 2 years, it can take 3 years, it can take 4 years, it can take 5 years. So the follow-up of the patient is also mandatory, but it is a very simple procedure and a very good procedure. Now, बच्चे लोग हमारे लिए परेशान हो जाते हैं कि मैम रिजल्ट नहीं आ रहा है, रूट नहीं बन रही है. So the result is not the root formation. Many different results can be seen. If you find the absence of the symptoms and the radiographic evidence of the periapical healing, it is a success. 1. If there is increase in the thickness of the root canals, increase in the length of the immature root, again it is a success. Success does not mean कि आपका apex को close हो जाना है. So all the vitality of the tooth is the ultimate goal. I don't know if this happens or not, but paper claims or the literature claims the vitality happens. These are all the outcomes of the revascularization. So please attempt revascularization, and if your teeth is infection free, that means your procedure is a success. So you can see increased teeth wall width and root end development, or you can find insignificant continued root development associated with apical closure. In type 3, root end development without apical closure. Type 4, calcification is seen. I told you in one of our case we have seen calcification and mineralized tissue barrier between MTA cervical gland and the radicular apex. Anything happens, it is a success. Okay? So finally, I would like to conclude. Everybody has a right to live. Right to live life is the belief that a human being or an animal has the right to live, and in particular should not be killed by another entity. Your teeth is meant to last a lifetime. Take care of them and they will take care of you. Thank you so much. Thank you so much for
Forward with our next keynote lecture, there is also an offline session by Dr. Baljeet Singh sir. He is principal of Himachal Dental College, Sundarnagar. He is one of the respected dignitaries and he is a very dynamic personality who is well known among the students. Kindly give a huge round of applause.
Dr. Pulkit. Dr. Pulkit, he has joined us from New Delhi, and he will be speaking on a very good topic, that is on dental photography. Okay. So I'll request you all that please stay back for his lecture also. Okay. Girls and boys also. Worthy Director Sir, my elder brother Dr. Vikas Sir, Anika Babiji, senior faculty members, Vice Principal Dr. Devinder Sharma ji, and my dear postgraduate and undergraduate students from Himachal Dental College and other colleges also. I feel honored standing before you all here with my presentation. This is a presentation which is very close to my heart. I've been presenting it for the past, I think, more than 8 or 9 years, but in the form of small parts. Okay, now since we people are already late a bit, so I'll start with the presentation that is pink for the sake of white. Together they look beautiful. Okay. So at the end we'll see that whether it is pink or white, alone they look beautiful, or is it together they look beautiful. Can you have that slide? So first of all, let's have a smile on your face, please. Is it there? Yeah? So when you look at the smile, how it looks like? Is it a straight line? Or is it in curve? It is in a curve, definitely a curve, a huge curve, but a curve which, if it is properly given, it will set the tone and it will try to straighten up everything. Okay, now that boy is sitting with their last line. Cheers on this. Look at that. Look at their smile now. Can you recognize who is this pretty lady? Priyanka Chopra. Pariniti Chopra. Okay. So how did you recognize this? How did you recognize? Intelligence. See, as I said earlier, I keep on, I have been presenting this particular topic since long, for the past 8-9 years, and the face which I keep in my presentation, that also keep on changing. Most of the time it depends on that whether my wife is sitting in the audience or not. See, during lunchtime we were having a discussion. I wasn't getting the name of the previous beautiful face that was there in my presentation, so I asked Vasundhara that who's that Sri Lankan actress? Jacqueline Fernandez. So she was earlier the face of my presentation, but I think if you people remember recently she was involved in some illegal activity, so I thought better we remove that face now. So I was looking for a good face, and I'm really a great fan of Pariniti Chopra. So I thought of putting this face, but at last, I'll tell you, I'm broken again. She is married to a politician. Okay, but anyhow, so we'll manage Pariniti today. Now see, now beginning with the presentation, that was on the lighter side of the presentation. Now see, when we talk about the personality of a person, there could be different factors that will determine the personality of a person. There may be different gauges, different tests to assess the personality of a person. Say for example, how a person behaves, how you respond to a question. Okay, how is your emotional stability? So many things, they determine the personality of a person. But it's an open question to all of you. Now, before a person utters a word in front of you, you're meeting a person for the first time. Before that person utters a single word, before that person interacts with you, how will you try to assess the personality of a person? Majority of the times we go by the looks of the person, isn't it? We go by the looks. Okay, and when we talk about the looks, again I think you will agree with me that see, boys sitting there, if I ask them, what's that thing which you like, this Pariniti here, so answer could be in different words. I like this about Pariniti, or this part of the body of the Pariniti, that part. But believe me, if Bhabiji comments, but see, that's the fact. Okay, but when we talk about the real personality of a person, as far as the looks are concerned, I think our focus most of the time is on the face of the person. Okay, and in the face, to somebody it may be that eyes are very attractive. Okay, somebody may like the nose, somebody may like the curly, shiny hair of Pariniti. But I think something which really, really attracts from the very inside of a person, that is the way you smile. Isn't it? And when we talk about the smile of a person, it is teeth which constitute the so-called white and the gums that are called as the pink. Together, these are the two things which probably has got the greatest impact over the face of a person and in the face than the smile of a person. Okay. Now look at this person. I think you must have seen this before also. In the very first instance, what did you recognize? Be honest. We probably recognize that the central incisor is missing. But few might not have noticed that one of the eyebrows is also missing. So that means, I think I'm audible. So that means I am emphasizing my point of view again, that ultimately it is the smile of a person that matters the most as far as the personality of a person is concerned. Okay. Now look at this picture. No teeth, no gums. But look at this heavenly smile. Isn't it? Look at the eyes of this beauty. Probably another Pariniti Chopra in the making. This is also beautiful smile. By the way, she is daughter of one of my postgraduate students from a previous college. I think this girl must be now 9 or 10 years old. Okay. What's missing here? What is this? This is a photo frame. Okay. Even though the previous picture was also looking beautiful, but this picture is looking more beautiful. The beauty has been enhanced by this frame. Isn't it? Right? So same thing I'm going to convey you here also. Now look at this picture here. What you see? An edenture is rich, only gums are there. Here, teeth are there, but they are again without. Are these two individually looking beautiful? No. So that means when we put a frame of that soft tissue, that is the pink tissue, around this white, then this smile looks beautiful. Okay. So what I am going to cover is not about this white part. I am a periodontist, hardcore periodontist, and I am going to talk about the soft tissue aesthetics. Some components, very few components of the soft tissue aesthetics, and the majority of the cases that I will be showing here, they are my own. I think one case has been borrowed from one of my colleagues, and I request Dr. Pulkit, please don't comment on the photography of my presentation, really very bad. Now look at this picture. So this is a case of a gummy smile. Now this is looking unaesthetic because of the excess of the gingival tissues. Okay, the gums. And how about this picture? This is again not very pleasing. The reason being that even though the tissues are not in excess here, but this is due to lack of tissues here. So that means both the lack and the excess of the pink tissue around the white, that is teeth, that can affect the smile of a person, that can affect the aesthetics. Now look at this. Even though the soft tissues may be okay, fine, but these deposits, these stains and deposits here, and this pigmentation part, the gingival pigmentation part, this is not giving an aesthetically pleasing look to the smile of these people. Okay, so similarly this here again melanin pigmentation is there, but along with that inflammation is there, gingiva is swollen, again giving a unaesthetic look. Okay, now look at this particular case. So this is, we talk about, I think majority of them must be interns or the postgraduate students, and I hope you people remember that there is something called a gingival contour. A very, very small finding in the gingiva, but see what difference it can make in the smile of a person. Of course, some restorations also have been given, but this was the same case which after this periodontal surgical management and with the veneers, altering the gingival zenith, look at the results it can give as far as the aesthetic part is concerned. Now this smile seems to be beautiful. Okay. So what I will say is that a healthy smile is a beautiful smile. Same lady, if she is having bleeding gums, swollen gums, even though she is a good looking lady, smile may be good, but this is not aesthetically pleasing. So the point which I want to convey to all of you, the message which I want to convey to you all is that, in a nutshell, it is basically a healthy and aesthetically pleasing periodontium that can be considered as the foundation of a good tooth or a restoration. You do best of your restorations. You get your crowns, your veneers made from the best of the laboratories in the country. But if your periodontium is not sound, if it is not healthy, all is gone into drain. Okay. The simple cases. I'll come to some special cases also for you where a periodontist really can play a very, very good role in the aesthetics of a patient. Okay, now look at this case. You talk about any film in the world you can find in the oral cavity of this person. Okay, so after doing some work, surgical and non-surgical, this is the result. Okay, similarly these type of cases. See, my presentation is quite lengthy, so I'll just try to rush through and stress upon those cases which really probably are interesting from your point of view. I'll just rush through this. So now see, there's a very, very common saying in the medical sciences that what your mind doesn't know, your eyes can't see. Isn't it? And that is very true. So that means if you don't know what exactly is a beautiful smile, you really don't know. You can't give the results to the patient. So that means you don't know what you really don't know. So that means unless and until me, or for that matter anyone sitting over here, unless and until we people don't know that what exactly constitutes an ideal pink frame of the white, probably we cannot give the character or the personality we are looking to give to that person's smile. Okay, so I will not go into the details of this. These are few of the factors that are related to the gingival tissues which surround the teeth, which ultimately determine the aesthetics of the smile of a person. Okay, now this is a simple, very minor thing that is gingival contour. This can have a far-reaching effect on the results of the smile of a person. I'm not going to the details of this. You must have heard about these terms, altered, delayed. These are few cases. I will not touch these. Now look at this case. Have a look at this, then I'll tell you. Music is no good. She is a professor in endodontics. She was really upset with a gummy smile, for the past many years, and she had asked me so many times, "Sir, can you do something with my gummy smile?" So I said, "Okay, we can try out this." Because see, it's not that a gummy-looking smile only could be because of excess of gums only. I'll come to that point also. There are so many factors we need to evaluate before opting for a particular type of technique to improve on the gummy smile. So in this particular case, what we did was that, see, naturally there was some gingival excess, so we opted for the laser excision of the excess of the tissues. The gingival contouring was there. I used knife also. Then she also complained about excess of melanin pigmentation also. So we went in for the depigmentation procedure also, but unfortunately I could not follow this course for a long time. So these are the results which we could get after 20 days of the surgical procedure. Now I'll come to this excessive gingival display. Right? You may get patients who will complain that कि डॉक्टर साहब जब मैं हंसता हूँ या हंसती हूँ सब लोग कहते हैं तेरी मतलब स्माइल बहुत गमी है, राइट? तो गमी का मतलब ये नहीं कि that it is the culprit is always the gums only, the gingival tissue only. It could be something else also. Okay, so here I have tried to sum up that what could be the different reasons for the gummy smile and what are the treatment options that are available with us. Okay, so a gummy smile could be because of the short teeth that are worn. I'll show you with the help of photographs also, good photographs. If the teeth are short, then also it will give a gummy appearance. Okay, then if the teeth, they are not worn but still the gummy smile is there, that is another option. Then there could be a case where the gummy smile with teeth of normal height, but it is because of vertical excess of the maxilla. Okay, that could be another situation. Or then there could be a situation where the gummy appearance is because of the long teeth, natural long teeth, right? So what we are, see, this is a case which can be managed orthodontically or maybe people like Dr. Divya. Okay, so this cannot be managed easily by a periodontist. Yes, I can attempt. There is a procedure called as lip repositioning. We can try that also. That also many times give good results. Okay, but what I am talking about here is this particular situation where the gummy smile is not because of short teeth, but it is definitely because of excess of the gingival tissues. Now look at these cases. Now this is a case which is because of short teeth. Gums are okay. Here the gummy smile is with the teeth of normal height, but it is because of the vertical maxillary excess. Now here the gummy smile is with the long teeth. This is a condition called, I won't go to the details of this, altered active eruption or altered passive eruption, and this is the case of gingival eruptions. Okay, so where I being a periodontist can intervene is these type of cases. Okay, and one of the cases I've just shown the videography of that. These are few of the cases that were treated before and after. Of course, few cases the restorations have been given, and they were given. I had the support of a very good prosthodontist right now working in Dubai. He had given the lineage to these cases. Now coming on to this particular field, that is gingival recession. This is a field which I love. I love to operate on these type of cases, and mind you, these are very, very challenging cases. It's not easy. Having said that, I love this field, but many a times I have faced failures. Straight away failures I have faced. Okay. There could be different causes for that. Some of the cases I would like to show you people. Now this was a case where I didn't see this. Have a look at this case. This is an implant supported crown that was given where there was loss of hard tissue also. Okay. Ideally this case should have been treated. Implant should have been placed after the ridge augmentation procedure. But the prosthodontist who was operating on this case, she preferred to give the crown this way, and after a few days the patient had the complaint of pus discharge and bleeding, and of course little bit of discomfort there. Okay, so they referred the case to us. So naturally there was a pocket there around the implant. We went in for the gingival contouring with the diode laser. Okay, so this is a post-operative view immediately after this. After 10 days, and then another prosthesis was given in this particular case, but of course with this pink porcelain. There was no other alternative that time. So we gave this. pictures are missing. Same case. Okay, now see here. So the problems with this particular case did not end up there. So after a few months, patient had gingival recession. Exposure of the workman, you can very well appreciate here, that was observed. So patient was back with this problem, and the prosthodontist was also again back to us that, sir, this is that one, what to do now? The reason was that there wasn't any tissue with good gingival biotype. It was more of mucosal tissue there. So naturally recession was to happen. So what we did in this particular case was, we went in for the connective tissue graft from the palate, placed it there. This is the picture after 15 days, and this is after 1 year. Same case. Now a case which is very, very close to my heart. एक होता ना कि जो मतलब खुद ही देखता रहता बार बार निकाल कर कि यार मैंने किया होगा क्या? Sometimes I keep on watching myself whether I did this or no. So let's discuss that case. Now look at this case. Very, very challenging and interesting case, I'll tell you. Not an easy case to handle. This stuff, that is mandibular right first premolar, that is 4-4. Okay. So patient came with this. It was endodontically treated already. You can appreciate the presence of a restoration, cervical restoration here. A deep defect. Look at the pattern probe. Almost 8 to 9 mm deep defect. So we went in first for, sir was talking about the regenerative procedures in the morning hours. So we went in for the regenerative procedure first. So this is the case after the reflection of the flap. We did root conditioning. A bone graft was placed right onto dressing. Now this is the case that was, look at this radiolucency. Okay, all around a large defect, preoperative. And this is immediately after placement of the graft. You can appreciate the graft, how nicely we have packed the graft right up to the apex. And this is 3 months post-operative. Bone regeneration had started, substantial amount of regeneration we could appreciate in this case. 6 months post-operative, good amount of bone has already formed there. So now comes the soft tissue part. That was a challenge. Okay, so first part of the surgery was the regenerative procedure to reinforce the attachment process, the attachment part of the tooth. So now we started with the root coverage procedure for this particular case. Look at the amount of gingival recession that has taken place, right up to the apex. Okay. So in the first sitting, after 3 months of the placement of the graft, we went in for a soft tissue free gingival graft. Again, in this particular case also, we went in for a free gingival graft from the hard palate. This is the epithelial side, this is the connective tissue side of the graft. Graft was secured to the recession side. This is the donor side. This is 3 weeks post-operative. This is 6 months post-operative. Okay. So are we satisfied? No. So we were also not satisfied. So we thought that we will go in for next surgical procedure. Went in for another surgical procedure. So this is the post-operative 7 months after free gingival graft placement. So this is the appearance before the third surgical procedure we attempted. That is the second gingival graft. Okay, we attempted another free gingival graft. This was before the surgery, we placed the graft. But this was 6 months post-operative after second free gingival graft. Okay, the case doesn't end up there. Drama is still there. So there it happens. Reason being that there is no bone surrounding that tooth on the labial side. Whole cortical plate had gone there. So patient came back after 7 months again there was gingival recession. So like the patient, we were also not satisfied that time, and I had the support of a very good colleague of mine whose thesis that time, he had a thesis on a material that is called as alloderm. I don't know whether you have heard this. This is a material which is taken from the cadavers, their skin. Okay. It is treated in such a way that there is no cell in that graft. It is basically the extracellular matrix that is there in that graft. So we thought of trying the alloderm. This is the third surgical attempt only to cover the soft tissues. Irrespective of that, the first surgical attempt we went in for the regeneration of the hard structures. So we placed the alloderm here. Now look at the results. This is with which the patient landed to us, and this is the picture after 1 year. So these are the results which are determined a skillful periodontist can give. Okay. So these are few more cases where we have attempted the root coverage with the help of different other surgical procedures, minor procedures which even the interns, the undergraduates, they can also attempt. They were tried. And similarly, we can try out this particular component of the soft tissue, which ultimately determines the aesthetic part of a smile, that is the depigmentation. Previous case I showed you how a periodontist can do this depigmentation using the laser, but this is with the help of knife. Look at these cases. This is before, this is after. If you don't have a laser, if you are not skilled to use a surgical knife, take an autoclaved diamond stone, just peel away the gingival pigmented part right up to the connective tissue. We can have good results there also, but word of caution here that before doing this, tell the patients that these results are not permanent. These results are not permanent. Reason being that it is there in the genes of the patient. Okay, we have to do this procedure repeatedly, maybe after 1 year, 2 years, whenever it reappears. Okay, this is the help of electrocautery. So I think we all are short of time today. So with this, some other day we'll consider these crown lengthening procedures because they are at length. They need to be discussed in depth. These are different categories of crown lengthening cases that we have performed. Now to sum up my presentation. Okay. Now look at these girls, leave these girls. So look at me, or for that matter, any other gentleman sitting over here. We all are so focused on our looks these days. We are particular about this, the aesthetic component. So everybody is after cosmetics. Okay, be it a female or a male. So quite naturally, if somebody thinks that I can give a very nice crown or a veneer and leave the soft tissues like that, it won't be acceptable to the patient. Okay. So patients really are, these days, they are increasingly becoming demanding, and they are aware of their rights also. They know a patient who reaches you for a particular treatment, he or she these days first they will Google and then they will come to you. They know much more than that what are the different techniques available in the market. Okay, so in this particular area, when the patients are so conscious and they are aware of everything, to cater to the demands, to the patient's demand, dentists, we people need to be scientifically and aesthetically skilled. And as I said in the beginning, no matter whatever wonderful work you do, but without a healthy and aesthetically pleasing periodontium, an everlasting charming smile cannot hold on. So that's why whenever I end up this particular series of my lectures, I will use these words, that as we try to respect the pink in the society, that means the girls in the society, when we deal with the soft tissues in the oral cavity, we people need to give the respect to the pink of the mouth also. Then only you can get the desirable results which you are looking for and for which the patient has approached you. So thank you so much, ladies and gentlemen, for your patient hearing. This is my team. I have been blessed with 5 more young men. Their names will be added shortly in the next presentation. And this is the ever-smiling team of the Department of Odontology and Implantology, Maharashtra Dental College, Nagar. So big round of applause for this. Thank you.
Thank you, sir. It was a very interactive lecture, and I hope everyone enjoyed your presentation and lecture. Thank you once again, sir. So this was Dr. Baljeet Singh, sir, Principal HTC Sundarnagar. Now I am going to introduce our next keynote lecture speaker. Our next keynote lecture will be by Dr. Pulkit Thakur, sir. A brief introduction of sir is he is MDS consultant and eminent prosthodontist. He has done his diploma in dental photography from University of Birmingham, London. It's a pleasure for us that sir is present amongst us today to deliver his keynote lecture. We welcome Dr. Pulkit Thakur, sir, for his lecture. Please give a round of applause for sir.
Thank you so much, Principal sir, for the very enlightening lecture. And very good afternoon. I think it's very good evening to all. Principal sir, Vice Principal sir, and faculty and students. Okay, this lecture will be very quick, not lengthy, and very interesting. One thing. Second thing, I will ask a question after this lecture. And I am carrying a very good gift for that person. Okay, let me start. So, I think briefly my introduction has been given. My name is Dr. Pulkit Thakur. I practice in New Delhi and I am consultant in Dubai also. And photography is very integrated part of our dentistry. Right? If photography is there, we can. There are n number of places where we put our cases. Social media is on top right now. And if you have good photographs, you are famous in the industry or anywhere, anything. Like social media, as social media is growing, we are learning photography by ourselves. Putting selfies, clicking photographs, Instagram, Facebook, everywhere, right? So it's not that photography you need to learn specifically for the dental purpose. But now it's very easy to learn because you are clicking photographs daily. Like one said that beauty lies in the beholder's eyes, right? Photography also lies in the beholder's eyes. First you see, then you capture. That is photography. Right? So this is the brief introduction that I am covering the terminologies, just basics of photography. Only basics, right? Not too much of things, not flashy things, only basic photography. So, like I said, first you see, then you click, right? This is a photograph of my recent trip here, and thank you so much. I am very blessed to be here because I stay in Delhi and AQI right now is 700. I can't breathe there. So from August, and when I came here in the afternoon, I realized that I breathe. I'm breathing, yes. So thank you so much. This is also, so these are the photographs. My journey of the photography, learning photography, I recently done one diploma because I was in London. Otherwise, I was learning photography, I was doing photography with that camera, which rolled up. Okay, so I was doing photography from very long. Right, eventually I become a dentist, and I realized that photography is a very key part of our practice, right? So I just did my diploma. So what is photography? I just said that two words, photos and graphic. Photo picture, which is clicked, and graphic, the creation, what you create. Okay, whenever you listen about photography, you talk about photography, you think big cameras like this one or this one, right? First thing comes in our mind, big cameras, big setups, and everybody talks about it just to show that only these participants. Okay, so everybody show these things first to show that only these things are required. Please, very distant. These things are required. These things required later on. We do first. All our dentists here, graduates, postgraduates. First we do, then 12th, then BDS, then MBS, then we join college. So it's similarly like that. You just need to know the basics, then you jump on these things, right? So nothing fancy. Lots of money. Whenever you talk about the photography, this camera must be 1,50,000, right? So you don't need those fancy things. Just learn the basics first. So there are three things in the photography. How many of you have DSLR cameras? 1, 2, and others, all are using Cohen, right? So, okay. So right now, smartphones are so much smart that they are smarter than the person who is carrying, right? iPhone 15, best camera, I say. Yes. So you can use your phones also, right? So these three things, ISO, shutter speed, aperture, these three things are the key of a camera. Okay? Either phone, either your DSLR. Now, if I talk about the dental photography, you click photographs. If you are using a DSLR camera, you just need to stick ISO and shutter speed. These are fixed. I will be telling you how these are fixed. You just need to play with the aperture. That's it. Those who are having DSLR, they can understand. Right? So what is ISO? ISO is the sensitivity of the lens, the sensor, the sensitivity, the sensor, sense the light which is coming through the aperture and it creates the image. So just simple, nothing else I am telling you. So it's you can see in your DSLR 100, 200, 400, 800 like these numbers. These are sensitivity. The higher the number, more is the sensitive of the sensor of the camera. Right? Simple. Next, shutter speed. Camera has shutter. All cameras are carrying shutter. Right? Even phone or DSLR both have shutter. Shutter opens, light comes in, shutter down, photographs capture. Okay, this is called shutter speed, right? And in case of you are using DSLR, it is fixed to 200. That's it. If you are using flash, it is fixed to 200. Main thing is the aperture. When you use it's very hard to understand when you are not using DSLR. Right? These terms are a little bit tricky, seems tricky and very difficult. That's why I am skipping it now. We were talking about the photography with the phone. I think everyone will understand that, right? So aperture, I just explained you. The aperture, you can see the settings of the aperture in your camera like this, f2.8, f4. So the number increases, aperture decreases. Alright, just the basic. This is the main part. When you click the photograph, your patient is here, you are clicking the photograph. If you are shaking, either your phone, if you are shaking, then your photograph will not come clearly. You need to be in the position like that. Don't be stable first. Be stable your feet like this tripod. Tripod has 3, you have 2 legs, make this position, be still, then click the photograph. Okay, so if your phone, if your camera, jitna still hoga, utna better photo aayega, right? Dental photography. So how it is important, right? Legal. One major thing, legal. When patient visits you, when patient come, first thing we should always do, click the photograph of the patient teeth, right? Why? Let me tell you my story. One of my patients in Dubai, we have done in the clinic, we have done her whitening, teeth whitening. I have given her veneers, and after that she dropped the mail that I will going to sue you guys because there is no change in my smile. That was evident smile, but we were having the pre-photographs and post-photographs. So she was asking the money out. That's it. जितना उसने पे किया था, she was asking that back, right? So ये आपको legal documentation बहुत ज़्यादा important है. If you are practicing here in the college, or if you are going to practice your own private practice. First thing, patient आया, patient को बिठाया, retractor लगाया, photo खींचा. That's it. Ask the patient first, yes, right? Publishing, students are here, so you need to publish good paper, so you need good photographs to put them. Okay? If you are putting bad photographs, then it doesn't look good. After the printing also, it doesn't look good, it doesn't seem good. So, good photographs for the publishing. Education of the patient. See, when we talk, and आधी से ज़्यादा चीज़ें निकल जाती हैं हमारे सर के ऊपर से, and सबसे ज़्यादा patient के साथ. If you are talking to patient, you are explaining the patient that you are having yellow teeth, we will do the whitening for you, zoom whitening, we will do veneers for you. So half of the things patient will be understanding. But if you show them photographs of your previous cases, like you have done the veneer, you have done the whatever work you have done, right? If you show them, patient was like this, ऐसा था पहले, अब ऐसा हो गया, ऐसा था पहले, अब ऐसा हो गया. Patient conversion becomes easy. Okay? This is the fact. Communication with the patient, dental teams members, and when you do work, like you have done the crown shaping, right? You click the photographs, you take the photograph of the occlusion clearance, and you can communicate with the lab. Sometimes lab say कि उसमें clearance ही नहीं था, आपने bite गलत ले ली. So you have that, bite ठीक है, everything is fine. You know the documentation, right? So, and major marketing. We are dentists. We are also, if you are running private practice, ma'am, sir, then we are also a businessman, right? We need more patients. And how will we get more patients? By putting good pictures on social media. Social media is very strong nowadays. You need to put good pictures over the social media, right? See this photograph. So, how photograph is crucial here. You are a general practitioner. I am a prosthodontist. I don't have any idea about this patient, right? I need to communicate with the oral medicine person or oral pathologist. I need a good photograph. See these 2 photographs. Second one was clearly, the margins are clear, everything is clear. So I can communicate with that oral pathologist or oral medicine and clearly make the diagnosis for the patient. I cannot say patient will let you know. No, action should be there right then. If the patient at dental chair, you should do something. Treat them. Don't कभी उसको वो मत दो आगे की डेट. Treat them. तो वो ऐसे ही आपका meanings. Small things, but matters most. Okay, I will just explain this. See these 2 pictures. Fluorosis stains. If you are doing veneer case, if you are doing aesthetic case, you need to communicate with the lab. You need to send the photographs to the lab because veneers are very thin, laminates are very thin. Lab asks us that if the cutting is okay, if the preparation is okay, if the teeth are okay. So you need to clearly see the difference. And sir recently just gave the lecture of soft tissue and pink and white. See, everything is white here, but there the difference is there, right? See, if you are clicking pictures like this, don't click it, right? Always use cheek retractor. This picture is as bad this X-ray, as bad this RBG, because you can't do anything about it. You can't diagnose properly, right? So click photograph. Whenever you are clicking the photograph, always put the cheek retractor and use black one. If you are using black one, that gives you better aesthetics. Okay, patient education. The most important part of clicking photographs is the patient education. See these two images. If patient is coming to you and you want to explain the patient that we can put the implants and we will give you good crown, or we will restore the tooth. If you show them these photographs, it is very easy to convert the patient. Yes, पहले दांत नहीं थे, अब लग गए, right? See this. This is the case for the zoom whitening. Shade is upper one, it's not visible. A3.5, niche B1. Zoom whitening. After zoom whitening, this is the immediate effect, right? If patient comes to you with the yellow teeth, if you show them these photographs and tell the patient कि हम zoom whitening कर देते हैं, as everybody wants white teeth, nobody wants yellow teeth, right? Patient will convert. Okay, so this is the advantage of clicking photograph. See this one. She was a 26-year-old patient. Lower, see the gingival resection. Those teeth were completely mobile. So we had crown preparation and then prosthesis. If you are showing the patient that we can give you a good bridge. See the aesthetics. The matching of the aesthetics is very nice. If you can communicate with the patient like this, patient will convert. Yes. See, the practice will be different in the different areas. I am from New Delhi. Practice is different there. You are from Himachal. Practice must be different. But this thing stays wherever you are going. I am working in India and Dubai also. These things works. Seriously, these things works. This is the case for the upper teeth. She was having any RPD, and see the smile. Patient was very happy. Right? Show them, click the good photographs, and yes, you will be having more patients. See this patient. This is extraoral photograph in the sitting position from the eye level, right? Before putting the veneers and after putting the veneers. Smile is good. Again, you need to just show the patient that we can transform you from here to there, right? The guidelines, basic guidelines, I think this is I think it's not visible, right? So basic guidelines are there in the Journal of Prosthodontics, in the Journal of Endodontics. If you uploading the photographs, they have the guidelines. The pixel size should be this much, and the 2 MB size should be there. If you are clicking photograph with the good mobile or DSLR, or first DSLR then mobile, if you are clicking with the DSLR, you can constrict the photograph, you can make the larger picture also. Okay, you have that liability, you have that flexibility. Okay. Again, the specifications for the PubMed articles. So all want good photographs. So if you are a student, you should buy the camera, because that is the correct time to learn the photography, right? That is the best time. Then you can apply in your practice. Okay, so usually we see these kind of photographs. Can you put anywhere on the social media or somewhere? If you show it to your patient will not convert. He will say that मैं तो बिना टेंशन के रह लूँगा, right? So don't do that. Okay, so marketing. Marketing is very easy nowadays. Previously, we need to hire people to market. That go there, and market bade boards lagana. Now you can put just on the social media, Instagram, Facebook, YouTube videos, and marketing is very easy. But again, you need to get the good photographs. So this is important. how to click photographs. First, extrovert. Make the patient sit in the comfortable position, and patient should be sitting in the erect position like this. Head should be stable, and you will be clicking the photograph with the eye level, on the eye level. ऊपर से नहीं click करना, नीचे से नहीं, बिल्कुल eye level से. ठीक है? तो that is your facial profile photograph. Second one, the smile. See, can you see here? Here, right? For the smile photograph, we need this angle. This angle, right? Straight angle, page smile नहीं आती. Smile is a curve. This is a curve, right? We need to click the photograph like this when you are clicking for the smile photograph, right? Then cheek retractors. Place the cheek retractor. Click the photograph. Right, left, and always take. Whenever you are taking the occlusion photographs, always take with the mirror. With the cheek retractor and with the mirror. Okay, mandible. If you are taking the mandibular photograph, try to put the tongue. Say, patient को convey करो that put your tongue at the palate and then put the mirror. It will give you a very good photograph of the mandible. Okay, full arch. And then the upper is very easy. Retractor and put the mirror. Right. So these are the steps to take the photographs in every case. From there to, right, clear? Guidelines, same, that has been explained. Okay, the upper, see, there is no tongue in the photograph. Tongue should not be there in the mandibular photograph, okay? It doesn't look good. And when you are clicking photograph, like this, so you tend to, if you are clicking with the mobile, I'll talk about the mobile now. Because majority of people are having mobile and they are very comfortable with the mobile. So if you are clicking the photograph, you used to touch the screen first, right? And then click it. What happens? Sometimes picture comes dark, sometimes comes bright. It happens because of the light and the automatic settings of the camera. So when you are tapping, right? If you are clicking the photograph of the tooth, tap on the tooth, not on the gum. Okay? If you are clicking the photograph of the tooth, then it will create the white balance. That means your picture will not be too white or not be too dark. If you are clicking the photograph of mandible, click here. Okay? Tap here. Similarly, the maxilla. Tap at the jaw, bottom, maxilla. Okay? Clear? Understood? Right? 2 points are clear, 3 points are clear. If you are carrying here, if you are from this lecture, if you are carrying out in the completion of this lecture, 2 or 3 points, my purpose has been fulfilled. Right? See the photograph of the denture. Okay. So these are the instructions for the implants. So how many of you are doing implants? Yeah. Okay. So if you want to document the case of the implant, right, you need to put pre-surgical photographs. Pre-surgical means when the patient is ready without anesthesia. One thing, when you are clicking the photograph of the smile, make sure that you take the photograph of the smile without anesthesia. Okay? If you put the anesthesia, then the smile will be there. Right? Then, if you are doing the proper surgery with this incision, then take the photograph of the incision, then reflection, flap reflection, then paralleling pin, after that implant, then screw cover and the suture. Okay, and stage 2 when the patient come back for the prosthesis, then zinc trial, metal trial, and final cementation. Or if you are giving zirconium, then basic trial if you are doing. Then so okay, the steps are clear. So these steps you need to follow. Right? Parallel pin, like this, the tongue is visible, not a good photograph. Direct, not a good photograph. If you are clicking the photograph of the teeth, after placing the implant like this, it should be always in the mirror, not direct. Okay, maxilla in the mirror, mandible in the mirror, not direct. If you want to click the photograph of the occlusion, place the mirror, side mirror, then click it. Okay, so these are the mirrors and contrasters. Have you seen these things before? Right? You have the idea? Okay, so if you are clicking with photographs with the phone or with the camera, buy these things. Okay, don't invest in the camera, buy these things. These are the essentials. Like this. for the aesthetic cases, mainly for the aesthetic cases, you need to click the photograph. If you are doing veneers or crowns in the interior, always click photograph with the reflector, black reflector. Okay, for the mandible, for the cheek, if you are taking a photograph of the occlusion, and only single tooth or you are using, or you are doing work. Okay, so see the photograph, difference in the photographs, old photographs. The second one is looking very pleasing, aesthetic. Yes. Okay. Okay, so main thing. These photographs are clicked with different things. iPhone, Samsung phone, DSLR, and OnePlus. See the difference. All are different, right? All are different. So these things are very technical. I think we have very less time. Okay, come to the main point. This device is called MDP, mobile digital photography, available on Amazon also. You just put your phone like this. The light goes inside in the mouth, and it gives you very good photographs. If you are using mobile, use this light. It will be very helpful for your photographs. So conclusion. Okay. So these are the tips for the dental photography. You can take the photograph of this one, and you later on you read. Okay. So it is saying that always use cheek retractors and whatever things I just said earlier in this presentation. All are those. Okay. So one quick thing I need to discuss with you. Just how many of you are periodontist? Okay. And everyone is doing cleaning, right? At your practice, study cleaning company. This product, there are various products in the market which gives you instant whitening, and these are not create any sensitivity. See, if patient is coming to you for the cleaning, patient usually thinks that cleaning के बाद मेरे दांत white भी हो जाएंगे. ठीक है? So there are different products in the market. There is one Purex, there is one Perfora for the teeth whitening gel, instant gel. If you are doing cleaning, you can prescribe this, you can give it to the patient, this whitening gel, or you can apply by yourself also to the patient and give it to the patient. The patient will be having instant whitening also, and it's not sensitive, right? And it is very aesthetic. So it looks good, and these are many products. This is just one product. So Colgate also launched this whitening pen. Okay, so this is a very good combo for the patient and for you also. After the cleaning, after you can click the photograph, and photograph will look more brighter on the brighter side, right? Okay, so done for the day. I have one quick question for you. If you are clicking the photograph, just one question from my side. If you are clicking a photograph and your picture is coming sometimes darker, sometimes brighter, what should you do? What you do? Just quick answer, and I am carrying a gift for the person who is going to answer that. Editing is not. Yes, editing is not. You can't do editing.
Turn on the flash.
Yes, you always click photograph with the flash. Okay, always. In case of yes, ISO.
Yeah, we have to adjust the ISO, fix the ISO.
Right. Quick ISO. We need to adjust the ISO. That is the answer. Because he is having DSLR. वो flash कर रहा है कि मेरे पास तो camera. I'm just kidding. Okay. Thank you so much for the listening. Yeah, please come here. You have, please carry this and okay. Right. So thank you so much for listening. I think you कुछ तो आपको समझ आया होगा, and you must be carrying one point or 2 points, right? So thank you so much for listening, and be a good photographer, click good photographs. Thank you, sir.
Now I'm going to introduce our next keynote lecture speaker. Our next keynote lecture will be by Dr. Pavitra Rastogi from AIMS Patna, a renowned professional and the renowned author of 7 textbooks, including textbook of oral medicine and radiology. Can I hear a round of applause for sir, please?
good afternoon or good evening, I should say. Good evening, everyone. And like, what is the target audience? Like, which are ELY, postgraduate, which department? Okay, final year. First year, postgraduate, same university. Then what about you? Indoor. No problem. So my topic is very common topic. Okay, maybe you're endodontist, but when you join general dentist, it is going to happen. Okay. So this is thank you, Matchel and Cynodent. These are some of the photos which I have taken morning in yesterday, and like a divine area, so-called Choti Kasi. So a special dedication to my mom. Thank you. This is about me. So my topic is about little bit very common topic, but little complex. Okay. So one of the topic from the orofacial pain. Okay. So have you seen any cases of orofacial pain? Okay. Related to endodontitis, have you seen any cases which have orofacial pain? Endodontists, what are there? Any orofacial pain? As an endodontist, which is the most common orofacial pain? Next. Endodontogenic pain. Orthodontic pain is also orofacial pain. Any orofacial pain means some very complex, some terminology should be there. The most important is orthodontic pain, correct? Now, what about any other than orthodontic pain? Have you come across with that? Have you came across like after the injections, intraocular injections, patient is coming with the episode of pain, which is like electric type of pain or dilating pain? Have you come across like that? Like a traumatic, post-traumatic trigeminal neuropathies? Okay, so these are the common orofacial pain. Okay, post-traumatic is not so common. Sometimes we see. But I am going to cover regarding the myofascial pain. So pain is unpleasant emotional experience associated with actual body. So हम लोगों ने finally classes में देखा हुआ है ना definitions. The most important thing, there should be an actual or potential tissue damage. Why this is required? Why this is required? Because to cause pain, inflammation is required. Okay. So because of this actual and potential tissue damage, there will be an inflammation, and then there will be pain. Classification, we know it is a physical condition and psychological conditions. Now physical conditions, it can be classified as somatic or neuropathic, and under this there will be a muscular pain. So this is a muscular pain, and I will be covering this muscular pain. Okay, this is a very large topic, an entire day is a less for orofacial pain. So whatever time is given to me, I am going to cover about the masticating muscle disorders. Now what about this video? Video thighs. Video on, the on. This one's on. Come on, assist me. Is there any persistence? Because there are videos, I want to have audio.
a moment. You can call any of your friends for this lecture, you can call. It was a very important lecture. And this is 100% question in your exams. My future friend distribution syndrome. Okay? इसमें आ जाएगा. Gradually we have seen. So we have heard about that. Anybody have seen any cases regarding any social care? Median style, the patient tries to okay, after
has been
huh?
my father has been
Okay.
और यहाँ पे जैसे कि हमारा वीकेंड का पल्स यहाँ पे बहुत ज़्यादा प्रशिक्षण और ऐसा लगता है कि जैसे हवा घुस गई है कुछ भी और यहाँ पे सबसे ज़्यादा.
What about the sinusitis? No sinusitis.
No history.
Okay. What about migraines history? No. Have you checked what the muscles? Like it's like a what? For that pain, maybe a sudden migraine or trauma, okay, or sometimes there can be an inflammation in that joint, and sometimes in female especially hormonal induced can be a positive agent, okay, or any hard food biting also can have a better compression or arthritis, osteoarthritis, but osteoarthritis not one that the degenerative disorder for the younger age, okay, so get one opinion and check it, okay.
Every day for 30 days straight to see if it gave me a better jawline, and this is what happened. Had to start off by getting an assortment of different gums to try, different flavors, different textures. My favorite ended up just being bubblegum. Then this is some footage of my face before starting the challenge because the whole idea was to see how it affected my face. Then time to start chewing, and I tell you what, I chewed a lot. And this is my face after 1 week. I don't know, you can be the judge, but back to chewing either way. Chewing, and more chewing and a bubble. Here is the final result. I don't know, I think my jaw looks a little bit wider and more prominent, but you can be the judge. And here is the before and after together. Let me know what you think.
Now, what do you think? What do you think about this aesthetic treatment of chewing the I think this should be added in textbooks. Do you agree that chewing so many chewing gum can have some effect on the muscles? Yes, there will be muscular hypertrophy. That is fine. The outcome was correct. Even if you chew, you will have a muscular hypertrophy. Now, what about the muscle pain? If you have a sustained contraction in some areas, there might be a pain as well. Correct? Now, our muscles are not meant for chewing like what buffalo have. Okay, so there may be a muscular pain. Yeah. Distance okay. Okay. Click. So what are the features patient may have when patient have especially the myalgic pain? So doctor, I am not able to chew. So whenever I am chewing, I am having pain. Next, feeling pain in the teeth irrespective of no dental pathologies. There is pain, but you are not having. If you see, there is no dental pathologies. There is no dental decay. There is no any odontogenic issues, but still patient have pain. Pain in the TMJ region with no radiological findings, no clinical findings. I am not able to yawn. I am having tingling sensation in my ear. Most of the time,
muscular pain, okay, especially the sternocleidomastoid muscular pain, will have a tingling sensation in the ear, and as well as patient may say that patient have a feeling of having the fish, what is it called as fish have stuck in the throat, okay, like something has stuck on the throat, like that patient may have a feeling. I am not getting proper sleep because of the pain. I am not able to open my mouth completely. Visited many dentists, including ENT dentists, etc. So what we do usually? So whenever patient comes and who doesn't have a specific knowledge of orofacial pain as person, we will diagnose as either the infected third molars or the infected third molars or impacted third molar, or you just refer the case to seniors. Okay. Or sometimes what you do is actually a pain because of the third molar, but you have attended some orofacial pain course, you directly jump to whether maybe it's a pain of muscles and you start giving the muscle relaxant, but still patient is complaining of that pain. So why it is so? Because of the incomplete examinations of the diagnosis and because of that wrong treatment. So one wise person has told me your correct diagnosis or correct treatment should include around 60% of the history part, 30% the examination part, and only 20% regarding the investigations. If you say 60% investigation part, 30% is examination, then that means you are going to come in a wrong diagnosis. Okay, so always remember that most of the time 60% should be in the history part related to orofacial pain. I am telling. Okay, if you say like endodontist, decade to investigation is required, but orofacial pain, you need at least 60% is the history part. You have to listen to the patient. Okay, if you properly listen to the patient, then you can come to a correct diagnosis. So masticatory muscle disorders, can you see? There is the normal function. This is normal function first. Then some event occurs. Now what that event can be any? For example, there can be amalgam restorations, the overhanging restorations or high restorations, or it can be injuries, anything which is causing any injurious event. So there can be either local muscle soreness, protective co-contractions, or it gets dissolved, or there can be a myospasm. So this is a peripheral sensitization, and once the CNS involved, there can be a central sensitization, and that will cause myofascial pain and fibromyalgia. Now, what is peripheral sensitization and central sensitization? Have you heard about peripheral sensitization and central sensitization? Okay. So peripheral sensitization means when peripheral tissues are sensitized. Okay. If CNS comes in that, then that means there is the central areas is also involved. Okay. Like when you have burn in your hand, so burning wherever the tissue have been burned, that there is a pain. Okay, that is called as peripheral sensitization. Now, near the area of burn, where there is no pain, there is no burn, still if you try to rub that, there will be a pain. So that is because of the central sensitization. Okay, because you have a history of burning there near the area, so your CNS is involved and they want to protect that area. Okay, so there is a difference between central sensitization and peripheral sensitization. Next, so what are the factors which can have a masticatory muscle pain? Either local factors like trauma to muscles, occlusal disharmonies, chewing hard foods, chewing gums, or if after a long tender treatment, or systemic factors like emotional stress, vitamin D deficiency, sleep disturbances, and nutrition. Now, other than local factors, I want to have a more impact on systemic factors. Okay, most of the time we directly just see the local factors and we try to solve them. But what about the patient who have a history of stress? See, patient who has severe stress or patient have a vitamin D deficiency. Stress, there will be release of catecholamines, and these will have an effect on gamma efferent system. So which increase the sensitization of the muscles as per se. So patient will have a pain in the muscles. Now whether it's a local or whether it's all the muscles are involved, that you have to palpate. Next. So first is protective co-contraction. Now what is protective co-contraction? The protective response, and there is a contractions. So example I told you, just after the amalgam restoration, if there is the high points on the amalgam restoration, patient bites on that. So the muscle, there will be a protective response on the muscles and patient will have a pain. Next. So it's a CNS response to injury or the threat of injury. So
So muscle pain after the heavy amalgamation. Now what will be the features regarding that? So the features, there will not be any, next, there will not be any restricted mouth opening. Next. There will not be any, there will be a slightly decreased range of movement, but main increased pain with function. Okay, जब भी पेशेंट बाइट करेगा उस एरियाज में, या फिर पेशेंट खाना खाएगा तो obviously बाइट करेगा again over that high points में, so there will be a pain, but there will not be pain when patient is in the rest. पेशेंट अपना रेस्ट करते हैं, नहीं पेशेंट को दर्द नहीं हो रहा है, ठीक है. And how you have to treat is, there is no specific treatment, only it's a protective response, just treat the etiologies, just remove the high points, patient will be alright, okay. Next, now what is local myalgia or non-inflammatory myalgia? So the example of local myalgia means there is a muscle pain because of the local factors. The most important example is the inferior, after the inferior nerve blocks. If patient comes with the trismus, okay, patient may have a local myalgia. So it's the most common type of acute muscle pain seen in the dental practice, that is medial pterygoid muscles injured by inferior nerve block. ये बहुत बार आप लोगों ने देखा होगा, स्पेशली सर्जरी में रहता है, एंड उसका ऐसा नहीं है कि आप कंट्रोल कर सकते हैं, इट्स इनविटेबल process. Next. So what will be the clinical features? So patient will have a restricted mouth opening, trismus will be there, patient will have a pain on functions, acute muscle weakness and local muscle tenderness. When you palpate the muscles, patient will have a pain. Okay.
आपको इंजेक्शन दिया था ना ये आरसीटी करते समय, है ना? आखिरी उसके कितने दिन बाद से हुआ है? एक सप्ताह के बाद से. एक हफ्ता ठीक था बिल्कुल, फिर धीरे धीरे मुंह बंद होना स्टार्ट हो गया. ठीक है, आगे ऑफ कर लीजिए.
अगर ये बोलता है कि जैसे ही आरसीटी के तुरंत अगले दिन से या आफ्टर फ्यू आवर्स हुआ है, तो क्या कंक्लूजन्स में हम लोग जाते हैं? मे बी अ माइल्ड पेन, ठीक है, मे बी एमपीडीएस हो सकता है, ठीक है. लेकिन ये बोल रहा है क्या 1 वीक के बाद स्टार्ट हुआ है, ठीक है ना, 1 वीक और नियर बाई दैट एरिया स्टार्ट हुआ है. और स्पेशली क्या हिस्ट्री दे रहा था कि मेरा जो है इंजेक्शन आईएनपी ब्लॉक, उसका हिस्ट्री था वहाँ पे, ठीक है ना. तो ड्यूरेशन थोड़ा सा कॉन्ट्रडिक्टरी है, बट स्टिल हम लोग का डायग्नोसिस जो है अराइवल हुआ वो
फिर 8 से 10 दिन के बाद ये स्टार्ट हो गया ना दर्द. इतना ही खुल रहा है आपका. खोलने की कोशिश कीजिए.
ओके, स्टॉप करना है आपको. फिनिश होगा. ओके, स्टॉप नहीं ऑप्शन. सो आपने देखा कि मैंने जब प्रेशर लगाया, मैंने अप्लाइड द प्रेशर, पेशेंट वाज एबल टू ओपन द माउथ. नाउ व्हाट इज दैट कॉल्ड? सॉरी, trismus 2 types का. One where you can apply pressure and you are not able to open mouth still, and one where you are applying pressure and you are able to open mouth. The 2 types of trismus are there. One is having a soft end feel, one is called as hard end feel. If you read occasion, you will get that knowledge. So no problem like it's required thorough knowledge for that, no problem, but you understand that soft end feel and hard end feel is different. Soft end feel is the characteristic of muscle pain, hard end feel is the characteristic of what you said is discal pain. Okay, so you are applying the pressure, but still patient is not opening mouth in anterior disc displacement without reduction. Okay, continue the video. Okay, video off हो गया क्या? नहीं, कंटिन्यू कर. हाँ,
फिर 8 से 10 दिन के बाद ये स्टार्ट हो गया ना दर्द. इतना ही खुल रहा है आपका. चलो 20 खोलने की कोशिश कीजिए. सॉफ्ट एंड फील पॉजिटिव. खुल के रखिए, बंद कीजिए. बंद करना जा एकदम दर्द हो रहा है ना. बंद करो, पूरा मुंह बंद करो, इधर कीजिए.
I'm saying the intraoral findings, everything. Next video, there is one more video. Okay, next slide. Okay, so this was the example of the muscle pain which was after the time of the presentation started. Okay, so So this was the local myalgia. Okay, so how you have to treat that? So physiotherapy is most important thing. Okay, do a physiotherapy, passive physiotherapy, passive exercise. What do you mean by passive exercises? Patient should not have a pain during the physiotherapy. Okay, ask patient to open mouth how much ever he can. Apply the warm pressure. Okay, or the any warm cloth, and then you can have a muscle relaxant as well. Okay, next. Next. So you can use the stabilization splint. There is difference between stabilization splint and night guard. Okay. So have you seen both night guard and stabilization splint? So what is the difference between night guard and stabilization splint? Night guard is mainly for the bruxism and stabilization mainly for the muscle spin. Okay. Next. Next is myospasm. So myospasm is the CNS induced chronic muscle contraction like in tetanus. Okay. Next. So what will be there? There will be marked restriction in range of movement. There will be acute malocclusions, increased pain with function, and entire muscles will be. मैं थोड़ा फास्ट जाना पड़ा जहाँ पे मुझे लगेगा कि सिखाना है वैसे काम. ठीक है. Next कर दिए. Next is every time. Now what about dystonia? So dystonia is the abnormal contractions which is there from the CNS involvement. Okay. So video निकालो. हाँ. Just see the tongue movement, the normal tongue movement, involuntary tongue movement. Okay. This is the dystonia case. Next one. It's a facial, normal facial contractions.
और ये बात करने का मतलब से बात करने का ऐसा हो गया चलता रहता है आपका ना विजना ऐसा समझ लगे ना नहीं दिख रहा समझ गया
Just an 8-year boy. किधर कैसे लिखा हुआ है? This is straight contractions. हमारे वो फिर से हाँ.
रात में देखी तो कल सुबह केस को हम अपने नजदीक अस्पताल में लेकर गए सीतामढ़ी प्राइवेट क्लिनिक में. वहाँ पे जाने के बाद डॉक्टर साहब बोले कि इसको माउथ पैरालिसिस था.
सीटर मसल्स.
इसका मुंह सूज हो गया. उसके बाद 2 मेडिसिन मिला था जो कि घर पे ले जाकर
अगर आप लोगों को बोले कि जस्ट 10 सेकंड के लिए करिए, you will have pain in the muscles. Now what about think about that boy? Okay. So this patient was admitted for nearly 3 to 4 months and heavy dose of clonazepam and other drugs, and then patient got relief. Okay, that is different topic. I won't go in that area. So this is the most important part, but I'll just cover fast as early as possible. So myofascial pain dysfunction syndrome, and because it's involved the fascia, that's why it's called as myofascial. And the most important is trigger point is there. Now what do you mean by trigger point? It's a taut band within the muscles. Okay, next. So there is a taut band in the muscles, and because of that patient have a pain. So these are the taut bands, and whenever you palpate these taut bands, patient will have a pain. Next. Okay, so these are the taut contraction bands. Next. So what are the etiologies? It can be a microtrauma or a macrotraumas, emotional stress, sleep disturbances, occlusal disharmonies, abnormal postures. Most of the time, if you are working more on the computers, you may have a pain. Sometimes you may have a pain. Next. Poor nutrition. Now this is the case why I want to kept here is patient was having a right ovarian cyst approximately some 40-30 okay. So what was the patient complaint was patient was having pain, okay, and there was the menstrual muscles pain, temporalis, sternocleidomastoid muscles, staphylococcus also was painful, and we have tried, like we means all the dentists, whatever the previous doctors was there, they have tried all the muscle relaxant, everything was Okay, but the patient was not getting relief still. Okay, then I asked for the vitamin D deficiency. Everything was checked, everything was normal. Then I asked for the evaluation of the ovaries, and there was the ovarian cyst, and it was a good size. Okay, it's not a small size. So I referred the case to the gynecologist. Still, gynecologist was not ready to accept that this muscle pain might be because of the ovarian cyst. Okay, then there is the article. Next. There is an article. It's taken from the article, and clearly there was written that there can be a fibromyalgic pain if patient have a ovarian cyst, and they because of the impact on the progesterone and estrogen level. Okay, so we have to take care of these such cases, like if a patient is young age patient and your patient is not getting relief, you may have a history. A patient may have a history of multiple cysts, PCODs. So this is the pictures we must have been seen in first years, the muscle contractions, and this is about the muscle contractions. The calcium is required, actin myosins, and then there will be contraction. Next. Now during relaxation there is ATP is required. Okay, ATP is required. So why I am keeping this picture? If because of the microtrauma or macrotrauma, sustained contraction, if muscles doesn't get this ATP, there will be a over-contracted band, and that will lead to a myofascial pain dysfunction syndrome. Next. Okay, next. Remove that, no problem. Okay, so there can be a myofascial pain because muscular fatigue, overextension, and this all will have these features like derangement, degenerative arthritis. So this is a complete cycle, vicious cycle. Okay, so muscle pain can have this occlusal disharmony, altered chewing function, and then it causes myofascial pain. So all the TMDs can relate in myofascial pain dysfunction. So whenever patient comes with myofascial pain, please check for the TMDs as well. Next. So lesson criteria you must have been seen that there will be pain, muscle tenderness, clicking, popping sound, limitation jaw movement, or there will be negative sign that means there will not be any clinical or radiological features. Next. So there will be positive jump sign, that means when you palpate the trigger point, patient will jump up. Next. So you should be able to differentiate between trigger points versus trigger zone. Trigger zone is seen in trigeminal neuralgia, that when you apply the light pressure, patient have a electric pain. That is for trigger zone. But trigger point you have to palpate. Okay. Next. So how you have to palpate trigger points? So this is a trigger point, and try to have a bidigital palpation. Okay. And then only you can able to palpate. Next. Patient have a referring pattern as well. Like what patient is complaining is pain in the third molar area, and you are checking about the third molar area or second molar area, everything is normal. Okay, there is no radiological clinical findings, still patient have pain in the second molar. And when you try to palpate on the muscles, now patient have pain in the tooth. Okay, and even in the same in the muscles as well. So the same muscles pain is referring onto the tooth. So that's called as referring pattern. So each and every muscles will have a referring pattern. Okay, so these are the referring pattern for the temporalis muscles, like anterior temporalis in the anterior tooth, middle temporalis in the premolars, and posterior will have on the molars. Next, so like masseter muscles will also have a referring patterns. Next, so why referring pattern is important is, so whenever a patient will be having complaint of odontogenic pain, if you are not able to see any odontogenic cause, check for the muscular pain as well. Next, so these are so this is the source of pain. Why there is a referring pattern? So when the source of pain and the site of pain, both fibers converge in the one area, that's called as theory of convergence, and they have this convergence. So they V1, V2 and the cervical nerves, they have a convergence in the pons, and they will be perception of the pain. So if there is a pain in the for example in the forehead area, they can be referring to the tooth or the vice versa as well. Next. So when you press onto the source of pain, patient will have a pain. Next. But if you have a local anesthetic on the site of pain, patient may not have a relief of that pain. मान लीजिए कि अगर मसल पेन है, आप आप उसको लोकल इंजेक्शन दे रहे हैं, INV दे रहे हैं, but patient still बोल रहा है कि वो पेन नहीं उसका रिलीफ हो रहा है. So that means you are palpating a wrong site. But if you give a local anesthetic onto the site, onto the source of pain, patient will have a relaxation of pain. So other associated features also you should know. Next. So how to diagnose this case when there is no radiological or investigatory findings? So the thing is proper history. So what I told you, 60% is the history part. We have to take. Okay. Take proper history of the stress, sleep disturbances, and rule out the other causes of orofacial pain, including odontogenic pain. Okay, soft and feel. So this is soft and feel, which I showed you in the last video.
Cut sound है
Cut sound. So the click sound is there. That is a feature of one of the listening criteria.
Cut sound है
So patient is able to open mouth, but with pain. Next. So now this is the hard and feel. Just open the similar restricted mouth opening and applying pressure how much ever I can.
यहाँ पे दर्द होता है ना, मुंह खोलने में यहाँ दर्द होता है ना, मुंह इतना ही खुल रहा है बस, क्या करो, डबल 20 mm खुल रहा है ना। अच्छा पहले कटकट साउंड आता था तुमको, हैं? कटकट साउंड आ रहा था, अभी कटकट साउंड आना बंद हो गया। कितने दिन से कटकट साउंड आता था? 6 महीने से। अब ये कितने दिन से बंद हो गया कटकट साउंड आना और दर्द स्टार्ट हो गया? 6 महीने से।
So what do you mean cut sound is clicking? Patient have a history of clicking. That means that time it was the internal displacement with reduction. Now it has converted to internal displacement without reduction. That's why now patient doesn't have any click sound because there is the complete restriction of mouth. Okay? Next. So how there is another things, you can have a tongue plate and you can ask patient to bite. If muscles is the causative agent, patient will have a pain. Okay? But if it's a TMJ pain, patient will have a relaxation of the pain. So next, I won't go in the detail because on time limits. नीचे पीछे आओ तुम जितनी जल्दी बच जाओ, हाँ ऊपर आओ, हाँ. So this is advanced diagnostic now. Scan, T scan, jaw trackers, these all features are there. Like if you see in the market, no, these are all now it's grown up. Next. So how to treat the case? First, eliminate any etiologies. Okay. Any systemic factors, elimination of stress, and any sleep disturbances, any trigger point. Next. So these are the muscle relaxants. It's there in the book. Next. So you can apply Morse sheet application. The main mechanism of applying Morse sheet is you are actually giving the vasodilatation so that ATP should be provided in the area of trigger points. Okay. Next. Cold therapy will have a relaxation of the muscles. Next. Spray and stretch you can use. You can have a cold spray and then passively you can stretch the muscles. Next. Ultrasound, low level ultrasound therapies is also vasodilator activities. Next. Trigger point injections. You can give an injection on the trigger points. Okay. And if you give a trigger point, you are giving a mechanical injuries. If you are providing mechanical injury, there will be inflammation, there will be production of ATP, and that will be relaxed. Next. Okay, next. So you can have an injection on the masseter muscles. You have to first just palpate the muscles, and then you give any trigger point injections. You can have a local anesthetic. Next. वीडियो एक है, हाँ वीडियो तो क्लिक करो. पेशेंट को फर्स्ट पैल्पेट कर रहे हैं. वी आर पैल्पेटिंग द ट्रिगर पॉइंट. वी आर मार्किंग इट. Correct diagnosis is you have to properly check the trigger point. If you are landing on the wrong area and giving injection, then patient will not have relaxation. So I am checking all the areas. I am seeing the junk sign. अभी इनॉग्रेशन होगा नहीं, 5 minutes. Next. next. So TENS therapy is also available. If you apply TENS therapy, TENS patient will have a relaxation. So how TENS work? It works on the principle of gait control. Next. Okay, then low level therapies. You can have a low level therapies and that also have a vascular activities. Next. Finish. Okay. First question. Next. So whoever gives they will see the answer. A 41-year-old salesman come to a dental clinic complaining of right masseter and have shortly after the amalgam restoration. So what will be the diagnosis? A high point. Then because of the high point is correct. Then what will be the diagnosis? It was a protective co-contraction. Next. 19-year-old female college discussing the problems. He have revealed that this type of pain have been increased 3 other occasions, like 2, 6, 8 months, and no noticeable changes in the occlusions. And there was the pain was nearly the episode of her college examination. That means the stress examination. The stress is also can be a positive agent here. Clinical examination revealed general tenderness, not the trigger point. Trigger point was not there. And there was no other clinical findings during the clinical or radiological. There was no trigger point. Okay, next. So it's a local malady because of the emotional stress. Next. So 30-year. चलो ओके छोड़ दो अभी सब लोग जल्दी जाना चाहते हो. क्लोज. थैंक यू. सब लोग को जल्दी है जाने का. No problem. So have you taken any single point related to muscles? Okay, the important thing is the correct the history part, take proper history, okay, and then do a proper diagnosis. That is more important.
We are waiting for the inauguration ceremony to start. As ma'am and sir are here, we would like to felicitate the speakers. And I would like to invite Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir to come forward and felicitate the speakers. The first speaker would be Dr. Pulkit sir. Thank you sir, the lecture was very interesting and informative. Please give a round of applause for sir once again. Appreciation for the lecture. Next, we would like to felicitate Dr. Piyush Shivhare sir, who just now gave the lecture. Thank you sir for the lecture. It was indeed an informative one. Please give a round of applause for sir. Next, we would like to felicitate Dr. Ajay Thakur sir. We are about to begin with the award ceremony. A little introduction of our award ceremony. Along with academics, there is a need of appreciation, acknowledgement, and that is why this evening is all about fun and appreciation. And for acknowledgement, we have initiated with Dentist Awards organized in order to recognize and honor respected and the associated people of dental fraternity, and this ceremony is initiated and organized by none other than Cynodent International and Indian Society of Dentistry.
Today, we have gathered here to honor the exemplary and the very inspirational personalities of our dental fraternity. who work day in and day out at very ground level and have done some amazing work in the field. It is a proud moment not only for them but for all of us who are present here as well, because these are people taking a fraternity and profession forward and contributing in its excellence and beyond and uplifting our honorable profession of dentistry. As it is said, appreciation can change a day, even change a life. But your willingness to put it into words is all that's necessary.
This award show is Cynodent's small initiative to acknowledge and honor the hard-working dental fraternity on the whole. We have various categories nominating dental students, clinicians, academicians, and of course the foundation stone of every dentist education, the dental colleges of India. So let's start with our award ceremony, and for that I would like to request our respected dignitaries to come forward for felicitation of our awardees. I would request our chief guest, Dr. Surendra Kashyap sir, our guest of honor, Shri Sohan Lal Thakur sir, Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir to please come forward for presenting the award. And along with sir and ma'am, I would request Principal sir, Dr. Baljit Singh sir and Dr. Devendra Sharma sir, Vice Principal sir, to please come forward. Thank you sir and ma'am. Now we are going to start with the awards. First is the award for Oral Surgeon of the Year, and it goes to Dr. Divya Malhotra sir. Oral Surgeon of the Year. Please continue with the round of applause for the award ceremony throughout. You have worked day in and day out to reach here. Next is the best dental college in community service, and it goes to none other than Himachal Dental College, Sundargarh. The best dental college in community service, and the award goes to Himachal Dental College, Sundargarh. I would request Dr. Sahil Thakur to join. Dr. Anil Singla sir. I would request Dr. Anil Singla sir to please join and to collect the award on the behalf of Himachal Dental College, Sundargarh. Please give a round of applause. Next is the category of PG Student of the Year in the Department of Public Health and Dentistry, and the award goes to Dr. Ruchi Verma. Dr. Ruchi Verma, the PG Student of the Year from the Department of PhD. If anyone could collect the award on her behalf. Outstanding Passionate Dentist of the Year. The category for the Outstanding Passionate Dentist of the Year, and the award goes to Dr. Vikas Jindal sir. I would request the judges to please give a round of applause for sir. Thanks to sir and the respected dignitaries. Dr. Ritesh Sharma. Dr. Ritesh Sharma, Dental Talent of the Year. Dental Talent of the Year from Himachal Dental College, Sundargarh, Dr. Ritesh Sharma. The award for the Author of the Year goes to Dr. Piyush Shivare sir. Author of the Year, Dr. Piyush Shivare a renowned author and has authored the famous textbook of oral medicine and radiology. It's a great pleasure to have her on stage with us. Next is Budding Oral Medicine and Radiologist of the Year, and the award goes to Dr. Ajay Kumar sir. The Budding Oral Medicine and Radiologist of the Year, Dr. Ajay Kumar sir. Please give a round of applause for sir. Thank you, sir. Next is the emerging researcher in the field of endodontics, and the award goes to Dr. Shweta Verma ma'am. Emerging researcher in the field of endodontics, Dr. Shweta Verma ma'am from Himachal Dental College, Singapore. Next is the award for Emerging Public Health Dentist of the Year, and the award goes to Dr. Sahil Thakkar sir from Himachal Dental College, Singapore. Next is the Emerging Pedodontist of the Year, and the award goes to Dr. Vasundhara Pathania ma'am. The Emerging Pedodontist of the Year, Dr. Vasundhara Pathania ma'am from Himachal Dental College, Sundarnagar. Please give a round of applause for ma'am. Next is the award for UG Student of the Year. The Student of the Year in undergraduate category goes to Dr. Sahibli Kaur. UG Student of the Year goes to Dr. Sahibli Kaur. The Student of the Year in the PG category goes to Dr. Akash Sikka from the Department of The award for the PG Student of the Year goes to Dr. Akash Sikka from the Department of Prosthodontics. Next is the Student of the Year in the undergraduate category. Again, it goes to Swati Chaudhary from BDS 4th year. Student of the Year undergraduate category goes to Swati Chaudhary from BDS 4th year. Next and the last one is the Prosthodontist of the Year, and the award goes to Dr. Archana Nagpal ma'am. The award for the category of Prosthodontist of the Year goes to Dr. Archana Nagpal ma'am. Thank you once again all the respected dignitaries and dear delegates. I would request the respected dignitaries to please take your respective seats on the dais. I would rather call upon our organizing chairperson and president of Indian Society of Dentistry and Cynodent International, Dr. Anmol Bagaria ma'am, to please come on stage for the vote of thanks.
Very good evening, everyone. Once again, I welcome you all to the inauguration ceremony of the 3rd World Dental Sciences and Facial Aesthetic Conference. Firstly, I would like to thank God for blessing all of us with His choicest blessings. And thanks to my mom and dad for their constant support. My mom is present here. I would like to thank and extend my heartfelt gratitude to our Honorable Chief Guest, respected Professor Dr. Cynodent International, Vice Chancellor at Medical and Research University, and our guest of honor, Shri Suhanlal Thakurji, former member of Legislative Assembly, Sundarnagar.
Thank you, sir, for gracing the occasion and giving us your valuable time this evening. I would like to thank our patrons, advisory board members, Dr. Stephen Cohen, sir, Dr. James Gutmann, sir, Dr. Pavitra Rastogi, sir, Dr. T.N. Kapoor, sir, for their constant support and blessings. I would like to thank all the dignitaries on the dais, off the dais, all the heads of departments, faculty members, and all the dear delegates who have joined the conference. Thanks to all the speakers and mentors who have given us their valuable time in enhancing the knowledge and skills of our delegates. A big thanks to all my dear delegates and students who have trusted us and joined us today. Thanks to all the speakers and clinicians who have joined us to enhance the knowledge and skills of the budding dentists. I would like to thank the organizing committee of Cynodent and SDC for their constant support in making this conference a grand success. I would extend my thanks to Dr. Ashish Chandra for tremendous support in making this event a grand success. Sorry if I have missed any names, but I am highly thankful to one and all. Thanks to all once again for being there with us and giving us your valuable time this evening. Have a great evening and a happy conference ahead. Thank you.
Ma'am, we request you to kindly rise for the national anthem. I will request the IT team to kindly play the national anthem.
पंजाब सिंध गुजरात मराठा द्राविड़ उत्तर बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगल नायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Warm greetings to all the ones present here again. I, Dr. your Master of Ceremony for the conference, on behalf of Team Cynodent International and Indian Society of Dentistry, once again welcome all our respected dignitaries, all our eminent speakers, and our dear physical and digital delegates to the 3rd World Dental and Facial Aesthetics Conference from 3rd to 5th November at Himachal Dental College, Cynodent. Today marks the last day of our conference. On 3rd November, we had the pre-conference courses, where 3 pre-conference courses were conducted. 4th November, that was yesterday, we started with the keynote lectures, offline and digital scientific paper and poster presentations, table clinics, and in the evening, we had the awards night, the cultural musical night that ended with the DJ night. And finally, on 5th of November, that is today, we had keynote lectures, and now we are going to have the much awaited result disclosure ceremony in the valedictory function. So without further ado, we will start with the valedictory function. And for that, I would like to invite our respected dignitaries on the stage, Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir, respected Vice Principal Sir, Dr. Devendra Sharma Sir. We would like to felicitate Dr. Shweta Verma ma'am, Dr. Pavitra ma'am, Dr. Chandra ma'am. I would request you to please come one by one on stage. Dr. Shweta Verma ma'am. Dr. Vijay. Dr. Vijay. volunteers. Ritik Sharma, Harshit Sharma, Tanish Sood, Yatish Malik, Tanish, Ankit Raj, Ankit Padman, Cohen, Karthik, Prashant, Harsh, Naman, Sohil Degi, Arnav, Amandeep Kaur, Vanshika Tam, Swati Rana, Rudransh, Ankit Palnai, Vaidhi, Mridul Rana, Umar Farooq Bhatt, Dr. Ashwini, Bharat, Akash. I would request you all to please form a queue and come on stage one by one. Please come in a group of 2. Dr. Shiva Chauhan ma'am, Dr. Abhinav sir. After the volunteer felicitation, I will call you on stage again ma'am.
पहुंच दी है
Dr. Angita ma'am, this was it, so we'll move on to the next category. The result of paper and poster presentation. If anyone's name was missed, please come forward. Or if anyone wasn't present at that time and is here right now, they can come forward right now. Okay, so as no one is there, we'll proceed. The result of paper and scientific paper and poster presentation. So for paper presentation, the winners of slot 1, that is the first prize, goes to Dr. Amana Dhillon and Dr. Alper Sood. First prize paper presentation from slot 1. The second prize goes to Dr. Neha and Dr. Shikha Sharma. Short paper presentation results. Second prize goes to Dr. Neha and Dr. Shikha Sharma. And the third prize goes to Dr. Nandini Mahajan, Dr. Amit and Dr. Sushil Rastogi.
Please.
From slot 2, first prize goes to Dr. Omar, second prize goes to Dr. Sakshi, and third prize goes to Dr. Alvin, Dr. Ayman, and Dr. Akshay, and Dr. Neeraj Sharma as well. First prize goes to Dr. Omar from slot 2. Then second prize goes to Dr. Sakshi. Third prize goes to Dr. Balkaran, Dr. Neeraj, Dr. Ayman and Dr. Akshay. Slot 3 we have the first prize goes to Dr. Pankaj. From slot 3, the first prize goes to Dr. Pankaj, Dr. Indu, Dr. Kajal and Dr. Sona. The second prize goes to Dr. Vikrant, Dr. Shilpa and Dr. Shilpa. Third prize goes to Dr. Bagaria and Dr. Javed. These were the winners of paper presentation from slot 3. Second prize, Dr. Vikrant, Dr. Siddhant and Dr. Shilpa. Third prize, Dr. Bagaria and Dr. Javed. From slot 4, the first prize goes to Dr. Stuti and Dr. Pavit. Dr. Stuti and Dr. Pavit. The second prize goes to Dr. Srishti and Dr. Alina. The third prize goes to Dr. Arushi and Swati.
जी प्लीज. Yes.
Now after paper presentation, poster presentation from slot 1, the first prize goes to Vidushi Verma, Swati Chaudhary, Arushi Gupta and Ritik. The second prize goes to Vishakha Dhiman, Sonali, and Prishita. The third prize goes to Amrita, Harmehel, and Ankit. So this was the poster presentation slot 1 winners. First prize Vidushi Verma, Swati, Arushi, Ritik. Second prize goes to Vishakha, Sonali, and Prishita. Third prize goes to Ankita, Harmehel, and Ankit. Please give them a huge round. Now from slot 2, poster presentation. Slot 2, poster presentation winners. The first prize goes to Dr. Prakriti Sharma. The second prize goes to Dr. Umesh. And the third prize goes to Dr. Sushita Thakur. First prize Dr. Prakriti, second Dr. Umesh, and third Dr. Sushita.
Yes.
Now, from slot 3, first prize goes to Dr. Ravi, Dr. Tanya. Second prize goes to Dr. Ashwina. And third prize goes to Dr. Jivanju and Dr. Ankush. Slot 3, poster presentation. First prize goes to Dr. Ravi and Dr. Tanya. The second prize goes to Dr. Ashwaya. And the third prize goes to Dr. Jivanju and Dr. Ankush. Now, the scientific poster presentation winners from slot 4. The first prize goes to Dr. Akansha, Dr. Nipun, and Dr. Rakshita. The second prize goes to Dr. Shreya and Dr. Tanya. And the third prize goes to Dr. Sonam and Dr. Rasa. Slot 4, poster presentation winner. First prize Dr. Akansha, Dr. Nipun, Dr. Vanshika. The second prize goes to Dr. Shreya
Yes, please.
and Dr. Tanya. The third prize goes to Dr. Sonam and Dr. Rasa. Congratulations to all the winners. Now after paper and poster presentation, we'll move on to the winners of table clearing. And the first prize goes to the winners of the table clearing. The first prize goes to Dr. Shobita, Dr. Ashwini, Dr. Yanma, and Dr. Shekha. The second prize goes to Dr. Kajal, Dr. Harmandeep, Dr. Sonam, and Dr. Tanya. Please give all the winners a
Yes, please.
Second prize, Dr. Kajal, Dr. Harmandeep, Dr. Sonam, and Dr. Kajal.
Haji, please.
Now we move on to the scientific committee called the MOD. Dr. Munish Goyal sir, Dr. Vijay Kumar sir, Dr. Shweta Verma, ma'am, Dr. Neeraj Sharma sir, Dr. Komal Rai sir, and Dr. Shilpa ma'am. Dr. Munish Goyal sir, Dr. Vijay Kumar sir, Dr. Shweta Verma ma'am.
Very big round of applause for them.
Dr. Munish Goyal sir, Dr. Vijay Kumar sir, Dr. Shweta Verma ma'am, Dr. Neeraj Sharma sir, Dr. Komal Rai sir, and Dr. Shilpa ma'am. Scientific committee calls the MOD.
जी प्लीज थोड़ा सा आगे
Now, the PG students, Dr. Balkaran Singh, Dr. Jagriti, Dr. Vikrant Thakur, Dr. Sidhant, Dr. Michelle, Dr. Ashwini, Dr. Yango, I would like to recall the names again. Dr. Balkaran Singh, Dr. Jagriti, Dr. Vikrant Thakur, Dr. Sidhant, Dr. Michelle, Dr. Ashwini, Dr. Yango, Dr. Diksha, Dr. Shobita, Dr. Shreya, Dr. Suchita, Dr. Akriti, Dr. Vidisha, Dr. Sunena, Dr. Prakriti, and Dr. Ume. The PG students from Scientific Committee.
Again.
For the cultural events, the much awaited result, the first prize goes to the Bhangra group. First prize goes to the Bhangra group. I will request all the participants to please come on stage and collect your prize. For the cultural events, the first prize has been backed by the Bhangra group. I request you all to please give them a huge round of applause. It was an amazing performance. The second prize team. The second prize has been backed by the fashion show team. It was a wonderful show and we all enjoyed it. Congratulations to all the participants.
Yes, please.
The third prize has been bagged by Nati. The Nati team. I would request the participants to please come on stage. Please give them a huge round of applause.
Yes.
Once again, congratulations to all the winners. This sums up the valedictory function. I would request the respected dignitaries to please kindly take their seats.
Haji, please, sir.
Dr. Gitanjali ma'am, Dr. Savita ma'am and Dr. Rohit. Dr. Rohit sir. Our cameraman.
कोई बात नहीं.
We would also like to thank them and our media partners. I would like to thank the team from HTC whose support made this conference possible. Thank you so much each and everyone. Thank you. I would like to thank to please proceed for lunch. This was the end of our valedictory function. Thank you very much. The time for the cultural program night. The Himalayan Cultural Night by Cynodent International and Indian Society of Dentistry in collaboration with Himachal Dental College, Cynodent. And for that, I would like to call upon Reddy to take over the podium and continue with the cultural events for the evening. We will wait for another 5 5 minutes and request the stage team to set up the stage.
Well, it must be high now. I promise there won't be anything sweet or poetic, just fire and fire. Devbhoomi means God's land. Himachal Pradesh is blessed with abundance of all forms. Imagine how grand the celebrations and folks must be. Our folk dance Nati is as beautiful as our lush sceneries. May I please present to you our very own folk dance, Pahari Nati. Let's add more music and less drama and a dash of sass to this evening. Moving ahead, our upcoming performance is a novel idea of representation, a Gen Z way of expressing and addressing issues that are deeply rooted in our society. With a perfect blend of fact and fashion, give a big round of applause for the thematic show, the fashion show, and for the theme of it, well, I'll let you guess for this one.
Bring it back like she loves some. In the club with the lights on, but you like the shot bar. Come and show me that you're with it.
body. It was indeed a very messageful performance. Upcoming, we have our very own group of music band. They call themselves Stamp B with their spellbound vocals. May I please call upon stage Stamp B. boundaries and embracing the beauty of cultural aliveness. Dancing is more than just moving to music. We'll take a break of 5 minutes. Bollywood and Bharatanatyam. Please give a huge round of applause to the team. Come on guys, you can do that. tired of all these performances, but trust me, the bucket of talent of HDC never goes out before. Moving ahead, we have semi-classical dance performance. Semi-classical dance represents a harmonious fusion of classical and contemporary dance forms, preserving the traditional essence while embracing modern nuances. Please put your hands together for this performance. आप जानते हैं कि हम HDC हैं, हमारी काम हमारी पूजा है और पार्टी हमारा घर। इसलिए बारी मर्सन खटर, पार्टी में पंजाबी, मैं हार्डकोर हिमाचली हूँ बटाई का। बारी मर्सी खटर गया, खट के ले आंदा गिटार। बारी मर्सी खटर गया, खट के ले आंदा गिटार। पंगड़ा ता सजदा जे नचे HTC दे स्टार। You know what it's time for. आ जाओ कहे, शुरू करिए पंजाबी पंगड़ा।
Thank you.